complication which you face is desaturation in the intraoperative period. So for our surgeons, at that moment we need their help and support. So when if needed, we can ask them to just hold on for a while, and we'll do our things and improve the saturation, and they can proceed. So this is the only thing we anticipate from our surgeons, and we are getting such type of support in our OTs also. So just during desaturation, just for a while, we can ask them to just hold on, and we'll do the things and then start. Now, sir, Dr. Saurabh has did the intubation. Now, I will hand over the mic to Saurabh.
On कर दो माइक को. फाइबर ऑप्टिक से डायरेक्ट करेंगे तुमसे. Okay, so good morning everyone. As we can see, this is a 32-year-old female we have anesthetized, and after standard induction, general anesthesia induction, we have put in a 35 French left-sided DLT. So, as we can see, there is a ETCO2 graph and DLT is in place, vitals are stable. So what I'll do is, as a standard practice, I've fixed the DLT, I've inflated the tracheal cuff. So I'll do a bronchoscopy through the tracheal lumen and see the position of the DLT. I'll confirm the DLT position, and then I'll go on with the bronchoscopy to show you the lesion. Section ready, please. Can
you tell that it's a pediatric bronchoscope or it's a not?
Table fill down, please. Yes, it is a pediatric bronchoscope. 35 French DLT accommodates only a pediatric bronchoscope. So this is a pediatric bronchoscope we are using. I'm going through the tracheal lumen. Still in the tube. Jelly. Gauze piece there. Yeah, we can see the blue colored cuff, the bronchial cuff is just outside. So I'll have to push it a little in. This is the trachea, this is the tube. So fixation remove karo, deflate karo, and push it inside. Tracheal deflated lung, inflate, push it in, push the tube in, push in.
So, Dr. Anuja, there are two techniques of putting the DLT. Either we can put a blind
wait.
Check with fiber optic bronchoscope, or once we enter, once we cross the practice,
थोड़ा सा पीछे करो.
that moment we can
बस थोड़ा सा
either in the traction.
Okay, so this is the carina, and this is the left bronchus. This is the blue colored bronchial lumen. So tube is in the left brainstem bronchus now. Please inflate the bronchial lumen, 1 ml of air. So we can see the edge of the bronchial cuff just at the carina. So my tube is adequately positioned. So I'll go ahead and I'll go in to the right side. Tube fix हो गया, tracheal inflated. Bronchial deflate कर दीजिए. ठीक. यहाँ पे गैस पीसेस दे दो मुझे. So this is the right side. This is the right middle lobe and the lower lobe takeoff. I think this must be the mass which is protruding. Upper lobe takeoff नहीं दिखा ना, but वो mass ही आ रहा है. This is the right brainstem bronchus lumen is narrowed. I think this on the right hand of your screen. This should be the mass. We can go in other bronchial segments. This is the tertiary carina. Other bronchial segments are okay. Surgical team, no, see. Yeah, right upper we cannot see.
Go back to see the base. Yeah, I want to see the implantation here. Can you show me that of the tumor?
Base of the mass, okay.
Yeah, I want to see the mass upper, yeah, all around. Okay, go back. Okay. Okay. Thank you. Take a photo. Take a photo of the tumor.
Video on it, uska.
Hello. Is it audible, sir?
Shall I come out?
Yes. Okay. Yeah, the tumor is in the right knee, it's extending to the right upper lobe. So I think we need the right upper lobectomy. We will see. The knee is free, right knee is almost.
Right main is just obliterated. I'll go.
Yeah, right
Yes. Yeah.
Right lobe is okay, yeah.
Yeah.
It's just right upper lobe extending to the right knee. In this case, sometimes we can do just a spiral line. I don't know how long it extends into the right knee, into the right upper. We can check and see. But sometimes from the CT is protrusion. We don't know the origin.
Tube double fix करो. Tube double fix करो. मैं थोड़ा 0.7 तक लिया. प्रतीक को बोलो epidural infusion शुरू करो. Epidural infusion शुरू करो. BP at 5 minutes. प्रतीक को बोलो.
Is there because of consolidation. But extent how far it is, looks like a narrow stop kind of thing. But we are not sure about because we are not able to negotiate the right upper lobe lumen per se.
All we can do one thing is. First step for surgeons.
I can prepare everything for second carina.
So that they
Cut and see.
the first and
If you see the mapping is compromised,
Then
we
we just convert into right upper lobectomy and then standard state.
You see yourself and then you realize that what problem or wrong.
we cannot take the upper lobe.
That's I mean the more practical option will be for.
The easiest thing will be right upper lobe. But sometimes the tumor is just protrusion to the right upper. So
Small start with the. They are doing the reduction so that you will have a first while this is according to the first step for a successful improv period course.
Madam, for the sake of the delegates, can you let us know between the different isolation techniques with the normal anatomy, what does the anesthetist prefers to do and why? which technique they prefer and what's the reason for that?
Okay, so in a normal anatomy, our first preference would be a left-sided DLT. The reason it should be left and not right is because if the bronchial lumen enters, if you take a right-sided DLT, and the bronchial lumen will enter the right main stem bronchus, because of the early takeoff of the right upper lobe, the bronchial lumen itself could end up blocking the right upper lobe. So that is why we prefer left-sided DLT, even if it is a left-sided surgery, unless there is a left pneumonectomy planned or a left mainstem bronchus where you are actually going to manipulate the mainstem, left mainstem bronchus. So the first preference would be a left-sided DLT. The next, of course, would be a right-sided DLT. Why we prefer DLT over bronchial blockers is because ventilation and isolation is better. Intraoperatively, the displacement of a DLT is less frequent than a bronchial blocker. Sometimes what happens if you're using a blocker and the side in which you have put the blocker, sometimes it because the blocker is blocked, it's difficult to suction mucus. All these things are possible with a DLT because they have a wider room. Now the next, of course, if the anatomy, upper airway anatomy is also a concern for the anesthetist. Like we already mentioned, that if it is a difficult airway, or suppose, very frequently in onco practice, because these patients are smokers and tobacco chewers, sometimes, they might have been operated for a head and neck mass. So if the upper airway anatomy is disturbed or distorted, we will have to secure the airway, and it will be very difficult to secure a DLT in such a case. So in those cases, we'll first put a normal endotracheal tube, single lumen tube, and then put a bronchial blocker to secure a one lung ventilation. So again, I would say that my first preference is a double lumen tube, left more than right, and then would be a single lumen tube along with a bronchial blocker. So like we just saw, the ideal placement when we go through a tracheal lumen, the ideal placement would be that the side which is blocked, you are able to see the cuff only after inflation. If you are seeing the cuff without inflation also, that means that the cuff is herniated. It's herniated, or I would say it's still in the mainstem trachea. So that you will have to push in the tube just by a few millimeters. Under vision you can do it, and then it should be just inside the mainstem bronchus of whichever side DLT you have put. And once you inflate the cuff, you are able to see a lining of the blue cuff. So that was the ideal placement. Dr. Sachidanand, sir, if you can hear, could you also show us a view from the bronchial lumen of the DLT, and we could have a discussion over that. Okay, so when this was the tracheal lumen side, we put a fiber optic scope through the tracheal lumen to see the placement of the DLT, and we saw that. Now, the next step would be to make sure we actually go for the bronchial lumen also. Why we do that is that once you enter the bronchial lumen, you want to see that both the secondary bronchi, whether they are not obstructed. This is especially more important when you are because you want to make sure that the right upper lobe is not blocked by the. Once you put a fiber optic scope through the bronchial lumen, you will see all the that's as far as the anesthetist wants to see. They just want to see that the secondary bronchi are not blocked. Suppose if they are blocked, what is the next step? That means that probably your size of DLT is wrong. It could be bigger, and that is why the bronchial stem of the tube is longer and it is obstructing one of the lumens.
Dr. Anuja. Dr. Anuja.
Yes, sir.
Yeah, now we are proceeding for fibroscopy of the bronchial lumen. So, so we are in the bronchial lumen. So, we are going in, right? First, we'll try to see the bluish hue from the inside of tube, the bronchial cuff. Then we'll try to see from the distal lumen of tip, the opening of right and left. So as
This is the tip of the tube. You can see the carina bang in front of you. And this on the left side of the screen, you can see the bronchial lumen there. Bronchial cuff is nicely sitting inside. Huh? Bronchial, I'll do the fiber optic from the bronchial side now and go into the left main stem, left main bronchus. So I'm going to the bronchial side. So this is the blue bronchial cuff you can see. We'll just go through the cuff. This is the remaining part of the left mainstem bronchus. After this, we'd see the secondary left carina. We go into this side. There's a left tertiary carina and left lower lobe, 3 openings. And we go to the upper side, left middle lobe. Left upper lobe.
we are in the left upper lobe. So anatomically, the left upper lobe is on the left side.
2 openings of the left upper lobe. These 2 openings. This is the tertiary carina, and these are the quaternary carina here. When we go more inside. This is the main secondary carina. We'll go inside. The scope negotiation becomes a little difficult here. These are the tertiary carina here. So gradually I'll come out. Is it okay?
Yeah. So now we are done with the bronchoscopy of the left side. Now we'll position the patient and start the surgery.
Raju, would you like to add something?
I want to ask the lady, suddenly once the isolated and we start the procedure and suddenly the anesthetist wants her, they're desaturating. What are the causes and what are the interventions the anesthetist takes up at that stage?
So, like you all know, the anesthetist is survive on 100% oxygen. Our first response is to increase the oxygen to 100%, and while we look for other causes. So that's our first reflex. Once the patient starts desaturating, our first reflex is to increase the oxygen to 100%. So as far as possible, we'll increase the oxygen, and the next steps would be depending on the causes. Like so, the causes could be that the patient is, the preoperatively patient's lung reserve or the cardiopulmonary reserve was less. All these causes could be there, but then after lung isolation, during this, that would manifest right after blocking the tube before the surgery starts. Before the surgery is happening, it's probably that there is a mucus plug. That is one of the most common causes, that there is a mucus plug in the ventilated side. So the next step would be you could do suction and remove mucus, and that would help in better ventilation. The next step would be to increase the PEEP levels. So we'll increase the PEEP to 10 so that the lung, the alveoli, they stay recruited and ventilated. And then there are other maneuvers. We'll start ventilating the collapsed lung. So, but that interferes in your surgery. So what we do is we just attach an oxygen with some PEEP. That means we are giving oxygen with some pressure, but there is no ventilation. There is no collapse, inspiration or expiration cycles. The patient is still, that part of the lung is still apneic, but we are providing oxygen and we put a CPAP there through a socket or through a different ventilator. So a CPAP of 5 to 6 centimeters of water we can apply to the non-ventilated lung. Then apart from that, if you have tried all maneuvers, the next step would be we ask the surgeon if we could, during certain steps in which you are comfortable, we could intermittently ventilate both the lungs, bring the saturation back up. Another thing would be that we start doing a low tidal volume ventilation, which does not interfere with your surgery. So whatever you're comfortable with. That usually is more appropriate in an esophageal surgery compared to lung surgery. So a low tidal volume ventilation. So instead of giving a 500 ml to one lung, we'll probably go down to 200 to 250 ml of tidal volume to both the lungs. So, and then increase the rate of the frequency of respiration. So these are the maneuvers. And if the patient is posted for pneumonectomy, our last resort would be to tell you to clamp the pulmonary artery as soon as possible. Because then once one side of pulmonary artery, the pulmonary artery is clamped on that side, the ventilation perfusion ratio is no more an issue. Then you have a 100% PQ match. So those are the things these are the steps we take.
That's one of the common problems that we face. And the shunting that occurs is more often seen with the right side as compared to the left because the volume that it has to cater is much higher.
Dr. Naveen, Dr. Sunil? Anybody on the OT side?
Yes, sir. Yes, sir.
We are not able to see anything on the screen. Can you just show us what you are doing in the OT position?
So just we are doing the positioning.
Please show us.
Yes. Yes. I can focus the screen. Cameraman, you can just focus the
Yeah.
positioning.
Show you the room. Yes. Thank you.
Yes.
Just somebody can read, maybe you, Dr. Sunil or Diego. What you're planning, the surgical plan, maybe you can read.
Yeah, so monsters. Yeah, so we are just doing the positioning. In the meantime, Dr. Diego will explain, we went through the CT scan and finally we have decided for, it will be right upper lobectomy and joining the intermedius bronchus with right main bronchus, that is right upper lobe sleeve. And I'll hand over the mic to Dr. Diego for the further plans, surgical plan.
Well, we were checking the CT scan and the only choice is right upper lobectomy. Yes, so the only plan is to do a right upper lobectomy. And because the tumor is extending to the right upper lobe, on the CT scan, there is a small mass. So there's no choice for a sparring lung resection, okay? The tumor is here. So we have to do right upper lobectomy.
Diego, can you show us again, please? We just got the screen shot. Right?
Yes, because we were checking the bronchoscopy, trying to see the possibility of sparring lung surgery, second coronal reconstruction, but it's not possible because the tumor is extending into the right upper here, you see, right upper lobe mass and here. So there is tumor here that it is impossible to do the second coronal because we will leave tumor in the right upper lobe. So we have to do a right upper lobectomy, okay? So the plan will be cut the right main bronchus here, cut here,
Yes.
cut here, remove the lobe, and do the anastomosis of the right main to the bronchus intermedius.
So you're
Just,
planning upper lobectomy with the screen.
Yes, right upper sleeve lobectomy, basically.
So now we are doing the positioning and we will show you the final position and we will be also explaining what exactly we want from the positioning tricks or so. Manju. Huh? Manju. क्या हो गया? Hello, Dr. Can you hear me?
Yes, yes, Dr. Sunil, please go ahead.
Okay, okay. So they're just doing the positioning part. We are doing basically the idea is that the chest position that should be as much as stretched with the head down and foot down, that the table is in arching position, roughly around 30 degrees or so. I'll just show the picture once like they are done with the
So the basic idea is to
open up the intercostal space. So the maximum is we can get the space. Explain the position.
Hi, good morning. So patient is in left lateral decubitus position. So we are trying to we keep it completely lateral, and as far as anterior possible.
This is Manjunath.
Yes, sir.
Yes, please go ahead.
Can you hear me now?
Yeah, yeah.
Good morning, everyone. So patient is in left lateral decubitus position, and we try to ensure that the position is such that we have maximum expansion of the intercostal space, and at the same time we ensure that the hip is at the lower level compared to the chest, so that when the instrumentation or anything happens, it doesn't hinder the movements. We generally place some axillary padding and one more roll underneath the chest at the level of mid chest.
Your mentor, Dr. Rajendra Prasad is here.
Yes, sir. Morning, sir.
We cannot show you right now.
Okay, one more thing is that when you put the right arm, you should be very careful that you should not be over enthusiastically stretched so much that the patient is having pain up in the post-operative period. That's a kind of a unconscious thing. Normally, we should be very aware about and take a particular note of that. Also, we will be putting the elastic compression on the legs, and then once the patient is positioned, then with the help of final table break, it will further accentuate what we wanted in the form of opening of the intercostal spaces. Now, briefly, we will also introduce to the equipment what we are going to use. So we have 4K vision with the ICG telescope, and 3D also standby mode, but we are going to do it with the 2D. And this is the Olympus system we are working on.
Can you show the system, Dr. Sunil?
Yeah, sure. So that's the kind of a new offer from the Olympus system, that a single platform offering all the three facility in one equipment. And regarding the vision tower, okay.
Anybody from Olympus technical side?
Yeah, so I'll hand over the mic so that they can brief you a little bit about that.
Yeah, very good morning, sir. I am Sanjeev from Olympus. It's a privilege for us to be a part of this conference, sir. And today in this conference, sir, we are going to demonstrate our newly launched platform, that is Visera Elite 3 we called. And the beauty of this platform, it has all the modalities under one, sir. It has a 4K with ICG. Yeah, it has a 4K with ICG, even the 3D in the same platform. And we have 3D available both in this thing, your flexi tip, as in the rigid. So it is with the LED based platform, sir. And the one mode that we have is the yellow enhancement mode. So during the white light surgery, this yellow enhancement helps of the fats and the normal vessels, sir. And this is a new platform. Yeah. So you can see there's a very lightweight. This is an auto-fillable camera head which has been introduced.
Oh, we'll check. Audio, please. Are you able to hear me?
Yes, yes.
Yeah, okay. So I'll hand over again. Sanjeev, who is from Olympus.
Yeah, sir.
So, sir, as I was mentioning about this camera head, these are very lightweight camera heads and autoclavable one. And it has the facility of power focus, power zoom plus one more continuous autofocus mode. Because there has been a challenge because of the high number of pixels in the 4K for the continuous focusing. And to overcome continuous focus mode. So that is a kind of a very unique in this. The moment you press a button, it gets focused, and then throughout the surgery, you need not require the focusing of the image again and again in this. There is a one thing that we have introduced. The other thing which I was mentioning about the yellow enhancement. That's a very it's a standard feature because sometimes particularly in obese patient, and it becomes difficult to identify the vessels and the fats. So this yellow enhancement will help in identification of those. And if the surgery permit, we will definitely request to demonstrate these features among this fraternity, sir. Thank you so much.
Thank you, Sanjeev, so much. So for the energy, we have two choices here. That depends on the Diago, what to use. Can you focus on the, so one is the harmonic Epicon endosurgery from harmonic generator. And we are using the long one, the standard laparoscopic handpiece. And then, no, wait. Second choice is for LigaSure. That's it. Here. Focus here. So the common system providing both the diaphragm as well as the vessel sealing. So we are using this FT10 machine, and both the options are ready as per the surgeon's choice. And for the handpiece, I talked to Dr. Diago, and he said that he will prefer the, yes.
Yeah.
LigaSure. Dono ek sath rakheenge.
What's your screen positions, Dr. Sunil? Can you show the instrumentation position?
Yes, so I'll just ask the camera person to focus in the screen area. Yes, you can focus it from there only.
Dr. Sunil, I think my problem is there. His voice is not clear, and slightly somebody can increase the voice
Volume?
the audio. Right.
Okay, I'll request the team. Just hold on for a second. Audio volume should go. Ah. Is it better now?
No.
Is it better now? No?
No.
No audio, come on. Are you able to hear me? Hello?
Yes, Dr. Sunil.
Yeah, are you able to hear me?
Better, but not very clear.
Okay, we are trying. Just give me a second. Problem है?
We lost the video also.
Hey, यार, क्या करें? Yeah, now the video is going.
Video, no, we don't have the video.
They don't have the video.
Yes, we can see the video of Sunil now.
Okay, thanks. So I hope you can see the instrument trolley, what has been arranged. So one by one, I'll just introduce 3 or 4 instruments, which as per Dr. Diago's choice, that's the workhorse for the entire surgery. The first one is suction cannula. The second one is something which bears his name. That's the Diago reverse dissector. That's a kind of a big right angle instrument, but longer one and very sleek one. And the third one, which is everybody familiar with, is a Jennings snake dissector, snake tip dissector for the vascular isolation. Apart from that, we have certain instruments from the, the entire set is from a Scanlon. Entire set is from Scanlon. And For the energy I was talking about, so LigaSure can show it. So we also prefers and he also prefers the same thing. That's the Maryland jaw LigaSure, which will be connected to the FT10 generator. And then for the harmonic, the standard laparoscopy one, that's the harmonic ACE. That's what. That is for the energy device. And for the telescope, we are going to use 10 mm 30-degree telescope, the standard laparoscopic one. Now I'll shift again, since we have done the positioning, I'll show you the bird's eye view of the position and then hand over the mic again to anesthesia team, because as a matter of policy, we always check after positioning the tube position as well as do the bronchoscopy again. I'll hand over the mic
Audio
to.
needs little louder, please. Audio again.
Okay.
Little low.
Sir, Dave sir,
Yes, Dr.
is it better now?
Yes, better.
Sir, now we have done with the positioning, and now as a part of protocol and policy, and it is also required that once
Zoom out the camera.
So,
Yeah.
so once we are done with the position, so we again have to check the position of DLT, because there are high chances of migration of DLT. So Dr. Saurav will again do the bronchoscopy and check the position.
Before that, we will do the final position check and show you also the final position. Wait.
Camera to focus on the patient.
अच्छा, इसको ठीक. Fine, let's come out.
So
Let's come out.
can you,
So
when you're doing the DLT, following, yeah,
can you show the
when you're doing the
position?
DLT,
No, don't show me.
did the
Final table position.
position of the tube change that much?
It can change, sir. It might not.
So this is the table position.
It can go in deeper or it can come out. So you need to check the position of it.
Because that is one of the advantages of the DLT over the blocker.
It is, there's a higher chance that the bronchi blocker will get migrated or it will move more compared to the DLT. DLT is more secure.
So are you able to see the final table position? Hello?
Yes, Dr. Sunil.
Yeah, so
Please check.
yes, you can see the footing has gone quite down and also the heading. So that you can actually see the intercostal spaces being clearly seen actually. And we can count the spaces very nicely. She is not relatively a obese kind of lady, very thin built. And that's the reason we are very well able to see the intercostal spaces. And this is something we always desire, that spaces should be seen clearly. Thankfully, the collapse was not the chronic collapse. Otherwise, in many patients, when there is a long-standing collapse, you cannot see that, because there is so much of intercostal overcrowding, rib overcrowding is so much there that the intercostal space is just not there, even to insert your finger, and it happens quite often. So now again, I'll hand over the mic to anesthesia team for their final bronchoscopy check.
Dr. Dev? Do you place the patient strategically on the operating table in order to have an intercostal space opening up, depending upon the patient habitus where the break should be?
Dr. Raju, would you like to respond to the positioning?
Yeah, right now, Dr. Diego is not in the room. He just coming in 1 minute. He has just gone out of the room. So I'll get him back and then we start going. In the meantime, Dr. Raju can comment about that.
No, we tend to keep the patient to one of the lateral edges of the tube, of the table, and then keep the neck down and the head down and give a break so that the intercostal spaces get wide open. But generally it is possible, but in patients, pure thoracic surgery where they deal with the lungs, with the tuberculosis problem, then the intercostal spaces may not get widened. In practice, I don't think that is that much problem for us.
Fortunately, she's a female patient, non-smoker, good clean lungs. So that's why Dr. Sunil is highlighting. They could see the intercostal spaces clear. Yes, Dr. Sunil? Yeah, they're doing a fiber optic, maybe not Saurabh? Yes, yes.
Yes, sir.
Yes, Dr. Rajendra, sorry.
Yes, sir. We are doing the check bronchoscopy again after final positioning of the patient.
This is the tube tip. I'll just go inside, the bit of mucus here.
Need to clear the view, Saurabh, yeah.
Yes, there is a mucus, so we'll suck it out and then we'll again try to see the, right. Go inside. So,
This is the carina. There is sitting our left blue colored bronchial cuff. It has come a little out. It should be ideally another millimeter inside. Just inflate it with 1 ml of air.
Would you like to push in or just inflate?
We'll just push it in.
sir, we have to push in because in lateral position, it has been seen that
Migrated a bit out, and on inflating it is just protruding out. So chances of it just popping out are high during the intra period. So we'll push it a bit inside. Ek second.
Dr. Rajendra Prasad has commented.
I was suggesting that maybe a good idea to tell them to show the, how before they drape,
Yeah,
because once they drape, all the landmarks are gone. It may be a good idea. to-
Yeah, we will mark it and before draping it, then we'll focus the camera on that. Let the anesthesia team settle for a couple of minutes and then, in the meantime, I'll also brief you about the vascular control and what we are going to use for the stapling.
yes, Dr. Sunil, we can see you now.
Yes. So for all the vascular control and division, we are going to use the white curved tip staplers. Can you focus these ones? And these are coming from courtesy Panther. Yeah, so this is the golden tip, curved tip cartridge for artery and vein. And then you have the gun, which is, good thing is that the blade is part of the cartridge itself. So every time there is no issue about using the old blade also. Now, I'll request the camera person just to zoom out the entire thing so that you can have a panoramic view of the OR from all the sides. Yes. So thankfully, in this OR, we have the facility to, apart from the good vision and the integration of the equipment, we also have the entire OR complex, which is integrated within itself. That is, every OR can talk to any other OR, and the entire activity of all the ORs can be relayed to a central control room. And just you need to take an output from there wherever you want to relay it. So there is a wall screen there.
We'll show the wall screen also.
Yes.
So this is done by Stryker. So
Yeah, so I'll ask Mr. Akash from Stryker to explain it and the integration part of the OT.
Good morning,
One of
everyone.
our first installations where we have created a command and control room where you can control all 8 ORs for the audio, video, within OR transmission, between ORs, from OR to auditorium or for transmission also. So we can sit there and control the entire 8 ORs. We can see the anesthesia charts coming into the same screen from different ORs, and we have a room view and then operator view also, camera. Yes.
Good
Akash,
morning.
yeah.
Yeah, good morning, everyone. Welcome to NCI Chajjar. So my
Be
name is
louder,
Akash.
be louder.
My name is Akash. I'm from Stryker. So basically, what we have done over here, we have.
Are you able to hear?
Yes, yes, but we can.
Okay, I will stop for a moment because the anesthesia team is showing the final bronchoscopy position. You can see the tumor there.
We cannot see the
Yeah,
screen, move the camera.
please.
Yes.
Okay. Yeah. So this is what the feed is going. And then this is the tumor which is popping out from the right upper lobe into the right main bronchus.
We cannot see the screen or something. Yes. Screen, yes. Now we can.
Clear. Yeah, is it comfortable now?
Yes, now we can see this.
Okay, perfect. So on the left side, you can see the bronchial cuff, the tube, and the right side, you can see the tumor which is coming into the right main bronchus, coming from right upper lobe bronchus into the right main bronchus. And I think CCT is happy with the position now, so they are good to go. Now I'll hand over back to Mr. Akash from Striker.
Problem going on. I have to sort it out. There's a problem going on. Sorry. Sorry for that.
Yes, sir.
Yes.
So basically, sir, we have 8 integrated OTs. Each OT can talk to the OTs. OT to OT is calling there. We can relay the signals, and it's all integrated like anesthesia machines, your PTZ camera, your endoscopy camera. So all has been integrated and can be controlled through one touch panel.
Audio, we have lost the audio again.
Okay, is it okay now?
No,
Is it okay now, sir?
not very clear.
Audio team, can you?
Yes,
Okay.
yes, go ahead.
So everything is integrated to one screen, which is housing. Can you point it over there to the screen over there? So there's a touch panel over there. We can control all the signals from there itself, and we can route it.
Yeah, that is the router you can see on the right corner.
So
All
we can-
video, audio integrations signals will go to the screen, and you can operate everything from there and connect with the central command center.
Can you just point out to the ceiling like this, the ceiling monitor? So we can actually.
That is the room camera.
Yeah, that is the room camera, sir, which is placed on the ceiling itself. And we have the hanging monitors where we can, display all the signals. And it is like 18 signals can be integrated into it and can be relayed from here to outside the command room or anywhere else. So we can do the recording also from here itself, and we can transmit all the signals from here to any of the OTs or the command rooms or to any facilities. And it's always like conference ready solution. So that is it with the integration.
We'll see if your time permits, maybe between the cases, you can show the command room.
Yes, sir.
Okay, keep it ready. We'll get back to you later.
Sure, sir.
Okay, thank you.
Thanks, sir. Now we are ready for the final dripping, etc. to be started. So before that, as Dr. Rajendra sir asked for, we'll show the landmarks and the final position. So you can see I have marked the intercostal spaces, not the ribs. This is the 7th space, and this is the 6th space, and this is the 6th rib here. So somewhere around the 5th intercostal space, the incision will be planned. Just for showing it, I have marked these 2 intercostal spaces. Yes.
So you're going between 6 and 7 for this patient.
We will be going in the 5th intercostal space.
All right. I think it's all set. We apologize for little because it's the first time we are doing this. There's a trial run, the audio videos between the ORs and this center. So we did some trial runs. So small technical glitches, I'm sure we'll be able to overcome. Very soon we are going to start with this. I think it's all set. So anything you want to?
I think the most important thing
Yes, Dr. Rajan.
with the portal wax is how you place your incision. Varies a little on the right and the left. And if you get it wrong, then it can be a bit of a mess. That is why I said that maybe it's very important to kind of understand where you put it. You go a little anterior and you just leave it, then be a bit, who is the best person to explain that? And it's a little different in robotics. You have longer arms, so you can be a little lower, but wax you have very big sizes to it. But when you're doing a multifocal, you have a little bit of a leeway, but for unifocal, you have stick yourself to unifocal. One incision to be different. If we get it wrong, then it's particularly in our setups where you're seeing this maybe.
Hello? Yeah, yeah. Is it audible now?
Yeah. Dr. Rajendra is just explaining the importance of the incision size and direction.
Okay, okay, sir.
Yes.
Please go ahead, please go ahead.
So that is what in multifocal you have a slightly more, flexibility, but here it is very important.
You have only one chance.
And in our setup, we see 70–80% inflammatory lung disease, where anyway it's a very, very difficult scenario.
Okay, Dr. Sumit, we are back with you.
This is number 5.
So maybe mark the anterior exterior line, posterior exterior line, scapular angle, and then people will be able to orient themselves.
Right, right. I'll do that. I'll do that, sir.
There's the scapula. Dr. Sumit.
That's the scapula here. That's the scapula here. The anterior border you can see. Yeah, here is the anterior border, and that's the angle of the scapula here.
Yeah.
And then you have the posterior axillary line. Okay. Since the patient is now in accentuated position, so what I'm marking actually not be, exactly collaborating with the normal supine position, but just for the sake of showing. And then the
Anterior.
anterior axillary line. This is the posterior, this is the anterior, and the mid axillary line in that position. That again, Dr. Diago will be explaining where exactly he is going to place the incision. And at the time when we drape, since now we are going to start cleaning and draping, so I'll move the camera out of the field now. Any other question apart?
Yeah, we have very experienced faculty here. Dr. Prashant, Dr. Sharma, any tips to the audience at this stage? Or your experience is different? Dr. Ayyappan, Dr. Harit is also here. Good morning, Dr. Harit. Thank you for coming. Madhav. So you can just interact. This is a free sort of a.
So Dr. Diago is back, and now he will explain the position of the incision planning. Wait.
The patient is in a lateral. Can you put this? Okay, patient is laterally good disposition.
Can we have the camera, please? Zoom out. Yes. Come that side, other side, opposite Dr. Diago. Camera.
Yeah.
Yeah.
Yes.
So we have two options.
Zoom out.
This patient we can go higher in the fourth,
Can't see, we are blocking again.
or we can go in the.
Please. He's coming.
I think if the camera comes from
Yeah,
there.
come to the other side.
Just one.
Yes, better.
I think we will go here, see because of space, because if we go here, we need too high in this patient. Huh? Here could be a standard
Yes.
for lobotomy. When we do a sleep, we normally go a little bit higher, okay? But in this anatomy, I can see that going here is a little bit high. Will be fine, I see a little bit high. So what we do is we go here. If you have any problem, because for lobotomy here is fine, but you have any problem for anastomosis, you can always do the incision here and move just in your difficult instrumentation, whatever. For example, you have difficult instrumentation, difficulties to do anastomosis, and you are too low, you can always go a little bit higher, okay? With the same incision, just in emergency, in a situation that you are not comfortable with what you are doing. In this case, I think this is a suitable intercostal space. I always consider the whole chest. Okay, I don't follow the landmarks of just following the tip of the scapula. Normally this is 5. So I normally try to see the whole chest, how long this. Sometimes there is a trick that you consider from the upper part to lower part, and it's normally on the middle. Okay, so but it normally it sometimes doesn't work to be in the proper space. So I think here, tip of the scapula a little bit higher, and this is the 5th intercostal space. For this spacing, we'll be fine. 5th. Okay, we'll be fine 5th. You can always have, if we have, for example, second carinal reconstruction or a carinal main carinal, you have to go higher. 4th. Yeah, 4th. You have to go 4 because from here will be difficult to reconstruct. But for right upper sleep, I think we'll be fine. Okay, so you go here. And normally a little bit more lateral. Not so anterior, we can go here. Here is okay. So I will do the incision probably here. Posterior axillary line, a little bit between posterior and medial. Just for a better angle. Also, when you go a little bit more lower and posterior, you have better access to the subcarinal space. A little bit more posterior. So, another thing is, depending where I'm working, I have a different setup for the system. For example, when I was working in Shanghai with all the team there, we are used to have the assistant on the other side because they are very experienced with the camera, and it's the best setup. Assistant on the other side for right upper lobe because I have more space to work. So the assistant is on the other side like this, and we have more space to work. If the assistant is not used to, it's the first time that is in touch with me, sometimes on the same side is the best choice, unless he can manage from the other side. In that case, if you have only one camera, we put the camera here. Okay, in the same.
Dr. Sunini, the voice is sometimes fluctuating, could you control that one, the voice?
But here we are working with the Olympus camera.
Diego, we have lost the voice control.
Hi. Can you hear me? Hello?
We can't hear you.
And now we can hear you. Can you keep the mic closer and maybe probably microphone may have to be changed?
Voice is distorted.
Okay. Okay.
We lost the voice completely.
Hi. Can you hear me?
No, sir,
No.
you're not audible.
We are not able to hear you.
Wait. Okay. Can you hear me?
No, sir.
No.
Hello?
Yes.
Yeah, is the voice going now?
The voice is there, but it's distorted, sir.
Are you able to hear me?
It's not clear.
Not clear. Okay, okay. Just give us a minute. We'll correct it and then. Okay, and then start wrapping. We'll start wrapping now. Cleaning. Yeah, yeah.
See, it's very important in these laparoscopic surgeries. Positioning of the patient.
Hello?
Yes,
Yeah. Now the voice is clear?
now your voice is better.
Okay, okay. So we will hand over the mic to Dr. Diago now.
Yeah, please.
Hello?
Yeah, we can hear you, Diego. Good morning.
Yeah, good morning. No, I was saying that in this patient, we have two choices. We can go fourth intercostal space or fifth. If this was a normal lobectomy, a fifth is the best choice. If you are continuing to do a sleeve, sometimes four is a little bit better. It's a little bit more difficult for the lobectomy, but it's easier for the anastomosis. So we will see now, after positioning the putting all the scraps, we will decide. But normally, for this spacing, according to this anatomy, a fifth is a good choice. No, you don't have, okay, normal scissors, long, open surgery. No, it's okay. We don't have a thoracoscopy. But this will be okay. This will be okay, I hope. If not, we use this. The camera, let me check something. Sunny, do you know the link is working? I think it's. No, it's not working.
It will not open it here unless you are in the personal network.
Okay, but if I go with, no, if I go with VPN, I can do it. Let me check.
From the personal network.
Just to see, no, to see if it works. Because I share in the groups. Yes, yes, yes. It's working, eh? Okay. Okay, okay.
Inshoot network doesn't allow YouTube here.
Okay. Okay, there was Netflix instead of working. Okay, it's working, okay. Okay, okay. So, mind you will be the camera. Okay. Would you want to stay on the other side? Is better? You will need an assistant also. So then we have to put the camera here, or you have, okay, you have different monitor, perfect. So that camera should be higher, huh? It's for me. No. If you have two cameras, it's not necessary. Maybe. It's like that. It's similar. It's the same. It's the same. Okay, so keep this. Yeah, put this more here, more higher. Be careful with the cables. Yeah, for me it's like this, okay? And mind you can watch that just from here, okay? It's better. This side. Yeah, okay. Yeah. Oh. Yeah, you can put this closer to you. You can watch this monitor from there. Okay. Yeah. Yes. Yes, I will say now. They can hear me now? They can hear me? Hello, can you hear me?
Yeah, we can hear you.
Diego, we are with you.
Can you hear me?
Yeah, we can hear you clear.
Okay, okay.
Can you tell us the position and the ports, the monitor position, the cameraman's position?
Yes, we have the patient on the lateral decubitus position, and we are gonna check now if we do in the fourth or the fifth. I will check when I'm scrap.
So how will you decide between the two spaces, fourth or fifth?
Yeah, normally for sleep, I prefer fourth intercostal space. It's more suitable, especially on the left side. On the left side, you have to do fifth, fourth. On the right side, sometimes for right upper, you can do fifth. Okay, depending on the anatomy.
No, emphasizing on the anatomy, can you tell us the less experienced, what anatomy determines that?
I mean, it depends if you see sometimes, sinus a fourth intercostal space is too high in some patients, depending on how they have how the patient has the diaphragm. If it has that higher in a higher location, diaphragm in a lower location. So if the diaphragm is too high, if you go in the fifth, maybe you are too low. And you have difficulties because everything will be, pushing, and the lung will be push it up. So, according to anatomy of this patient, also we check how long is the chest of the patient. So, there is also one interesting thing that I always do is that if you are uncomfortable, of course, I did maybe a couple of times in my life, but it's an option that for some surgeons with less experience, that you can always do the incision in the fifth intercostal space, and if you feel, because for lobotomy is always fine, fifth, and if you feel that you are, uncomfortable for the anastomosis, you can always move to the fourth through the same incision. That is one of the things that we can do. So we use ligature or harmonic? You go open both? So you want me to use both to show?
It's your preference.
I can use both. If you want to show both, I mean.
It's your choice.
Okay.
So now the technical position and personal position.
Okay.
They were asking for that.
Yeah. For example, something that I like very much is when the assistant is on the other side. This is the best setup for a uniportal. And when we have the assistant located on the other side, it is the best setup. Of course, the assistant should be more experienced for this, for doing this. So we need an assistant with a little bit more experience, but when you are used to that, it's the best for the surgeon, because the surgeon is more comfortable with more space in front of the patient. When you have an assistant on the same side, sometimes you need to do some maneuvers to avoid collision with him. It's fine, I will always do it. But if I have to choose, the best setup is assistant on the other side. You will see. So we can use harmonic or ligature, both are okay. If you want, I can show you how I use both. Okay. To show, because both are open. So I will show you how I will use harmonic and how we use ligature, okay, to show you different ways. There are two, for example, two things that I like from both. From harmonic, I like a little bit more because it's faster, and it is faster. You can go faster. I have to be more careful with one of the jaws, okay, one of the shears. The ligature is very good for thymectomy, for example, because it's more safe when you are dissecting around the innominate vein. And for the lymph node dissection, I think ligature is a little bit better, maybe a little bit, because you can seal the vessels a little bit better. So in case of chylothorax, I think it's a little bit safer, but it's fine, both are fine.
So now I'll just hand over the mic to our nursing chief, Mr. Rakesh, for the safety checklist announcement.
Okay, I will start.
Very good morning, all of you. My name is Rakesh Kumar Sarma, servicing registered head nurse in this hospital. I am very delighted to you for this live conference workshop, especially Dr. Diago, Dr. Sunil sir, and organizing committee. I request to entire team kindly. Kindly introduce yourself one by one, surgeon, anesthetist, scrub nurse, and floor nurse.
Myself, Dr. Naveen, is assisting surgeon today. Dr. Manjunath, assistant surgeon.
I'm Dr. Saurabh, anesthetist for the case. I'm Hemraj Kumar, assistant scrub nurse.
I'm Dr. Sachidanand, anesthetist in the OT.
Now patient details: Sangeeta Saridan, 32 years female, UHID 102938251, diagnosis carcinoma 12, right upper lobe, and surgery plan, right upper lobectomy with VETS. Now from surgeons, any have anticipate blood loss?
200 to 300 ml.
Any specific improvement requirement?
We have taken all the instruments for VETs related to VET that we have already explained to the audience there.
Any critical or unexpected steps?
No, it's not anticipated.
Now anesthetist. Sir, specific concern related to patient?
Only concern was one lung isolation, that is taken care of.
ASA grade?
1.
ठीक है sir. Nursing staff. All instruments are trial.
Yes, sir.
Any issue related?
No issue.
NVT equipment. Okay. Thank you.
Thank you very much. We are good to go. Dr. Diago has gone to scrub. We will be starting in 5 minutes.
Can you show the OT setup, the cautery machines where they are lying, the camera screen, the trolleys?
Okay. I'll ask the camera person just to turn this here. So the instrument trolley is at the foot end, just a standard mouse stand, and then you have the equipment for the cautery and vessel sealer on the pendant on the one end of the OT, which is at the foot end, and then all the anesthesia side on the opposite side. So we have the monitors. We can see the hanging monitor there, and then the monitor for the assistant, and the main vision tower for the surgeon. Along with that, you also have the anesthesia monitor on the back side. We have turned off the wall screen as per request of the operating team. That's where the entire setup of the integration equipment on that wall, where the blank screen you can see. So we have a kind of a 3-feed system here. You can go for the room camera, endocam, and the OT light cam. So all the 3 feeds can be sent to any designated server or so and can be relayed simultaneously. Now we will be focusing again only to the operating field. and then hand over the further proceedings to the operating team.
One 30 you have. But 45 you have vascular many.
Dr.
How many?
Sunil, I have a question for you.
Only few vascular. But for the next case,
Dr. Sunil, you are.
but we can use from the next this case or not. Okay. So how many you have vascular? Hello?
Yeah, Dr. Harit has some, wants to ask something.
130 and 245, only three for this case. Wait, I think it's enough. It's enough three. Pain. Okay. Okay. Okay, one black, okay.
Yeah, please. What was the question?
Yeah, so Dr. Sunil, the question is that if this was planned robotically, what would have been different from incision planning?
Okay, Dr.
Well,
Yadav.
if I do robotically, in the portal, the incision is lower. The incision is at the sixth. Will be here.
In the sixth.
Because for an uniportal VATS can be here or here.
Two spaces.
If I do robotically, you have to go here. Because otherwise you have no angle for the staplers, unless you do hybrid. If you do hybrid, if you do robotic with VATS, then you can do fifth, because you do the instrumentation with the robot, no problem. And you do VATS staplers, no problem. But if you do fully robotic, you have to go lower. Otherwise, you cannot angulate the staplers for the upper. I'm thinking to go higher in this case. Higher is better, because fifth, a little bit, more easy. Let's go higher. I want to go higher, but from the other hand, let me see. But higher. Yeah, but I was thinking that it is a little low. Okay, we'll go higher. Okay, give me the 5. Okay, we start. Okay.
So you have decided for the fourth intercostal space?
Yeah, I think I will a little bit higher.
Okay.
Because of the pacing has a. You can see the incision. Can you give me the mouse?
What is the size of the incision?
Show the incision.
3 centimeters. 4 centimeters.
Okay, this incision. Huh?
It's hardly 3.5 to 4 centimeter incision.
No, it's less. I think it's 3.
Probably 3 centimeters.
Yeah,
I
yes.
correct myself.
With my finger.
Yes, yes, yes.
Dr. Sunil, the cameraman is standing to the front of the Diago, on the other side?
Yeah, I think it's the best setup.
Okay.
Find it from you. You can see, I can see that this incision is high, but we'll be fine for this. Okay, stay like this. No, this is too big. Give me a forceps. Okay. I know. Yeah, the. How much is the cautery? No. 20 is too much, 40, 45. It's too low. 45, okay? The line is collapsed, clamp. Okay. No, not too much. Hold it. Okay. Can you believe this? Like this. This. Fun.
Can you do the function on the right side?
I don't see the light is not correct. Honey? Okay, yes, okay. Okay, the potato. Fine, fine. So there is one good thing of this good potato is that we keep. You will see, we keep the upper part of this to keep the camera. So you see that we are in a good place, in a good position. Hot line. Suction. Can you put the camera a little bit higher and close to me? Yeah. Okay. And put now. Okay, and close to me. Okay. Normally I don't use this suction. This suction is too thin. But okay. There's no light. So we start with the inspection here. You see, we are in the good intercostal space. The upper lobe is here, like this. Okay. And the first thing we have to do is to do the retraction. Okay, upper lobe is here. Okay. It's a little bit inflated because of retaining air, but it's okay. Maybe will suction will be. But I think the upper lobe is retaining air because of the tumor. Yeah. Okay, doesn't matter. This is for you. So what we do now is we do like this. With this one, we can keep the camera like this. Okay. Give me a. And we have to do another trick, which is give me something to fix this here. Okay, there are small tricks, but they are very important. The important is about tricks, like life. Life is about tricks. Tip and tricks. Okay, it's good. Okay, camera always on the upper part, and I will go below. Okay, let's start. First thing, I'm gonna go. I will not be very fast. Okay, just to teach. Okay. 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 Take the camera here. Okay, I will stay like this. The camera maybe for Manju is better there, so I don't need to be like this. Okay, give me the grasper. Camera always on the middle of the image. Is there? I don't want the zoom. Put 1.0. Grasper, grasper. No, grasper is land grasper. Perfect. No, land grasper, land grasper. Land grasper. Okay, this is okay. So the first thing is we just do like this. This is retraction, huh? Like this. Okay. There's some additions here.
Can we have it close up?
Some additions. Give me the harmonic or ligature. There are additions here, so you have to remove it. And you go out a little bit. This is for you. Take this for you. Okay, take this. Give me the harmonic, please.
Diego,
Okay. Yes.
there's a question from the audience here.
Yes, sir.
What is silk suture from the incision? What is the purpose of that suture?
Is just to keep the camera in the upper part. It's for you.
Okay.
All the time. Yes. So now what we do is to do the retraction like this. Okay, for exposure. Look, I want to show you how I do the retraction without using too many instruments. You see, we do the retraction like this, and then it's for my assistant. Okay.
So,
And then now I can go like this. You see, harmonic.
so that thread is part of the wound
Harmonic.
protector itself.
Harmonic.
That comes from the
Okay.
applied medical.
Please prepare a vascular 45.
So you can see the Aztegas and SVC junction here.
You can see how I do the harmonic. I think the harmonic is the best instrument, or either harmonic or ligature, to do a good dissection. You can see how the uniportal provides a very good view here. Closer. And you see camera always in the middle of the image. I think harmonic, this camera is the best in the market. You can see the quality is really amazing. Olympus, really amazing. And you can see how I'm using the harmonic. This is what we call advanced instrumentation. That is a concept that we developed in 2015. We were the first in the world doing this concept. It's called advanced instrumentation. That means that we use only 2 instruments. It's called also non-grasping technique. You see, I use the harmonic, I move to the right, I move to the left. You see, very careful, without any movement. You see, I'm not grasping the lead notes at all. I'm just doing this, and the idea is to do this carefully. You see, in order to remove all the lead notes.
Diego, there is a question from audience. What is the harmonic setting you are using?
I don't know what one we put.
It's 3 and 5.
Yeah, it's normal. It's the usual. So for example, we can start now doing the dissection of the lymph nodes. You see?
Dr. Sunil, yesterday some expert was asking what 2 and 3, 2 and 5 is the better, right?
It's the personal preference of the surgeon, to be honest. Some people like 2 and 5, some people like 3 and 5, but for the sealing part, mostly it's either 2 or 3. That all depends on the personal preference. I don't think much of a debate about that as such.
So this is the 4R node.
You can see that the uniportal provides a very good view. And this camera has a high definition, so it's amazing.
When do you stop it? You continue your 4R from here? How much you go now? And then what's first?
No, I think we can have this now. I think we can do the lymph nodes now, because it's a good idea. I go from here, and you put in the.
That's a very good thing, because once you remove the
Yes.
the entire anatomy gets open.
Yes, exactly. So I want to do the lymph nodes now. And you can see how we do this, is called non-grasping technique. You can see it's about working in coordination with the suction and with the harmonic. Always carefully, you see. And the idea is try to do with no bleeding. It is more elegant and more
precise. You see, this the energy device is the best dissector you can have, huh? So it's about moving to the left, moving to the right. No, because I think, you know, the concept of uniportal evolution in the last year is to do everything with the less number of instruments, make it simple. Huh? And this is why I think uniportal is really amazing, because when you learn, you don't need to use too many instruments, you see? But we are doing everything very simple, no grasping technique. You see, and I use the harmonic as a good dissector. Huh? Sometimes we don't even need the
Do you have a plan to do a comprehensive dissection, or is it only for access?
Well, I think you can do complete. Maybe in a carcinoma, you don't need complete, like radical, because it's a typical carcinoid. But I think we can do a good dissection because it helps also for the anastomosis. So you can see.
I just wanted a comment about the lung
See, well, for example, yeah, I'm happy. Yes. I think there is a little bit air that is because of the obstruction of the tumor. So, but the anesthetist did a very good job with the tube placement. So everything is okay. You can see here, we are going from down for up. I just want to show you how I do the advanced instrumentation. There's some vessel here. And imagine. In the middle. Small vessel here. Okay, so we can go from the upper here. You see?
Appreciate the external view. His elbows are all below the level of his chest. You can see he's not.
And now,
Do it.
No, it's not good. This for you, hey.
Shoulders are training like anything.
Yeah,
Whereas you can see his elbows are in a good comfortable position. Actually, his left hand is on the other side of the camera now.
Okay.
So it's not like hard at first.
So you can see the aorta on the. So it's very important to go here deep, because some people sometimes don't do this part. They just do. You see, it's another lymph node here. Yeah.
Yes, sir.
Here, if we go from here.
Very well done.
Thank you, sir. Most of my learning has been from you.
So now we can go from here, you see? And now we can move to like this. You will see how I move the package from the lower part to the upper part. Huh? I think there's still some stacking part. Back. Still some
Do you think those lymph nodes are malignant, or those due to inflammatory process?
I think they're inflammatory. Okay, so here you can see it. Let me give me now. Sometimes we can do this. Give me the dissector, please. The snake, sir. Because I think that here there is some part we can do like this. See, we don't need the snake. Huh? It's just this movement. You see, without the snake. So it's about learning the movements of how do a proper movement. See, I'm doing like this. It's a very big lymph nodes. I'm surprised that this patient has such a big lymph nodes. Okay, go ahead.
Also, dissecting this lymph node will where the trachea is easily for us. So we can go up to the carina easily with that.
Sir, video team, can you make the PIP little bigger so that let it be on the corner, but a little more bigger?
The most important thing is how he is handling those, that small 2 centimeter area. That is what is important. They need to show us that one better.
Zoom in the PIP a little more.
Yes, yes, we are doing that.
You see, I'm just doing these movements all time. It's about, you see, I use this action as a grasp. You see, as a traction. It is very important to learn how to use this action, you see, as a grasp, as a retractor.
So what is the size of this suction device? Is it 5 millimeter or bigger?
6 mm tip.
Really big lymph nodes.
Is it curved or straight?
It's a curl from a scanline, and he was not very happy about that. He wanted 7 mm.
Yeah, I prefer the video one, but it's okay. I normally don't use this, but it's okay. You can do it, but you can see a big lymph nodes. My God.
So we're planning to do 2R also?
What?
We are going to do the.
No, I'm trying to just remove this one.
Okay.
I'm going to see when it finish. Because they are huge, you see. And it doesn't look beautiful, these lymph nodes, to be honest.
The nodes
It could be inflammatory, but you see they are like white.
like yesterday's cadaver, we all have lots of.
Possibly because of the component of obstruction, we do expect, obviously, you can see
very
clearly able to pass the scope through that.
One message where is the carcinoma. It's not similar to a non-small tumor. To do this section, for the first place.
I think we finish here because we can go higher, higher, higher. My God. There's no end of these lymph nodes. My God, look at this. It's coming from everywhere.
If you have a query with this, we can always get a frozen.
I think it's the. It's not the goiter. My God. I think it's okay because it's carcinoma tumor. I don't think they are malignant. It's a small tumor.
So actually the number of lymph nodes depends on how long the patient has had atelectasis also. Sometimes because of the occlusion and atelectasis, they tend to have.
So you see, this is where.
But once he has done the.
You see, it's a huge. Okay, this for you. Okay, it's 2 and 4. Huh? I think it's enough. But it's good because we already removed the lymph nodes, and now we can start the resection. Okay, section.
This is a really nice dissection. Both trachea and hair wall is
Just
bare.
take this. You can see, you can see all. Of course, we can go higher, but I think this is not sure is lymph nodes or is something else. We don't know. So you don't need it because it's a carcinoma. Maybe if the patient was a carcinoma, it will be able to remove higher. But you have the higher you go, the more risk of laryngeal nerve injury. So let's go here now.
Because it's a nasty question, I'm sorry to ask you this. So in your initial phase, how many times have you injured any major vessels around it? Because now we have seen you through this, so we are going to follow this tomorrow, day after on the table.
Okay.
So.
Okay, so now I'm gonna go here.
It's not answered.
He's asking how many times.
How?
How many times you have the artery or vein during the defect?
Very well. In the last years, I don't remember. My initial days, yeah, Some, of course, I don't remember, but of course, in the learning curve, you have some accidents, but not too much, to be honest, because I always be very careful. But of course, I have some bleeding cases in the learning curve, of course. Okay.
Can you explain the anatomy of the main TA first ones?
Yeah, go here.
Where do you see?
Yes, so, give me a harmonic. See, there is a leaf node here on the pulmonary vein.
That's a level 10.
Yes, here. So we're gonna start here, opening this. Here's the phrenic nerve.
Very close to the front.
Yes. Prepare a 45 vascular.
45.
Yeah.
Dr. Diago, do you prefer vein first, artery first?
It depends on the case. In this case, we'll see. And as I said yesterday, remember I said yesterday in the lab that I don't follow always the same path. I do whatever is easier. Normally, right upper low, I do the artery first and then the vein. In left upper, I do the vein first. Good for you? Yeah. So we are gonna go here, Manu. We have to see the artery now. This is the artery, but I think
First branch of Pankaj artery of RPA.
there's some kind of fibrosis. You see that the artery is a little bit fibrotic. Yeah.
You are having an excellent camera system and a camera man.
The cameraman
Yeah.
is not so good. Don't tell him that. I have to be rude with him to be better. Okay, so now you can see there is one branch here of the vein that is stuck to the artery here, you see? Yeah.
Start of the procedure, you told you're going to be slow, but the way you're operating doesn't.
No, this is slow. Actually, is slow. This is slow.
You see? There is some vessel. The vein is stuck to the artery here.
Yeah, generally for initial cases to start with inhibitor, do you suggest using harmonic or do blood dissection?
It depends. I'm gonna go here because I can see. Give me this snake now.
You are an expert, but here a lot of students are there.
I think harmonic is good, but you have to be careful when you are starting. Always, okay? In the learning curve, because harmonic is good, but you can have a problem if you are too close to the artery. So always very careful with harmonic until you get experience. Huh?
Yeah, especially this right upper lobectomy, the
Yes.
vein is always adhered to the pulmonary artery.
Exactly. You can see here. The artery is a little bit stuck. Yeah.
Like you said yesterday, usually do you think that doing a little more posterior dissection of the bronchus and cleaning out the lung more and then coming to this will be better?
Harmonic?
Will it help you in stable?
No, because you need to go here. So we don't have any difference. Show me the upper part. And here. Two more. You see? I think it's two more here. a lot of tissue around the artery, you see? A lot.
Carcinoids generally have very dense
Yes.
inflammation around.
Exactly. Okay, so. Now we can see the artery. Now we can see that. Yeah. Okay, give me a snake. Snake.
Which is the main PA, which is the first branch.
Now this is the upper artery for the upper lobe.
Yes. And what is below your instrument is the main PA.
Yeah.
Main lobar.
I think this patient has a small PA. Give me Diego.
Sometimes, like he mentioned yesterday, if you're not careful, you might think the main PA the patient is make sure that
Diego?
below the branch.
Okay, normally you don't use this card. I think there's some lymph nodes behind something. Okay, normally I don't use the stapler. Okay, give me a vessel loop. I will show you how we do the vessel loop. Okay, normally I don't use it, but I will show you. Give me. No, but give me something. Snake. Snake.
I think the vessel loop helps.
Yeah.
In retracting and putting.
I just show you. I normally don't do it, but I will show you. Okay, how I do it. I only do for robotics the vessel loop. Okay, stapler, mosquito. Mosquito. Okay, so I'm gonna show you how we do. Okay, so the key is, remember, for the upper lobe, disangulation, very important. Can you take this? Disangulation, because it goes direct, okay? You will see, remember, do like this, go to the upper part, like this, go to the upper part, traction. Go behind, like this, okay? No. Let me do, no. Like this, okay? So you keep this traction a little bit. Okay. So we do like this, okay? We do. Going to the lower part, like this. Going back now, a little. And just, it's about one trick like this.
Video people, please, PAP, please. Very important, yeah.
Okay, remove this. Remove this. Pull it. Pull it. Okay, and now we fire, okay? Very careful. You can see the curved tip of the panther is very good and the quality is excellent. Of this stapler, I really like it. Okay, so here. Now, we can continue, maybe we go to the vein, okay? So, we can see that the middle lobe is here. I think there's still additions here.
Really, when you introduce the stapler, you already created the curvature and then went. Is that the appropriate, is that is the better one, or when you get into in a straight way and then give the curvature?
What do you mean? Suction?
No, when you're introducing the stapler, you create the 45-degree angulation outside and then maneuver it inside.
Yes.
Is that easier technique as compared to bringing the straight stapler and then give the curvature?
I think it's better to put inside already, harmonic, with angulation already. You put with angulation and then you will change.
Okay.
Harmonic. So now it's very important here to identify the middle lobe, okay? Yeah, you see? So middle lobe is this one here. Yes, so. So I think here is fine, huh? Okay. In snake. Prepare another vascular staple, 45. So very important to dissect like this. These are some tricks. Okay, give me the Diego, please. Vessel loop. And now it's important to go like this, okay? As a loop. And here I'm going to show you one trick. Another Gonzalo's Rivas trick. It is the trick of the suction, okay? I will show you now. Okay, we put like this.
Can you see from the exterior?
Okay. Keep like this. And you stay like this. Okay, I will show you the trick of the suction, okay? Give me the other, please. Okay, the trick of suction is like this. It's very useful for the vein. Don't do it for the artery. It's very useful for it. So we do like this. Okay, we open like this. Then we put the suction below. Go back. Go back. Like this. Show me here. Okay, and we pass the suction. We remove the dissector. No. Like this. Remove the vessel loop. Here. Okay, and we do like this. You can see. This for you.
It's a good technique. Once you are doing this, what is the purpose of the?
Trick. And now we can make any traction we want in a stapler. And it's very easy to pass the stapler. All the staplers give me like this. All this angulation. Okay. Again, the same angulation. Look, and now I cross my hands. Look at this. Like this. Cross my hands. And now go back, go back, go back, go back, go slowly. Slowly, and now very careful. Because I think I will prefer a 45, a 30 for this.
Yeah,
Show me. Show me.
30 is ready.
No, but you have only 130. I want to keep it for the posterior ascending, but it's okay. Okay, you can see, and now we fire. Okay, one, and we fire slowly. This is the Gonzalez Rivas trick of the suction. Okay, I will show you several tricks today. Yeah, we can later cut this. That doesn't matter. Okay, so now we just do retraction here, like this, harmonic, and then we are going to go to the posterior. You can see that my assistant don't need to move the camera too much. Play with this is better. So he didn't disturb me. Okay, and then like this, harmonic, and I will stay like this. Okay, now we go to the posterior ascending artery.
Okay, Dr. Diego. Now versus a standard right upper lobectomy and the sleeve lobectomy. What will you do different now? Now you will go more distally.
What?
Now this patient is going to have a resection of the right upper lobe and a sleeve. Compared to a normal lobectomy, I think normal lobectomy you will.
No, lobectomy will do the same like here. Show me.
You are doing a Fisher-Last technique.
Yes, I always do for upper lobectomy Fisher-Last. I think that is the best technique for right upper lobe, unless you have a very good fissure, complete open. But even in that case, I like to do have a standing artery there. You see, you have to be careful.
So, Diego, one thing with the audience side, if you're doing a straight forward upper lobectomy, we should take the bronchus first or the posterior ascending?
It depends. It depends what I find. It depends what is easy. So I normally do according what is easy. If it's easy the artery, I do the artery. If it's easy the bronchus, I do the bronchus. I never follow the same always. Understand? It depends. No, it's a lymph node. This is a lymph node. It doesn't matter, we can, okay, we can go now. Let me, okay, this for you, it's a brand, it's for you. Back. Take like this. Okay, harmonic. Thanks. Okay, we go here now. Let's do a posterior retraction now.
Diego, when you will not use a stapler for a vascular?
What?
When you will not use a stapler for a vessel?
Well, if the vessel is too small, or the angle is not good, I can use clips, Hemolox, Verena.
Safe or do endoswitching?
Okay, so I think we can go here. Yeah. This is, I'm gonna show you from behind now. Go. Back, Mayu. We're gonna see the posterior part, okay? Like this.
So we are seeing the bronchus from up down.
Okay, stay like this. Okay, then make traction. Harmonic. Okay. So let's continue with the dissection here because it's important to have some in the middle, mind you.
What lens that you are using, is it 30° or 0°?
30 always.
Any advantage with 45?
I don't like personally 45. I think 30 is always enough.
It's 10 mm, 30°.
Because sometimes we see large bronchial arteries coming and supplying the carcinoma.
Manu. Yeah, there will be a lot of lymph nodes here in this area. So it's good to do this now. The view is really good. Excellent. The best camera on the market. Look at this. My God. Look this lymph node. Unbelievable. Yes. I think Bergus should be cut here.
In carcinoids, what is the velocity on succumbing?
Yeah. Oh, yeah, Maya. What is my? No, remove it. How to remove it? Of course, I mean, this is typical carcinoma, right?
Yes.
Yeah. Typical or typical?
Typical.
Typical, so it should be inflammatory, so I'm not worried.
When you remove the subcarinal, you lose blood supply to the bronchus. I don't think that is the case because it's usually very well vasculated. Are you worried that the
Could be, of course, you have to be careful, but it's not something that we can control, because if the lymph node is there, you have to remove it. There's a vessel here. Yeah, I know. No, mind you. Let me cut. This is a vessel. It's a vessel. It's a. Okay, mind. Wow, look at this. My God, unbelievable. Huge, huh?
It's the cleanest lung you have done in India.
Yeah, but the lymph nodes are crazy. Look at this. The lymph nodes are very, very big. Also in the paratracheal, I was surprised that for a carcinoid, are like this.
Yeah, you will be completely removing this level 7 lymph node.
I think Well, not only a part of demonstration, I think we have to do it because it's a big lymph nodes, so for the sleep, we need it. Sorpresa here. As you can see, that are very, very big. It's going to the end of the world. Okay, back. No, mind. Wow, look at this. Why this person has these lymph nodes with this color? Yeah. It's completely blocked. Look at this.
Actually, this is a very tough case with stuck lymph nodes.
Yes. I mean,
because it's being done by a maestro, we can see it so easy, but otherwise it's so difficult.
No, it's difficult. And I think this patient has a carina very low. Look at this, because I think this is the left. So look, the carina is very low. You see? Completely abnormal. The carina is never here. No, the carina is just here, not here. So it's very low, very strange. But anyway, okay, we can continue. All cases are challenging, yes.
They are selected for you only.
Okay, so let's start opening the lung from anterior position. You see the lung is...
This is one of the cleanest one we could find on CT scan.
Yes. Actually, it is quite surprising. There is no carbon on the surface.
Yeah.
In Delhi.
Oh.
Not every starts before we get all black.
I know.
We're spending most of them.
Okay, section. But this carcinoid is not easy. Normally carcinoid are much easier. But this is quite difficult. Okay, so let's yes. Let's open the lung now. Okay. So give me staples now. Okay. Manu. Camera. Give me the snake. Yeah, there's a posterior ascending behind. You can try to remove this lymph node. I know. Yes, give me now, no, I want to open the fissure for the 60 purple. Back, man. The lung is inflated because of the inflammation. Take this for you. Take this. Mind. Harmonic. No. Manu. The more you can remove, the better. The more. And you know, no. Rotate the camera. Yes, more rotation. Okay. Yeah. Rotate the camera, please. It's for you. Give me a snake. Snake. Like this. We don't need to do this, but okay, it's fine. Harmonic? Harmonic. Okay, go back. Okay, back. Further. And it cannot be like this. Man, you, this view. Okay, stapler. Yes. 680. Okay, so we go like this. Okay, go. Yeah, section. Okay, I think you have to go here, just below the middle. Okay, stop. Back. Go back. Now we leave it, and we show it. Huh? I think it's okay. Section. This is the first shot. Okay. Okay. Yes. Let me see the here, below. Show. Let me see here. I wanna see. I can put more. Give me Gasper.
Diego, for the sake of can you repeat the same step, because this is very critical, the way you introduce the stapler.
I think here, okay. Okay. It's okay, we can fire. Yes, it's important to put between the middle and the upper. Okay, middle lobe and the upper lobe, and to see the stump of the vein, because we need to progress above the stump of the vein, okay? Section? Yes. Yes, so, okay, like this. Okay, so now here we have to see the posterior ascending artery, which is hidden behind a snake. Exactly. It's very behind. So it's very important to see the artery, because we're going to place the stapler here. Here. Okay? Okay, stapler. Yes. No. See, another 60 here. No, right. For the bronchus, for the lung. Another 60. You see, now we don't move from here. You see, I have a very good position, so it's important, don't move now. Another 60. Stay like this, move, don't move, don't breathe.
So the next fire is from the second to the.
You pay a little bit, go back now, stay at the end, stay outside. Okay, show me here. Do like this. Go. You have to put here. You see, just far from the ascending artery, okay? And now, very careful, do like this. Remove, go. Wait a minute, don't move, don't breathe now. No.
Very good, very good.
Here's the technique, okay? So we have to do here, okay? Not too much. Now it's better. Now you have two options because this posterior ascending is a little bit difficult. It's not the typical. See, now everything is more clear because this artery is a little bit difficult compared with others because it's very far. So we have two options. We can try to do the artery now. Let's see. But this for you, the interaction. You see, it's a little bit difficult. This artery.
I don't think stapler will go.
No. I will maybe go more here. Snake.
Do you prefer a clip or ligature?
I prefer, for this case, clip is good, but the problem is that for sleep, I don't like clips. Because,
Later on.
yeah, will disturb, yes,
Clip will disturb us.
exactly. And these lymph nodes are keep creating problems here, you see? A lot of problems. So let me see, I want to remove this lymph node because it will make everything clear, okay? If I don't remove the lymph node, this one is gonna be hard.
This lymph node will actually continue behind.
Yes, exactly. This is why this case is being a little bit difficult. It's more difficult than a normal carcinoma because they're crazy lymph nodes. Crazy lymph nodes.
This node will go in and join the other.
This one? Yes. Okay, just this for you. Give me the, yeah, this for you. Give me the harmonic. I'm gonna remove this lymph. Mind. Go back. I have to remove this one. If I don't remove this one, I will not see clearly. Okay, stay like this. Harmonic, this for you. Harmonic, please. Mind. Show me. So I think it's important to remove this lymph node. Okay, this for you. Suction, lymph node, this is very blunt, I don't know. Okay. You see, we have the worst location for the ascending artery. It's completely, is the worst location. Yes.
Sometimes I found that 6 comes from the. They have a common.
Sometimes a common trunk, yes.
So when you're doing from here, is there any way you, or you just dissect distally and confirm that it's not.
No, you have to see that this, no, but this is going to the upper, for sure. Okay, give me the snake. I would like to see if I can pass this. Because another option we have is to cut the bronchus.
I think that will make
If I cut the bronchus, the tumor will be here. We can cut here the right main, but for this purpose, we need to dissect first the lymph nodes. Otherwise, we lose a lot. Okay, we have another option, which is, okay, go back. Let me see this. You see? It's going to the upper, clearly. Huh? Completely fusion more. But you see, it's not easy to completely fusion. So let's do the ligament. Go down to mobilize this. So in this case is different compared with other carcinomas because these lymph nodes are creating a lot of trouble.
very important to remove all the.
Okay, this for you, Manuel? Sure. As you can see that the lobe is, look at this here. Oh, where is like this? Yeah. Harmonic is for you. Harmonic. And you take change hand. Yeah. Show me.
You are doing aspergillosis, anything is easy for you.
Yeah. No, but I mean, I don't care about additions. I'm used to additions, but you know, the problem is this carotenoid has these lymph nodes that are causing a lot of problems. This case is very difficult because of the lymph nodes, not because of the tumor, but the lymph nodes are creating a lot of trouble. Go, 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 go. I want to see where is the limit of the, where is the limit of the lung? Show me. Here. Huh? In the middle.
Just one decision is just able to see everywhere.
All right, the lower level here is consolidation. I don't know why. It's for you. Harmonic. Okay, just back. Show me in the middle. Play, yeah, play with this a second. You see, look at this. Look at this. You have to biopsy this, eh?
No, I think there is a consolidation in the lower lobe also. There is some. Are you feeling any hardness there?
Yes, yes. No. We have to do some biopsy to have it later. I think just for, maybe it's inflammation, but just for safety. Because I mean, it's a young lady, we don't remove the lamp for this. Okay. Give me now sponge stick. I will go from behind now. Let's work more on the lymph node because maybe I have to cut the. Okay. Give me a sponge stick. Put here a sponge stick. Yeah. Prepare a sponge stick always. I forgot.
Uniportal axis, if any injury or any accident happens, you can spread forward, put a sponge on stick.
Yeah, always ready.
Yeah, it has to be always ready.
Always ready. Give me the other grasper, the other grasper. The other one. The other one. No, there's another grasper there. No. It's this one, give it this. Always this ready, always. You have to have always ready, just in case. Cut this, I don't want this. Okay, just go here, Manu. Stay like this. Okay, go like this. Okay. Harmonic. Let's do this lymph nodes and clarify the anatomy, okay? Because the anatomy I think is not clear. Suction. Okay, back. Yeah. Let's go here. Here. No. And this for you. No. Stay like this. Harmonic. Closer. Closer. In the middle, in the middle.
Just see how
In the middle. In the middle.
just sliding. Watch each step. Sliding first. Sliding first. Not easy to do. Once you
Go.
master it,
Go. Closer.
The left hand is what
My God, look at this. Crazy. Eh?
Indeed.
Look at this. Oh.
There you go. I think it would be wise to practice just find the left hand and then.
I think left side looks a bit easier as compared to the right.
Funny.
What is something remarkable, he hasn't used any gross space as of now. That's what I'm looking at. Is he going to use it or not?
Okay, yeah, go. Yeah. No, rotate the camera. No, I can see, I can see. Okay. Play with this. Okay, you see we have a very good access to the circadian space, harmonic, but the problem is this crazy lead mode. Show me. Where is going? My God. He's going to the end of the world. Look at this. There's no end. Unbelievable, huge. Not there, not there. I think it's higher. It's higher. It's there. It's there. You see? This is the left main. Yeah. Make more traction, mind you. This is the left main.
Yeah, hard.
Okay, I think I have a not good view. And not good traction. Okay, just over. I miss my section now for these cases, but okay. I think I can survive. Harmonic. Oh, yeah. Look at this. This is the left main here, you see? Show me here. Show me better in the middle, in the middle. I think we have to cut here because I don't know where is the limit. Yeah, because this is, you can't see. You cannot see. My God, mind you, push.
I think you can take it off more from the periodic condition.
Say like this. Like this. Okay. Give me now the snake. Let me see if I can do more with the snake. Yeah. Show me, show me, show me. I don't see. In the middle. No need to move all. Just move the. In the middle, my friend. No, look, take this, take this. No need to move this. Just move this. Play with this. In the middle, okay? Say like this. Harmonic. Say like this, Manju. Like this. Like this. Like this. Like this. Action. Yes, yes, yes. Okay, it's for you. Now, this is the, okay. Stay like this, Manju. Like this, harmonic. Like this, okay? Come in the middle. Harmonic. Now, you have to coordinate with me, Manju. Your hands. No. Don't touch them. Because we have to do this as a, okay, like this, okay? Harmonic. Okay, this is doing nothing. Have to replace. Okay, just here. Say like this. Slowly, okay? Harmonic. So like this, can you, like this? And like this, no, no, come on. Like this, yes, okay, this way. Let me replace it. Okay. Camera, look, where is the camera?
Yes.
The camera is in the middle, not should be in the upper, mind you. Take care of that. It's in the middle, this is why I was not working comfortable. Stay like this. Stay like this. Okay, stay like this. Like this, okay? Stay like this. Suction. Harmonic. Why? Stay like this. No, no, no. I think one of the problems is that this is too. Stay like this. Harmonic. Closer. Go closer. In the middle. Go closer, closer, closer. Because it's impossible. If I don't hold, it's too big. You see, it's going to the end of the world.
It's going to be
This is what we thought the cleanest of the lot, what we admitted for the workshop.
I think, I mean, it's a carcinoma, so I'm not afraid, but because if this malignant, the problem is very bad. Closer, closer, closer. I think if this lymph nodes were malignant, the prognosis will be very bad. Of course, it's a carcinoma typical, so it should not be a problem.
Dr. Sunil, are we planning further section on any
Not exactly, because this was a typical carcinoid. So.
Just for the benefit of the audience, we can have it.
Do you practice that, Sarana? Do you do lymph node dissection?
No, lymph node dissection I do.
Yeah, but frozen section?
Look at this.
We have a challenge here right now.
My God. Give me his neck. Yes. I think the problem of this case, is that we can continue to leave nodes to the other side, and we never stop. So you see, because here there's another one going to the other side, I think.
Everybody is clapping just for the lymph node.
So I think it's enough. So now we can see that this patient has a very low carina. So we can do, I think, now cut the bronchus, because we will remove the lymph nodes. And then when we cut the bronchus, we will do the posterior ascending artery easily. Okay, so I think it's nice. Okay, give me the section, clean the camera.
Now, Diego, for cutting the bronchus, you ask your assistants to put a bronchoscopy inside, guide your cut, or?
I don't think we need in this case because it's from the right upper. So, say like this. Casper?
In what situations you will be doing an intraoperative bronchoscopy to evaluate the margins?
Normally I don't do it.
Normally you don't do it.
Casper, this Casper is not okay. This for you. Okay, so here we can see the right up. The grasp is. Say like this. So you can see here, this is the right name. So we can cut here. Okay? I think we'll be fine here. You see? This is the left here. So here's the right name. We can cut here because I think it's Fine. Okay, give me a snake.
Thing is, when we cut and you have to know that you can always go once to back.
Yes, give me a snake. Snake. Is the other side. Huh? Okay, so give me give me scissors. Yeah. Oh, give me the sector, please, Diego. And give me now a vessel loop, just to show you how we do with the vessel loop this. Or maybe no need to use the vessel loop, just I cut here. Okay, scissors. You can see here behind. So if we cut here, okay.
Always hold it for the trachea, you never use anything here.
I use sometimes, but I think in this case we don't need. The only problem we have is that I don't have the scissors, my scissors. I think here's okay, yeah? Oh, no. The scissors not working. Sis, I need the scissors that cut. That scissors not cutting. Tell this. Give me a vessel loop. Scissors that cut. Give me a vessel loop, please. Vessel loop. Because we don't have thoracoscopic scissors, so that's a... Come on, give me the scissors. Okay, man, you put in your, okay, like this. Please cut.
Wow. Oh.
It's for you. Suction.
You have a very nice mark.
Yes.
So for carcinoid, you need actually negative mark.
No, I think it's a good margin. Look, as you can see clearly. And the good thing is that when you do this, now the posterior is easier, posterior ascending, you see? Harmonic. And this is important because, you know, when you do this harmonic, in this case, I normally don't do this. I do all the lobectomy, ascending, and I leave this for the end. But in this case, because of the difficulty of the posterior ascending, it's better to do in this way, much better, okay? And now we do this, okay? I can dissect with this, see? Okay, give me a snake. No, Diego? Diego? Stapler, 30. Yes. You can take the margin here, but I think it's free, clearly. Maybe here we can cut, we will see, we will cut one ring more or not. I think it's free, Sorry. Yes. Stapler? Yes.
Origin is way distant.
Now we use 30. Okay, this for you. And now I think we can continue with the fissure and do the intermediate bronchus. Stapler? Yes. Yeah. See a tumor here? Snake? Snake? To cut here. And I don't see. I don't see Manju.
Diego, you want to see the middle of the takeoff before cutting?
There are lymph nodes here. So you have to remove these lymph nodes. Oh. No. Sister.
Preoperative bronchoscopy, like we saw in the narrow bronchoscopy, is very essential because we know that there's no disease beyond.
No, because I don't have good scissors. The problem is the scissors are not good, so it's difficult.
Long
What use the laparoscopic one?
Okay. Let me try. Go. Give me scissors. I'm struggling with my hand because I'm not thoracoscopic. So I don't cut well. You see, it's going to be difficult to cut. I don't see Manju. I don't see. No, I don't see Manju. No, I don't see. Yes. Why you didn't give me? Go. Let's go. Oh. Wait. Oh yeah. Say like this. This for you. Take this for you.
While we are doing this,
No.
Raju, what is your policy, sir? Do you do further section on the margins?
For carcinoid, no. You carry it?
Suction is not working.
Saline, please. Saline, please. But I think for adenocystic carcinomas and for adenocarcinomas, we should do, and squamous, we should do a cross section.
For all malignancies, I do it, but not for carcinoid.
Suction is not working. Show me there. Give me the scissor, please. Give me the scissor, please. Scissor. No, it's not working. It's not working. Okay, section. Let's see. Then I want to see the bronchus from here. You see? It looks freer. It's freer, but close, huh?
But at least we have a.
You see, show me. It looks good. Okay. Stapler, back. Back. Look the camera. Okay, go back. Show me. Taper. Don't put the camera down, please. Come on, stable. Stable. Section. Show me here. Back. Show me here. Okay, now rotate back. Section. Go. No.
Very difficult step.
Back. Camera. Go. I think it's okay. Okay, back. Okay. Yeah, it's okay.
Whatever you have, purple, okay, do 45.
Well, the only thing is that we finished the leave now, so. And the buyer. Who has my phone? Take some photos. You took some photos during the cut? Okay. Also, some photo of us? Of us? That's right. Okay. So, okay, I think we did the most difficult already.
Which of the steps would you say should have a disclaimer, should be done only by an expert?
We did the most difficult.
Just take up one or two specific things.
I'm on it. Get back.
Actually, every step is difficult, but I think the way 2 steps he is around the artery, 2 steps is around the vein. Hardly struggles to just push the stable.
Okay.
These are all back.
Crazy lymph nodes, huh?
Really,
And the lobe inflated make difficult operations.
but I think
Okay, right,
the
Roscoe?
most important thing will be the anastomosis. We will see how the one thing.
What is this bag that you are using, Diego?
It's a Medtronic bag in the camera.
I think
It's very good.
method to put this, so the bag is the lower aspect.
This is EndoCatch from Covidien.
So sometimes you may even struggle in putting this inside. Each step is really difficult, but I think it's essential to inform that everybody put it in a proper bag.
Ouch.
And, please show the, now can you just show the external camera bigger? Bigger, please. See how.
Diego, one of the problems that
You
we
can
have.
check the. Okay, let's take the tumor here.
Show the camera.
Diego,
Yeah.
can you let us know, when you have bulky tumors, say about 5 centimeters in size, and then you are going to remove this 3 centimeters
Can I take
probe,
a photo of this?
what are the techniques that we adopt?
I think margins here are okay. It's coming from the upper, as you can see, margins are free, yeah? Clearly here and here as well. This is the intermediate, I think. And this is the top. This is the main. Yes. So I think main is free and intermediate, I think also is free. Look.
I think we have a very good margin. It's coming.
Okay, take a photo of this. Okay, enough, huh? Change the globes and do the anastomosis.
Diego, I have a.
We need the more difficult, no problem. That will be easier.
Diego, I have a question to you. So when you have a bulky tumor of about 5 centimeters in size, after resecting, how do you retrieve the specimen without damaging the specimen?
Well, sometimes I do fragmentation inside the back with the finger. Partial cut of the tumor.
Okay.
I don't care about that.
So you don't mind cutting into pieces and then bringing it out?
No, I don't mind.
What is meaning within the back?
I prefer to cut the tumor and not the patient.
But the commercial practice is to send the entire specimen to the pathologist.
Pathology is not, because normally the prognosis of the tumor is not, is that, the prognosis of the tumor is the lymph nodes and the positive margin. So if I see that there is a clear margin, I don't mind.
Okay.
Cutting the tumor, fragmenting the tumor. Because even if you don't cut the tumor, if you pull, and you can break the ribs, and you will also have the tumor broken after removal. So it's better to do a control broken of the tumor.
What you said is absolutely logical. As long as the margin is free, the tumor dividing into pieces is not a big issue.
In the next room. Okay. So we don't lose time. Good.
Hot water, please. So, Dr. Diego, what are you using today for the anastomosis? Some PDS or rolling?
Okay. Here we go. Section. But here we see we don't have choice because we need to remove the lymph nodes. No choice. If not, you have bleeding. And if you don't remove these lymph nodes, if you want to cut the right main bronchus, there will be a big bleed because there will be vessels here. So you have to remove it. Yes. I can cut this part. Yes, one little here, one ring here. And this here. Right ring is okay. This is why I never use this section because it's very narrow, and to remove blood and for everything is difficult. Yeah, give me a plastic.
Diego, anastomosis.
Okay, so I will show you the tricks for anastomosis. I will do it slowly, okay, to show you the tricks. Step by step. Okay, so here's some harmonic. Some
Diego, how to do a tension-free anastomosis? Can you?
Come on.
Tension-free anastomosis. What is the length of trachea that we can the bronchus that we can sacrifice, and to reduce the tension?
Okay, so let me see if we cut one ring, maybe. So the most important, remember, as I mentioned yesterday, is to make the alignment of the membranes with the membranes, okay? So I will remove this ring. Okay? You need a snake and a scissors. We have thoracoscopicals or not? Okay. Scissors? It's a little bit bigger. The good thing is that we can include this as a margin, okay? Okay, suction. Suction. Okay, so everything is clear here. We did before when the. It's already, it's completely complete. Okay, me harmonic. I'm gonna cut this here. This. And harmonic. Just coagulate this now. We know the is going very deep now. Yeah.
There is a live YouTube link which is posted in ISO Academy group. If anybody wants to send it to the students, they can watch it.
I think it's okay, huh? Enough. And then we start the anastomosis, okay? So change this action now. So we have 40. Show me the PDS we have. The PDS of this is. No, not 70, 26. 26. It's PDS. Show me. But it is very small needle. No. But it's too. Let me see. Show me. Oh, open that. If not, we exploring is fine. I exploring normally.
Diego, can we see your needle holder?
Show me.
What needle holder you are using?
I think it's okay. I think it's okay. No, I wait. Thoracoscopic. We don't have this Canon. Okay, if there's no honor, I can try this. It's not the best, but this is how big is this? 90. How big is this? How long?
90.
Okay, let's go with this. So the most important now is suction. Okay. So here you can see, align this. So you will see clear this for you. Give me the snake. So it's very important to align now this correctly. So this is the membranous portion here, and this is the calculation. So you have to start here, from here to here. Okay? You see? Very important, okay? Good alignment, okay? It's for you?
Do you know what suture material and what length and what curvature you require?
Okay, give me the snake. I want to remove this stitch, this staple behind, because I don't want to have in the suture. Okay, let's start. So,
we are not having the clear audio from the auditorium.
vertical photos. Okay, so we start now. Can I put some light here? So we start in and out here, okay, in the joint here. Oh my God, this is very, I don't like it. I don't like this.
Do you know what suture material?
This is proline, sir. He's using proline.
He's using
Okay, let's go here like this.
3020. 30.
I like the skyline one, or the Chinese. Stay like this, stay like this. All right, no, but it's open surgery, it's more difficult. Okay, and now we go out in here. Okay, show me, mind you. Here. So out in here, it will be here.
Dr. Sunil, can we add PIP?
You see, here's the joint.
Yeah. Oh, okay. Please enlarge the.
Here, okay? And now I go here. And go. Here, like this, okay? And now, take this for you. With the other one, okay, leave it tension. I go like this, section. No, this is open surgery, no. Well, I will do with this, no problem. I go here, Andrew. It's terrible, this. Let me try with this. It's not my favorite, but like this. So I go with the other one here. What happened? Take this, take the base. When I do this, you have to keep tension here, okay? Okay, and now with the first one, I go here, like this. Don't move, Manu. Here. Just about here, okay? And then I grab it here. And I fix it upper. Okay, be careful. And then I will fix it here in the pleura. Okay, this is the Gonzalez-Rivas trick. Another of my tricks. Like this. Okay, and then I rub it. And now, leave it. You see, like this. I will fix it here. So, this will not interfere with me. Okay, let me see how long is. Leave it. Okay, fix it here. Mosquito. Okay, we fix it here, okay? Like this. Okay. And now we go. What happened now with the camera? Okay, now. Okay, and now we go with this. Suction? No. I will use that, don't worry, I will use. This far from me. Okay, and now we have, okay, you hold see, like this, to keep in the base. So, okay, let's go. And now we do running suture, okay, all time, like this. Oh, Mario. Show me. And now I have to go front down. Like this. Go up. And now, don't make traction. Don't make traction, don't make traction. Leave it.
It's a double lead.
Out. Out. My assistant should be going in and out all time. Show me, Manju, don't move. No, give me a hook, because don't move, Manju. Hook, one hook, not a hook. Hook. This, remove it. This never happened. Why should it happen now? Yeah. It's double tangle. Why? What happened here? Why? Out. Manju, I don't see. Manju, you have to show me. This way. Come on. Take out this for me and put it like this. And this out from, look. Your hand far out from here. No, Manju, no, not vertical, like this. Like this. Suction. I have a out in here. Now out. You have to follow me in order to avoid this tangling, okay? And it's very important, the system now. They have to go in and out. When I go out, he needs to go out. For example, now, out, and now go in with the stitch here. I have to go closer here and more distal in the other part. Okay, because there's discrepancy. And now I go here, I grab it, go out, I'll do it in the end. Going to see. Manju, you have to go out to follow me, and then, okay. Now, it's very important. Okay, go closer. Out. Okay, going. I have to calibrate, going.
Each step you have to keep. Bigger than the.
Yes, so I have to go closer here. Out. Oh. Okay. No. It's tangle. Hook. Hook. Sorry, I don't like. Okay, so I go. Out. Go.
I had my share of accidents with those clips. After that, practically I abandoned it. What your experience?
Well, I like for some cases.
Okay.
I don't like Hemolog. I like the Grena because they are better. Man, you don't move too much. And it's more safe because it's safer than. Oh, what happened? What happened? Why?
They're available here?
Grena clip is amazing because they never lose tension. I don't know. I told them.
Do you be Indian?
And I also like the angulated needle holder. This is straight, which is completely different. Angulated is much better.
This maneuver is very, very difficult. It looks so easy in his hands. Yeah.
So it will be much easier with my instruments, but. Out. Go.
Also important to the final knot should be on the cartilaginous part.
Oh, yeah.
So that is what is.
Mind you, put it in medium. Look. Oh. Don't touch me.
You can see how the needle is.
No. So I will change to this. Go.
Sometimes sir, I use left hand.
Out. We are correcting now.
Recently, an Israeli company has brought out a new equipment with the laparoscopic one with a 270-degree angulation with all the movements, range of movements like a robotic. Probably that will be us. It's very bulky.
You can only rotate it in one.
Out.
Here you use like this.
So Saravana, here would switching to 3D mode help?
Yeah, definitely.
Go.
Switchable platform.
Now, because we need to correct.
The issue is once you get used to.
You see, it's corrected. One more, and we will go with the other one.
Once you get used to the 3D platform, I mean, it's very difficult, even if you have probably a 4K depth perception and you go for a year or so. And then you know it gets challenging again, you want to switch back to a
Now I stop in the proximal. Oh.
We can say he's taking more on the.
Okay, leave it. Okay, I think we have corrected already. I will go with switcher now. Okay, this for you now.
So we should try not to telescope.
Please open, mosquito. Open.
Dr. Raju, when you started doing this, you did interpret in all or?
Initially interrupted, but now switched to continuous.
Oh.
But I have the problem with illustration to avoid that, this is better. And one thing is, he was doing so easily the left hand one. I cannot do that. I modify it and do it with right hand only.
Okay, listen. Okay, now.
Do you do it with the left hand?
And I go. And I want to do this.
So what he's doing now, he's now pulling so that the posterior suture line.
Okay, this for you.
Start and.
Give me the mosquito. Okay. No.
Actually, all the.
And be careful with this. No, I don't want this.
All the older.
Okay, now keep it on. Okay.
Which show interrupt anastomosis. But after lung transplants have started, everybody.
Your hand out. Your hand out.
They found that, you know.
If you put a hand here, I cannot work.
So everybody has switched over.
Section.
What is your?
Leave tension now. Leave it. Leave tension. Leave tension.
There's no need actually.
Okay,
But one can use it, I think.
I will use in a robotic case. But I actually took 2 sutures and.
Diego, your views about the V-lock?
Yeah, and robotic cases is amazing.
It's amazing, okay.
So we have switched over completely to V-locks. So when you are able to do it in robotic landing, so that's the only. In robotics, it is extremely good. Same thing with. There were concerns, only concern with V-locks. When you take the bites, you have to be very cautious because you cannot pull back. So that accuracy is better in robotic. Here, sometimes even if you go wrong, you might have to take back. The V-lock rips apart the number. So if you're able to do that, then I think V-lock makes sense.
V-lock for robotic is amazing. I use my own suture in robotic. I customize one suture. It's better than V-lock. It's double needle bar suture.
That is 3-0 or?
3-0?
3-0.
I will show you later. It's a Gonzalez Riva suture, customized for robotic only. Leave it. When I pull, you have to leave it. And you. It's customized with 2 needles. Okay. Oh.
I think this, what he's doing now is, see, the room is already closed, and you have to make sure you don't take it posterior way.
Don't make traction, don't make traction. No traction. Out. Go. Keep traction now. And you have to be like, look, and don't be like this. Be like this and play like this a little. Okay, give me now. Okay. Out, 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 out. Oh. Oh, shit. This needle holder. It's very important when you are used to a needle holder and you change. Back, back. Back, 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 back. Out. Out. Mind you, look where you are. You are in the middle of the incision. Mind you. You are in the middle of the incision. I cannot work with this. It's very difficult if I don't have a good help of the camera. Is try to put like this and to play with this, mind you. You see, it's not the same. Look, if you are like this, you interfere with me. You can be like this and play with this. Try to be the most parallel to me. Okay, don't make traction. No traction now. No traction. Back. Out, 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 out.
Monday we must be remembering the frequency days.
Oh, what's happening? This, give me, okay, give me a hook. Remove this.
Very much, sir.
That's the voice.
Remove this. Remove this.
I must admire you for the.
Leave, 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 leave.
I've learned from you, sir, most of it.
Good. Okay, it's for you. It's for you. I will do. The sleeve is very important. When you do the sleeves always with the same assistant, you go very fast because he knows how to follow you. So it's difficult when you change the assistant. Okay, give me. So look, the camera should be here, like this, man, like this, in front of. Look, your hand is in the middle. Leave it, tension now.
You can see like he showed yesterday. The
Show me,
left hand is
I
actually
didn't know.
pulling the bronchus apart so that you can take this last two weights. As the lumen starts closing, it's very difficult to take the last two weights.
Oh. You're doing one part. And now the last one.
So he's leaving it a little loose intentionally.
Then.
But you see his left hand just pulling the lumen apart a little bit.
And now that's the
Last weight.
remove the section, remove traction, remove traction, remove traction. Remove traction. Leave it.
See how he's using the suction to open up.
Show me something more. Finish. Okay, we finish. Okay, hook. Why you remove this? No, don't remove this. Okay, okay, don't remove it. Give me a hook now. Go back, go back. Go back. Go down, let's see. It's for you. Give it to me. Give it to me. Okay. So now,
So you can see the knotting, how you'll do it. This is the, show your trick, Dr. Diego.
yes, I will do like this. We keep always one. Cut this, cut here. Right now, I need light here because the problem is I don't like the not pusher we have. Cut here.
Okay, can you show the external view little larger, please?
Okay, this is also my technique, Gonzalo Rivas technique.
Yes.
Okay, I will show you.
Yes.
But it's important. Okay, what video, what not pusher you have? Light here, light, please.
Light on, stop light.
I will give you a pusher, quick, okay? I will kill like this with me. Let me see if this is good or not. Okay, I think this is cool, okay. Okay, I will pull like this. Now I will give you, be careful. Take it, take it, take it.
So he's single-handedly doing everything. You can see the entire suture is being held by his hand.
This is my technique, Gonzalo Rivas technique. You do alone, everything yourself. This is not pushing, is not bad, huh? It's good, it's good. I like. It's good, it's good. It's good. For a sleep.
Yes.
Who made? You? I have one similar in Portal, in Scalan. Okay, please do suction now. So the good thing of this technique is that you do yourself and you control the tension yourself.
Yes.
Look, I even don't need assistance. I can do myself like this. Look, I don't need him to wear this. I can do myself. You see?
Yes.
Like this. Okay, scissors.
I think the incision is very nicely placed. It's just front of the.
Yes.
Front of the anastomosis.
Okay, finish. Water.
Very good.
No, don't do it yet.
No, actually.
I'm just anything like it.
Some should inflate. They should.
Never victory before.
There should be no air leak.
There should not be air leak. Yes. I think anastomosis was nice. You can see.
Dr. Diego, do you ever put a patch?
No need. I only put a patch after chemoradiation. In case of chemoradiation, or if I do carinal, yes.
So what patch? Intercostal?
Yeah, no, I do this. I use a flap from here, from thymus.
Or you just take the thymus and flip?
Thymus and flap it, put it here. Jumanji.
Okay, so he's inflating. Anesthetist is inflating?
No, they are doing suction.
So,
Okay.
so it's very essential
Okay.
to ask the anesthetist to do suction.
Yes, you
before
can.
inflate. Because sometimes clots can dislodge and go distally and patient may have.
No, look. Look
atelectasis
this.
in the post.
Be practical. Take this. Okay. In life, you have to be practical. Save time. Time is the most precious thing we have in life. And I lost 5 days of my life in the last week.
Dr. Diego,
Yeah.
if the patient has received radiation, and will you still do a sleeve in a carcinoma?
Yes. I will do.
Any dosage, like more than 60, 65?
No, I did in 60 already in some cases.
Okay.
I mean, because the only choice you have is pneumonectomy, and pneumonectomy is more risky.
Post-op pneumonectomy, And to the anesthesia team, in a patient who has an anastomosis, how will you, do you extubate on table or? keep-
Yes. It depends, I mean, normally we extubate on table because the patient, the anastomosis should not suffer from the ventilation. It's not a good idea. This is a young patient, I think. But depends on the anesthetist choice. But young patient,
Negative pressure breathing, normal breathing is better.
Generally, how many days the patient stays in the hospital in your center?
what?
What is the average stay in the hospital?
Yes. No, in my center, we always extubate the patients, especially sleeps. Because the sleep patient, the mechanical ventilation is not good. So, and this is a young patient, he will be extubated with no problem for sure.
So, what is any post-operative protocol on day one, bronchoscopy for suctioning?
We have to keep some, yes, fuel cell, and we have to keep some antibiotics in these patients, very important.
Okay.
So you can see the anastomosis there. Yeah, it's very good. You can see?
Yeah, so, excellent, you can see the anastomosis now.
There's nothing inside.
Yeah.
So excellent.
Very.
Do all this?
Yeah, it's fine. Okay. Don't, there's nothing inside. It's clear. Yeah, just ventilate. Let's try.
I think the key for sleeves is to, convince your anesthetist to try to extubate the patient. I think that is the biggest thing you can do.
You can do. Yeah, please. Start ventilation. So you can see middle lobe is good.
So all the lungs are in.
Yeah, it's coming up, good. There's no leak.
Excellent demonstration.
Diego, all the entire audience is enthralled with your virtuous performance. I think this is the best beginning from the NCI for organizing the first workshop here with a master like Diego. Thank you, Diego.
Well, the small leak here, I think it's the lung. Can you see?
Thank you.
It's on the lung here.
Dr. Diego, I think India is giving you more gray hairs.
There is more leak here from the lung, but nothing, yeah?
So, do you use digital drain?
Yeah. No, it's very small from here, from the lung. It's here, you see?
Small, very small.
Can you do suction, please? First to be sure. Suction not working.
The lung is nicely expanded.
Yeah, it's a small leak from the suction not working. Here, you see when I press here, stop. It's something from the lung from the lower part when we dissect it here. You see, yeah, from the, it's on the stable line, you see?
Yes.
Yeah. Okay, excellent. We put some chili cell or no need? We put, yeah. Give me more chili cell, yes. Yes.
So one 30 cell, please. 30 cell. And 337 is almost 20. Not 50.
Nothing.
So, any anesthesia you would give?
Can you have from the anesthetist regarding protocol to follow?
Change to the normal.
So for extubation, we'll extubate this patient after putting a supraglottic device. So we're not extubating straight away with a double lumen tube. And under deep plane, we'll extubate or remove the double lumen tube, put a supraglottic device. Again, do a fiber optic scopy, and after reversal, we'll extubate the patient. This is our normal protocol.
What's the postoperative analgesia or regime?
Since we have already put the thoracic epidural, so we'll give continuous infusion of local anesthetic in the post-operative period through epidural catheter.
So what's the stay in the hospital, expected stay?
maybe 2-3 days maximum.
A round of applause for the anesthetist too, please. Thank you. We put half here, We have joint ERAS programs for most of the complex cancer surgeries. So we have a pathway for all cancers, parenchymal, GI, peritoneal surface, hypex. They normally get discharged by day 5, day 4. Even half.
Diego, you were mentioning you want to do biopsy from the lower lobe. You want to do it now? Or?
No, I think not needed. What do you think? I think it's like inflammation. Because the tumor in the CT scan is clearly upper, there's nothing lower. I think it's a chronic thing. Half results, half is half. So we'll put this clean in the camera.
Dr. Raju, what is the post-op protocol? Day 1, what do you do? Do you do an X-ray or on? When do you do your first X-ray?
Generally, we do an X-ray on day 1 and day 2 and day 5. And most of the patients go home day 5, 6.
But,
in contrast to generally we keep for about 5 to 6 days. And most of the period in our hospital, we tend to keep them in the ICU. Generally, we keep them for 3 days. And then he goes to the room. But I think that's varies from center to center. What's your protocol?
I think so. So most of them, we don't send them before.
Yeah,
I don't think in India we need to be that fast track sending them day 1 or something. But we keep them overnight in the ICU, next day morning ward, and then day 4. So we tend to do in the ICU itself within 3 to 4 hours after surgery. Because I found after sleep sometimes they develop atelectasis because of mucus plug. So we are very aggressive on bronchoscopy. So that you don't lose the saved lung. Sleeves and carenals, like always there's a bronchoscopy set by the side of the patient. So I think whenever there is a problem, just suck the mucus out and that's it.
Sure. Okay. Yeah.
Because the incision is small, actually you will see the pain is not that much. Or one more echo.
No need, maybe. I think the biopsy is fine, and no bleeding from there.
Don't open.
No, but no bleeding. Okay, finish.
Actually, the 15mm ports, the rimmed ports which have those, these is so hurtful to the intercostal nerves. Here it's just a
24 is enough.
24,
And we can.
24, please. They've already placed them.
Okay.
They've already placed.
No need. Maybe in next case we can do infiltration on it epidural, because we do intercostal block here to show it's good. We know put epidural and it's good for the patient.
So actually we have stopped putting it. We just put the intercostal blocks. So epidurals.
So we do put epidurals, epidurals, but then we also have choices. We can always put a paravertebral block. Yeah, that works very well. Then also rectospinae blocks are also now very effective. And there's a lot of evidence saying that a rectospinae block is as good as an epidural. And then you get a unilateral block. So, Dr. Nishkar.
Yes,
very good, excellent. Good camera, amazing. No foggy. No foggy one time. No, amazing. Can you hear me?
My teacher also that my yellow and toxicity is much lower because the blood levels are much higher than the top.
So usually we do epidurals because they have been gold standard. We have been doing for ages, and complication is very less. Learning curve is not there because everybody is doing day in day out. Followed by paravertebral oblique rectospinae. And the challenge with rectospinae and paravertebral is we need to put in a catheter. So epidural you put in a catheter, you keep for 3, 4, 5 days. We keep sometimes for a week depending on the need. With ESP and paravertebral, there is a challenge to put in a catheter, especially if you're doing it in initial stages. And then you have to do it bilateral sometimes. So that becomes an issue. So epidural is most easy to handle that way.
all depend, there are always plus and minus for all the modalities of giving analgesia. I think it's for a small incision, we will not need a lot of analgesics. But definitely, we should be very, very careful that we should try to avoid opioid as much as possible to these patients. So that's why we give local anesthetic infusion, so that patient is completely pain-free. They are mobile, maybe after 3-4 hours, they start sitting and they start having their tea and something, and second day they are walking around and there is no pain. And we try to avoid opioid as much as possible. And regarding this epidural and this block and that block, it will all depend on anesthetist to anesthetist. As far as patient is comfortable, I don't think that we should be bothering about, but definitely we should avoid, we should keep patient as much as possible pain-free, and we should avoid opioids.
Thank you, ma'am. So all in all, patient's comfort is most important, because perioperative ambulation will be possible only if the patient is pain-free. And like ma'am said, that we are slowly moving towards opioid-free anesthesia. And it is not just because of the side effect of opioids, but we also have gradually evidences coming up that opioids are responsible, at least at a biochemical level or a theoretical level. And even in animal models, that opioids can lead or at least contribute to recurrence and metastasis. So that is yet to be explored with good strength in humans. But then working with cancer patients, we really need to take care of this. So good ambulation is possible with regional anesthesia techniques, pain management techniques, and to spare and opioid sparing techniques.
Actually, the anesthesia part has improved so much over the last few years. Actually, this patient, if it was done in our hospital, he'll be having chai at 4 p.m. and having dinner in the night. So actually, they keep them so pain-free, and these people can actually have food in the night, walk around, and it's amazing to see what because we have decreased the opioids, like you rightly said, that sensation, the decrease in sensorium, all has gone away.
Right.
They're up and about, they're doing very well, and excellent to see that anesthesia is just doing so well.
Thank you. And it's possible because you are taking lesser incisions. So we are also able to do it. So we have to work together as a team.
Yeah.
As long as you will follow the same protocol, it's not the incision alone. I think the change in our attitude towards that.
It's not the incision, small incision or a big incision. I think if we know that how to make patient pain-free, we will be able to do it. If you know the fundamental, what should we avoid so that patient can be mobile, I think we will be able to do it. So definitely small incision, you will have to give less medication, and you will remain more confident that now patient will not need more. But if there is a big incision, then also patient can remain pain-free, as we are keeping pain-free at IRCH and NNCI.
Yeah, I would like to say here, our policy, Dr. Sushma's department, it's a pain-free policy. Pain-free means even surgeons who have forgotten, a lot of trainees, what is pain? Even during rounds, I stopped asking them. So once my trainees pass out and go back, then they will realize, yes, we have to learn this. So that is the kind of comfort level we have here. We never bother about what is pain, what is the patient, we just operate. So I think that is the kind of thing I was talking yesterday. So they have an official sort of a policy, a pain-free hospital. So that is ingrained in top to bottom, including residents, junior residents. So everybody, no patient should complain of pain. So that is the kind of policy that has been adopted.
So I met one of our alumni, surgical alumni, just in a second I'll tell. Last week, and he came and he told me that, madam, how you are keeping patient pain-free on second, third, fourth post-op. I said, why you want to learn? So he said that because these techniques are not practicing where they are practicing. So it is important that surgeons should know the basics of anesthesia, so that wherever they will go, they can start this practice by their anesthetist. And this will happen only when you will work together.
You're asking us to do epidurals now.
Yeah, actually there are rounds by anesthesia team of all post-op patients, even if they come out of ICU. So there is a round every day, morning and evening. So by the time surgeon comes for rounds, so these issues are already sorted out. So, Dr. Diago, you are done, Dr. Sunil? I think they must be on their way back to auditorium. What we're planning is we'll just have a short inauguration, very short inauguration. Then we'll break for lunch. Then we'll come back for the second feast, the surgical feast, followed by lunch. So we have 2 cases lined up. We'll check with Dr. Diago. I think most of the audience wants to see the subxifoid approach for thymectomy. So we have that case ready, and another sleeve, left sleeve, I think is also ready. So we'll take a call on that. Yes, Dr. Pardon? Yeah, absolutely. We'll continue with all 3, don't worry. So we have everything is ready. So we can continue with all 3 cases also. So we'll just, maybe we can sign off from the OT. Anybody there in the OT team? Yeah. But Sunil, maybe we can ask them to switch off the screen. I would like to thank the chairpersons and the moderators for this wonderful moderation of this session. Thank you, sir.
And at the conclusion, Dr. Sashira from anesthesia has the remark.
Okay, please.
Sir, dear sir.
Yes, please.
And Sushma ma'am, just we would like to take 5 minutes more.
Okay,
Because
sure.
Dr. Balbir is here to just showcase our paperless charting system of the hospital. So just we will introduce only 5 minutes.
Sure. Please go ahead.
Before that, we must have a round of applause for the support personnel, including our staff nurse, nursing staff from the scrub team, Mr. Hemant, all the support staff, including the sanitation, including the technicians, and the entire ground staff of the NCIOT. We are thankful to them. Now over to Dr. Balbir.
So before Dr. Balbir starts this paperless starting system.
Hello, Balbir, just hold on. Dr. Sushma is giving some opening remarks.
This is basically a system which we have at NCI. Means like when you will go to OT, you realize that there is no paper, and whatever we are doing on the screen, and whatever we are doing on the screen, like if I have started 500, 200 ml of, if I have given me 5 for half an hour, or if I have given some blood transfusion on what blood I have given, so it will automatically go to ICU, and ICU person will not have to saturate it. So human error can happen, and we want to be able to over at what is happening in the OT. So the ICU personnel who is there will be able to make sure that what has happened in OT, minute to minute information is there, and this is also connected now with our emergency department. So when emergency department patient is coming in, for example, surgical oncology patient, post-op patient, or medical oncology patient is coming in, they are shifting to ICU. There is no communication with all other time we are not wasting, and there is a good system, and whether you must have heard that is का पूरा net चला गया था पूरा का पूरा because of the cyber attack, but everything has stopped, but this paperless charting system was still working absolutely fine. So this is what we want to, Dr. Balbir wants to show, and Dr. Balbir is a faculty of ours who is responsible for everything. Everything means everything. If there is anything problem, any problem, or sisters are not using, sisters start using paper, then Balbir is answerable that why they are using. So all nursing staff, all doctors, they have to use paperless charting system, and he is improving it day by day, and it has become a fantastic thing to show everyone. Thank you.
Balbir, yes, we can start, please.
Thank you very much, ma'am and sir, for giving me this opportunity. I would like to take.
You are blocking the screen. Please come to side. Yeah.
I would like to take 2 minutes of everyone just to show the screen of this paperless critical care solution monitoring system.
Fine.
And this paperless critical care monitoring system, it provides us the real-time data of this monitor, which include hemodynamic monitoring and ventilator setting, as well as data from the ongoing infusion pumps. So it will automatically fetch it and display it on the screen. And once we will activate this case, this data automatically go to ICU critical care solution, so that we can have a complete data without any loss of data. So it's very useful, as it will enhance our ability to monitor the patient and spending less time on documentation. So it's really useful. Thank you very much.
Thank you, Dr. Balbir. So, Dr. Sunil, we would like to sign off from the OT. Yeah, I think he's already left. Anybody in the OT?
Sir, we can sign up from the OT?
Yes, please ask them to switch off the camera, please.
Okay,
Yeah, so.
Thank you, sir.
So, thank you, Dr. Satyanarayana, thank you. So we'll just have a brief video about MCI, then we're waiting for Dr. Diago to reach the OT, then we start the inauguration, which is going to be very brief. Then we'll break for lunch and come back. Can we run the video?
एम्स नई दिल्ली का राष्ट्रीय कैंसर संस्थान चर्चा सबसे बड़ा कैंसर चिकित्सा शिक्षा एवं अनुसंधान केंद्र है। एनसीआर में वार्षिक 5 लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा। 25 आधुनिक मॉड्यूलर ऑपरेशन थिएटर सुविधाएं। एनसीआर देश का पहला सरकारी अस्पताल है जिसमें 3 एक्सरेटर के अलावा दूरदर्शी चिकित्सा की भी सुविधा होगी। यहाँ 15 करोड़ की लागत से पूर्ण रोबोटिक लैब स्थापित की गई है जिसमें प्रतिदिन 100,000 से अधिक टेस्ट किए जा सकते हैं। भारत सरकार की डिजिटल इंडिया पहल के तहत पेपरलेस क्रिटिकल केयर सिस्टम एवं ओटी इंटीग्रेशन स्थापित की गई है। एनसीआर में 700 करोड़ से अधिक के आधुनिक चिकित्सा उपकरण स्थापित किए जा रहे हैं जिनके माध्यम से व्यापक कैंसर चिकित्सा शिक्षा एवं अनुसंधान किया जाएगा। एम्स नई दिल्ली का राष्ट्रीय कैंसर संस्थान चर्चा भारत का सबसे बड़ा कैंसर चिकित्सा शिक्षा एवं अनुसंधान केंद्र है। एनसीआर में वार्षिक 5 लाख रोगियों के उपचार के लिए 710 बेड का प्रबंध होगा।
Have some background music or anything? Not ready. Okay. Yeah, I think we're just waiting for Diago and Dr. Sunil. Maybe I think they're about to reach. So Dr. Ayappan will continue, don't worry, we have the whole day today. We have prepared our teams. So this is a captive audience. That is one of the advantages of coming to MCI, you cannot escape. So there is no transport. Even if somebody wants to go back, it will take minimum of 1 hour to come back. So nothing to worry. We have actually lined up 4 or 5 cases, so we have 3 standby cases also. But let us start to Diago and take a call. Shivani starts. This auditorium was done by Godrej, the entire Tankri project. It was done by Godrej, including the audio, video integration, interiors, designs, everything. So this is one of the state-of-the-art auditoriums. So there you have to just plug and start audio, video, you don't. So all the fiber optic cables are laid from the theaters to auditoriums, everything is in place. Yes. Giving a small brief about our timelines during the inauguration, so we'll just show that. Yes, please. Yeah. Dr. Rajendra would like to make a small announcement regarding the forthcoming.
So while we are waiting for this inauguration, I thought I'll inform you that every year we also do the main aims a conference in thoracic surgery. And this year we have scheduled it for 24th to 26th March. And it's generally very useful for the residents and practicing surgeons. So we'll just display brochure. And all those who are interested are very welcome to attend that conference. We'll just display the brochure
or distribute few of them, but I think they have given it to the audiovisual team just to display to give you the idea of dates. Thank you very much.
Dr. Chandramohan is here. You want to announce regarding the forthcoming ISO events, I think.
Sir, in fact, very happy to have this meeting here, which is one of the stalwarts events of NCI, and we are so happy to see even this cadaveric workshop was something which is we never attended in the past. The quality of demonstrations are excellent, and today we had a very wonderful opportunity of visiting this NCI, which again is I think the of our cancer care of India, and we are really proud for the organizers and administrators here. And regarding IAS, Indian Association of Surgical Oncology is very happy to associate with a lot of activities. Next week we are having a Midcon in Agra. That too again steered by the team in AIMS with Dr. Dev and all. And please do attend if you are free next weekend in Agra. And the most important event of Indian Oncology Fraternity is the Indian Cancer Congress. This is happening this November 2 to 5 in this meeting will be attended by more than 20,000 delegates, and we'll have nearly 3,000 international delegate faculty coming and demonstrating various aspects of cancer care, not only surgical oncology, but also radiation oncology as well as medical oncology. And please do register for this meeting. And the important attraction of this meeting is there are going to be a lot of scientific presentations and abstracts by young oncologists, and there will be a good number of awards and cash awards and the big awards. Sometimes awards may go up to lakhs of rupees. And please send your abstracts, join the meeting. And also ISO will be having a lot of meetings in future. Also maybe next NATCon will be happening in Bangalore. So please join and please keep listening for ISO announcements and join ISO activities. Thank you, sir.
This is an interesting place. What happened just 1 hour back, there were a lot of fields here. So they were trying to cook lunch for us when they lightened up the whole came and started. So now we have to make a stop there for a moment, but lunch is ready. But it's a beautiful place. I think the Sultanpur Bird Sanctuary is also very close by. So we thought if we have some time in the morning, maybe we can go around. It's 3-4 kilometers. It's a big water, a beautiful sanctuary, around 3 kilometers from here. So this is the one Dr. Rajendra Prasad is announcing right now. Back to back, I think 24th to 26th March. Yeah, I think let's give a big hand to Dr. Diego. So please come this side. So we can start the proceedings of the inauguration ceremony. Dr. Ritu, please.
Thank you very much, sir. We'll now have the inauguration ceremony followed by a small lunch, after which we'll be continuing with the live surgery session. I request the following people to grace the stage for the inauguration. Dr. Sushma Bhatnagar, Head Department of Onco-Anesthesia and Palliative Care and Chief ISCH and NCI. Dr. SVS Dev, Head Department of Surgical Oncology, NCI and Organizing Chairman of the workshop. Dr. Harit Chaturvedi, Senior Surgical Oncologist, Chairman, Max Institute of Cancer Care, ex-President ISO and Oncology Forum. Professor Diego, Dr. Mamada Kar, Director, AIMS Jodhpur and Darbhanga, Dr. Chandra Mohan, Secretary, Indian Association of Surgical Oncology, Dr. Sunil Kumar, Professor, Surgical Oncology, NCI and Post-Director, Dr. Naveen Kumar, Assistant Professor, Surgical Oncology and Organizing Secretary. We will start the ceremony with the blessings of Goddess Saraswati with a Saraswati Vandana, followed by lighting of the lamp. Starting the ceremony with the blessings of Goddess Saraswati with a Saraswati Vandana. Now invite the chairpersons. Lamp lighting for the lamp light. I now invite Professor S.V.S. Dev for the welcome address.
Thank you, Victor. A very good afternoon. This event we have been planning for almost 2 to 3 years. It was getting postponed a number of times. I would like to welcome the dignitaries, the star of the show, Dr. Diego, and all the eminent national faculty, without whom I think this event would not have been possible. And our chief guest, Dr. Sushma, Dr. Harit, and dignitaries of the dais and of the dais.
So basically what I'm going to do in the next 5 minutes, so what you're seeing is, it looks simple, but I'll just give you the brief, what has been, how this institution has come up, what is our vision in 5 minutes. Then maybe we can proceed with the further inaugural ceremony. This will be followed by a felicitation of all the faculty, because I think they are the key for any event. The national faculty, we are very grateful. We'll have a short felicitation ceremony. Can I have the slides? Can I have the PowerPoint, please? So just to, because we have delegates from all corners of India, and a lot of them, this may be first visit to AIIMS or NCI. So we have actually, our mother institution is AIIMS, All India Institute of Medical Sciences, which is in the main city. And we have a cancer center there that is called IRCH. That is where we all started our careers, and NCI was subsequently built as a project of AIIMS. Yesterday, we were at trauma center that is part of main AIIMS. That is where our cadaver lab is located. And this campus is our second campus. This is almost 300 acres campus. The second campus of AIIMS Delhi. And NCI, the first center which has actually started services in the second campus. So why NCI? Because the course background I want to give, the burden of cancer, the thoracic malignancies is grossly underestimated right now in India. If you take lung and esophagus, they are the leading sort of cancers, almost constituting 20% of all the solid tumors in India. Surgical oncology field is evolving by expanding by subspecialty. So there is a need for dedicated workforce for thoracic oncology. And medtech is evolving very rapidly. Clinicians and mid-career surgeons need to update their knowledge and skills. And that's why we have decided to do focused theme-based workshops and courses with the need of the hour. Just like this, you make friends, you learn new things, and which will last in long-lasting bonds, where your life may change sometimes. I've seen sometimes you attend a conference, you meet some people, suddenly there will be an entire change in the course of your careers. So that is why we have decided we should do focused skills, knowledge, and awareness courses related to the field of surgical oncology. Courses on HIPEC, CRS, oncoplastics, this is thoracic, and few others are lined up in future. Department profile, we should know, because we are standing on the shoulders of our giants. This has started, you see, there are challenges of starting surgical oncology, you all know, in specialty hospitals. Standalone cancer centers, the entire challenge is different, like Tata Institute is a huge multi-specialty hospital. So we had almost 2 decades, 2.5 decades of journey of this department. There were no beds and there was no organs when the unit was started. The program started in 91 and joined the department in 1991. From the Department of to start surgical services. 2 beds we started. We slowly built up 2 theaters so they have donated 20 lakhs. With that, we started a 7. Then IRCH was expanded to 75 bedded facility. Now, 82 bed facilities, out of which we got 45 beds in 2005 and 3 operation theaters. 2012 was a turning point for us. That is when we started our MCH program. And 3 more faculty joined, Dr. Sunil, Dr. Devatish. The planning of NCI, that is when the plan for NCI was conceived. When Government of India has asked us plan for
research and treatment in India. So that is when we were asked to prepare a proposal. 2019 was the time during which we got the various approvals for this project. The land was given by Haryana government at that time to AIIMS. This was lying vacant, and almost 3 to 4 years to cross the bureaucratic. 15 and 16, I will show the timelines that is when this project. Construction was completed in record time for the government project. By 18, everything was ready. At 19, we started soft launches and services were started in 2019. Our department from 88, if you see, started with 1 faculty, no residents. Now we have 13 faculty, 30 residents, a strong surgical oncology training program, a total bed strength of 120 beds for surgical oncology exclusive. We run 7 tables every day, almost 35 tables a week. Approximately we're touching 3,500 to 4,000 major cancer surgeries together at IRCH and NCI. And we have a huge database of a unique project of our department, which has more than 20,000 patients. And 50 research projects. We are embarking on organ-based surgical oncology programs. Most of our faculty in 2012 are pursuing organ-based oncology. Of course, it is not possible. Thoracic surgical oncology program, because it is relevant for this conference, is given by Professor Sunil Kumar. It's a very quite low-key but solid and strongly committed number 2 for me. He's built up this department over the last 7-8 years. The true multidisciplinary thoracic oncology program is developed in collaboration with medical radiation. We have who is involved in this program, cardiothoracic surgery is involved. We do a lot of complex cardiac surgeries and pulmonary surgeries with cardiothoracic. We have a theater there where he goes and operates. So we have, as part of this program, we have basics, VATS, advanced collaborative work with cardiothoracic also. And onco anesthesia, I cannot neglect, I've been telling. So this is one thing I would like to say for all the surgeons and anesthetists. It is like a relationship between a wife and husband. All right, whether you like it or you hate it, you have to live together for your entire life. Every day morning you have to see each other, both the anesthetists and surgeons. So we have seen sort of cultures that were there 20-30 years back. So a lot of fighting going on between surgeons and anesthetists, cases getting cancelled. So we have decided maybe 25 years back with Dr. Sushma that we will change this culture and develop a very friendly sort of relationship, supportive relationship, and a unique program. So that is where we started our journeys together. Now I am very proud to say this department is one of the leading lights of NCI, and also they have done some unique achievements by starting DM Oncology, Onco Anesthesia course, the first time in India. They are also running MD Palliative Medicine, and they are providing comprehensive perioperative care, including anesthesia, pain, critical care. I would like to give them a big hand to the audience. Coming to NCI, we have seen the video, the scale of the project you have seen. The budget allocation is around 2,000 crores for this, 700 beds exclusively for oncology. Almost 3,000 plus career opportunities once it's fully functional. The main focus here is on research. I will just show you what we are planning. So this was the initial layout of the NCI. We thought it should be a comprehensive center, connected. The clinical services should seamlessly connect with the research services. That's why there is a bridge connecting all the blocks. If you see the NCI building, we did not want any physical barriers between specialties or between sciences or basic sciences or clinical sciences. So that is the only way to grow in the field like oncology. This is the kind of scope of the project. It's almost 2.5 lakh square meter built up area, fully paperless ICU. It's a full automated robotic lab. You must visit that. Proton is coming soon. 25 operation theaters, PET scanners, MRIs, linear accelerators. We are also planning an intraoperative radiotherapy facility in the phase 2. We have a dedicated onco emergency division, 50 bedded ICU, which is functional already.
20-bedded nuclear medicine, bone marrow transplant, and we are expecting to see almost 5 lakh patients, the total visits in the next 2 or 3 years, including new and old. Right now, we see in Delhi, almost 20,000 new cancer patients are seen. I'm in charge of cancer registry. So 20 to 22,000 new patients are registered every year in Delhi, out of which 50% are seen by IRCH and MCA, almost 12,000 new cancer patients. Our aims and objectives when NCA was conceived, it is to act as a principal agency of the country for promoting, coordinating, and conducting innovative research and development of novel interventions for cancer, provide affordable quality care to cancer. So that is another sort of our aims. With best of care, we can provide at affordable prices, top quality care. Capacity building is our main aim because we need trained manpower. That is what I think will drive any institution is recognized not by the stalwarts who are working there, but the alumni or the kind of students you are producing for the future. Translational research, of course, is one of our main aims of this center. So we are in the process of setting up basic sciences labs, the genetics, molecular biology, the anti-spectrum proteomics, genomics is going to be done. It is just started because there was a lot of pressure on us to start clinical services. So we are lagging behind in the research, but we will catch up soon. These are the current various specialties which are already working. There's a lot of young faculty in the audience. They are the backbone of running this center. We have young faculty, fantastic opportunity they've got. They have got the freedom, they've got the money, they've got the support to lead these programs and to put in place one of the best sort of facilities. You should go to our blood bank, our services, you go to our radiation facilities, all managed by young faculty, dynamic faculty. We just stand back and support them. So most of the facilities are already functional here out of these 15 departments. And one of the best I would like to say is our hospital administration, led by again a young team of Sheetal, Dr. Tej. They are the backbone. The entire show how it is running in the hospital. I think, yeah. So I think they are the real stars to run the entire such a huge campus. They're just fresh assistant professors. They handle everything here. Patient care model also, we wanted to have a unique model here. It is a patient-centric multidisciplinary team approach. We don't have any clinics based on the names of individuals or specialties. It's all organ-based clinics with the disease management groups. A group of experts will manage particular cancer like the TMH model, but we are also including basic scientists also in this research DMG groups. And we have already started theme-based clinics like cancer genetics, preventive oncology is doing, Dr. Raju is here, Dr. Jitendra is here, another 2 of our bright stars. We are doing fantastic preventive oncology work, going to rural parts of Haryana from this center and setting up a beautiful model for preventive oncology in India, which I think is the need of the hour. And we are also working at integrated clinics because the government's aim is to integrate the traditional Indian medicine. So we are also running a clinic, Ayush clinic here along with our Ayush division. The special programs which we have started is bone marrow registry transplantation, oncocritical care, proton therapy is coming up. Minimally invasive has started, robotic is going to take a little while. IORT, palliative care is integrated here. So from day one, there is a physician who takes care of palliative needs of the cancer patient here. Special and advanced programs we have already discussed. Another unique planning which we are doing is to have state-of-the-art skills and research lab for surgeons, a dedicated research lab, which will have experimental surgery, device development, digital surgery lab, artificial intelligence, virtual reality, minimal access, core surgical skills. We have actually conceptualized, we have prepared a plan. We are about to start the work on this project. And biobanking is also going to be one of the major components of our center, biobanking. So the current ongoing programs, we have various MD, DM, MCH programs, fellowships, organ-based fellowships, everything is in place. I'm happy to announce the surgical oncology is going to start fellowships in thoracic surgical oncology, dedicated program. It is under approval right now, and one peritoneal surface and one breast oncology. So the timelines, this is when the first Bhumi Pujan was done in 2015. This was just a green field. Only the paddy fields were there, nothing else. Then phase 1 was dedicated by 2019. It was completed in 3.5 to 4 years time. The Prime Minister, Honorable Prime Minister Narendra Modi dedicated this center in February 2009 for phase 1 services. So this is when we used to come when this campus was like this. This was in 2016. Here you can see there are some residents also. That is the kind of involvement. And the faculty, we used to come and develop this center, and we used to take their inputs in the planning, how the OT should be built, how the patient flow should be there. Everybody was involved, including the sketching. So this is one of those unique projects where the users were involved from the beginning. Otherwise, what is done is you just built a center without taking the inputs from the real users, and something is given to you, and after that you'll spend another 10 years to get it according to your needs. So this is when we were visiting this center, when it was coming up in 2016 and 17. You can see here, Dr. Shushma is here, myself, Dr. Anuja, Ashutosh. So this is how this project was brought step by step. By 18, most of the construction was complete. Buildings were taking shape. And this is end of 2018. We started installing equipments. That was another big challenge here. A lot of expensive equipment we have to procure between 2017 and 18, and this we could install by 2019. Most of the systems were in place. These were the pictures which were taken during our inaugurations. We started soft inauguration, huge project. It cannot be started in one day. It takes years and years of hard work. So we started one by one theater to begin with, 10 beds to begin with, established good models. Then slowly we started scaling up. These were theaters. We can see some visitors coming. Dr. Chandra R.A. from Society of Surgical Oncology also visited here. And these were the hospital block inauguration by the director, Dr. Professor Guleria. And we did our own inaugurations. Whenever we are here, we used to call all the staff. We used to do today, okay, आज ये वार्ड ठीक है, आज शुरू कर देते हैं. कल ये OT ठीक लग रहा है, चलो कल इधर ऑपरेशन शुरू हो जाएगा. Then we started this sort of soft inaugurations. Everybody is telling, sir, ये नहीं है, वो नहीं है, CSSD नहीं है, blood bank नहीं हुआ, specimens कैसे जाएगा? We said we'll manage. So somewhere you have to start. So I would like to compliment all the residents and all the supportive staff. So without them, this would not have been possible. So working here in a far off place without any transport or communication. So it's a fantastic journey we had. This is our core lab, our ICU. This is our first surgery we did, the historical photograph at MCI. We did a simple case in the ground floor OT. This is our endoscopy services. We started again endoscopy services. The main OT will take some more time. So we started stopgap endoscopies for all cancer patients in the hospital block. This is our PET scan facility, PET scan facilities in nuclear medicine. And other, I think, unknown fact is this hospital was the hub for during COVID pandemic. Dr. Shushma and her team did a phenomenal job here. They treated almost 6,000 COVID patients, 6,000 COVID patients. So our cancer services were started after 3-4 months. This COVID has hit. We have to stop all the oncology services. Entire AIMS, the COVID load was put on NCI. So all these guest houses, everything was launched in a hurry. Sometimes these things help you in propel your, making your hospital functional. So suddenly all the guest houses, all residential complex became functional because of COVID within a very short span of time. So the entire campus was full. 2021, again, we cooled off from COVID. Then again, we started bringing back oncology services. So these are the statistics. You can see how we are growing slowly over a period of time. There are a lot of challenges, but I'm sure we'll overcome them. So currently we are seeing almost 5,000 new cancer patients. A lot of surgeries are being done. Radiation is being done. And you can go and see our outpatient departments, a lot of footfalls currently. This slide is very interesting. I think
For everything, if you want to achieve excellence, I think it is the passion and commitment. Passion and commitment, which is not, I think, every institution or every specialty or every program, if you don't have these two qualities, it's not possible. So this is the motto of Diego, okay? Nothing is impossible. He has written a book, you can buy in Amazon. So I was reading his biography last week, how he started his career. In 2007, he challenged the standard paradigms of thoracic oncology surgery, and he turned it head on and showed a new way. So that is what I feel is the sort of a passion and commitment. Everything is possible, nothing is impossible. So you all must, all the trainees, I request you should read this book and read the biography of Dr. Diego. So the kind of enthusiasm, energy, passion, and commitment. So these four qualities will make anything possible, whatever may be the hurdle. So this is, I would like to give Dr. Diego a big compliment. We all have to learn a lot. Thank you, Dr. Diego. This is the, I think, article you all should read about his journey, where he started and where he has reached. So we also enjoy our life because it's not always work. We need to maintain a work-life balance. This is our team. Recently, we had a cricket match led by Naveen and Jyoti, two captains. I don't know who has won ultimately. So, and we also have a good break. So we work like a family here. So with that, I think this is the background I wanted to give to everyone. Since morning, everybody was telling it's a fantastic setup. A lot of good things are being done. But the journey, if you see, the department is almost 25 years it took to reach this stage, and NCI is almost 10 years. So the message is there are no shortcuts to success. You have to work hard. So with that, I would like to conclude my welcome address. This is the background of the institution, the department, and the program. I'm sure you had a wonderful time yesterday in the cadaver course, and today this is a short break we are taking, and we'll get back to our live show again post lunch. I'm sure you are going to have a wonderful time. We have a social night today, followed by dinner at NCI, and tomorrow we are going to wind up by lunchtime. Thank you very much.
Thank you, sir. I now invite Professor Sunil Kumar for the course introduction.
You go to cadaver first, followed by seeing the master, and then recall whatever you had so far, try it on a model. So we are on the second phase. Today we are having the live surgeries. Yesterday, everybody attended the cadaver program, and I am sure if you combine the experiences today and yesterday, things will be much in place. Tomorrow we have the simulator session. Today also, those who are interested, after 4 p.m., the intuitive vehicle is there downstairs, and anyone who is interested, we will be putting in the group anyway the list just to organize the things, but this is for tomorrow. Today also you can visit and enjoy that session. Regarding the next part, because what you just witnessed is much of that is a combination of not only a skill, but also of technology. So unless we are versatile with that, probably this is not going to be optimum. So we are thankful to Panther as well as the Olympus system, who have provided the visual backup of the transmission as well as the live surgery. So there will be some presentation from Olympus regarding the upcoming technology, because this is what we are going to hear and see in future as well. Learning never ends. For many of you, it might be just a beginning. So for some of you, it may be on the middle of the path where you wanted to be. And for some of them, it may be some refinement, particularly through the live surgery. So, but ultimately, at the end of the day, if you take something on to propel yourself on the path of thoracic surgery, I'll think that our effort will be fruitful. Thank you very much.
We would like to go forward with a few words of wisdom by our Chief, Dr. Shushma Bhatnagar ma'am.
So good afternoon and welcome to NCI. Dignitaries of the dais and my friends. We have heard a lot that we can do a lot over a cup of tea. And we can say what we have not been able to say over a cup of tea. But I can say that over a cup of tea, we can do wonders. And this I will tell you how we have done over a cup of tea wonders. So as Dr. Dev has said that shown the journey. When I came first time 25 years back, I thought that how I will work only twice a week, OT, Monday and Thursday, with only 2 surgeons and there are no residents and all. But when we met Dr. Shukla and Dr. Dev, and when we started working, I think the way we have thought and the way we have worked, it's an example to we should be working. There is not a single day when we don't have cup of tea together. Only when we are not in Delhi, then only we miss our tea. But when we have tea together, it's not that we are talking something, but I have a list of problems and Dr. Dev has a list of problems that these are the problems we are facing in development of. Initially, we used to think of surgical oncology and onco-anesthesia, but now we discuss what are the problems we are facing in development of IRCH and NCI. And immediately, I'm telling you, cup of tea is this much only tea, but we find out a solution. And this solution includes handling a lot of politics, handling a lot of government rules, handling a lot of issues which are unacceptable and unavoidable, but we find out a solution. And we also discuss how to boost morale of our junior colleagues. And you must have seen that all the juniors, the way they are working in the operation theater, and when the way Sunil, Sachidanand, Seema, and everybody has developed, they are the backbone, and they have now already, we have made the successor planning. So we also discussed that, oh, this person is feeling low in these days, how to make his morale, what are the problems he's facing. This is the way we discuss and we find out the solution. So I have given an example that a cup of tea can do miracles. I'm not giving you something which is very difficult, but you have to find out your colleagues wherever you are, who is your person who can be an open-minded and can discuss problems and can just find out solution. And we can do miracles with only for 15 minutes and half an hour. And it is day-to-day audit what is happening around in our departments. And I can say that because surgical oncology is developing, onco-anesthesia was also developing. So we have not seen that our department should develop. We have seen that both the departments should develop. And you must have realized that onco-anesthesia, DM onco-anesthesia was first in, not even in India, it is in the world. When Dr. Vijaya from MD Anderson came and asked me that how you have started a dedicated course on onco-anesthesia, because we were unable to convince our colleagues or about this thing that there is a dedicated course of onco-anesthesia is required. And I still remember that for 7 years I used to roam around with the files, and every day I used to come and over a cup of tea I used to throw in the either my room or Dr. Dev's room, that nobody is listening, nobody is understanding that why it is required. And finally one day it has happened in 2016, and now when we see that all over India surgical oncologists and onco-anesthetists are there, and when we hear their feedback, I think we feel so proud that they are doing with the same zeal and same enthusiasm. We have made the rules, not a single case will be cancelled. We have made the rules, not a single case will be unfit, and we have made the rules that there is no limit of working hours. We start our OT 8 o'clock, but we have no limit that when we will go back. So this is, you know, we were fortunate that this technique of whatever policies and protocol we have made, it is going on, and wherever our residents are going, they are doing wonders and they are making us proud. And I'm really very happy to say that a cup of tea can do miracles. And please do this in wherever you are. And this is the way kind of, you know, developing from one faculty and 3 residents and 2 faculty and 3 residents, developing huge whole department of onco anesthesia with 14 faculty and 67 residents we have. So I think we can do everything if we will have a good coordination, mutual understanding, mutual respect, because most of the time what we have seen that anesthetists are not respected and not rewarded as much as they should be. But I'm not saying because I'm an anesthetist, you should respect me, but if anesthetists will work properly, I think automatically they will achieve and they will earn respect. And I always say that it is, you have to earn respect, you have to show and you have to prove that you are important for the patient, for the hospital. And this is the way we have worked. And I have given the example that what we have worked. I'm really, really happy. And I really wish about this course is going to be very, very successful. I have already told Dr. Dev that short courses are very, very successful, and especially when people like Sunil and Naveen and they are leading the course under the supervision of Dr. Dev, it has to be very, very successful. And we are already hearing that yesterday's workshop was very good. Today's we have seen that first course, and Dr. Dev forgot about the Dr. Diego, that, you know, he was not getting visa and he was not getting, nothing is impossible. I think this is an example that nothing is impossible, because, you know, 2 days back, you must have received a message from Sunil that Dr. Diego is not coming. But, you know, today is here. So nothing is impossible. He was in the embassy and then Dr. Dev worked here from here and finally he came. So nothing is impossible when we are working together, when we have a mutual respect, when we have understanding, and when we know how to find out a solution. The most important thing, how we are respecting our junior colleagues, how we are respecting our staff and even as sanitary staff, and even every staff is very, very important, and everybody has a place for their own. And I'm really proud that the way NCI is developing with our help of our junior most faculty, they are working here, and senior people are coming and supervising over here with the help of hospital administration. The way NCI is developing with definite or strict protocol and policies, I think within no time, it is going to be a hospital which everyone from the whole world would like to see this hospital and come and like to visit this hospital. Thank you very much, and congratulations, Dr. Dev, and everyone, those who are involved.
Thank you, ma'am. I now invite Dr. Harit Chaturvedi to say a few words.
Thank you very much. Thank you, Dr. Dev and Dr. Sushma, for having me here. And I want to say that actually I've seen this whole journey, this family blossom in front of our eyes from a very close distance. And you've not just made this institution, actually you have impacted the whole NCR and the country in a very big way. Because this big-hearted approach and generosity actually influences a lot of minds and leads to a lot of growth in the professional space. I really want to thank you for this. And as you said, nothing is impossible. I think no better example than Professor Diego. I think he has not just turned thoracic surgery upside down and changed the whole perspective towards it. He has become a global teacher and a global citizen. The way he travels, the kind of energy and passion he carries, it is so infectious and so inspiring that even at 60, I feel that different stages of life still at this point, I feel that so much more to do and so much has to be done. And he has really inspired me at this age. So I'm sure everybody in this hall will go out as a better person to try to do more and better for the larger society and also for the professional space. Sharing so much and helping so many people grow is really inspiring. So thank you very much, Professor Diego, to be here. And thank you all. Thank you.
Thank you, sir. I now invite Dr. Madhav Anandkar if he could share a few words of wisdom with us.
Good afternoon, sir. My teacher, Dr. Dev, Sushma Madam, Dr. Diego, Sunil, Naveen and Chandramohan and my colleagues. I felt fortunate that I am here in front of my teachers. I achieved this much. This is how we have trained in this institution when it is started like a single unit. I was here in 98 to 2007. That time, I shared so many things with Dr. Dev has shared with me. I remember one thing I always share. He was telling that this IRCH, I started, so many people are discouraging that time that IRCH name was Institute of Recreation and Caricature Home. People are like doing those so merrymaking, but this, I congratulate sir and bow to him that they created this IRCH created this institution, which are so inspiring and so proud moment for us and all alumni also. And now that inspiration and that education has made me so task challenging, taking the task, challenging task to my heart. That's I now leading to AIMS. Like one is making Darbhanga AIMS starting from zero, and another heading Jodhpur. Behind that, this all planning, I always also tell my students there also, Dr. Dev's dictum, that if you fail to plan, you already plan to fail. That is the basic things. That's why in every way, this is a life. I have adapted these things, and I am now feeling that nothing is impossible. What Diego has written and Dr. Dev highlighted, I am not telling more of things. I just think fortunate that this institute starts with the most challenging, like thoracic surgery. So first time started here, and that is very thoracic surgery, also very close to my heart. And I have done my fellowship also in thoracic surgery. We started a lot of cases here. And this IRCH dictum like anesthesia and surgical oncology working like a family, we cannot replicate everywhere. I tried a lot in Bhubaneswar also. This is very, very impossible. I don't think everywhere it may be like that. And everyone wants that type of that atmosphere, but very difficult, very difficult. That's like, that's why so much my admiration to Dr. Sushma Madam. And when she joined, I joined that time resident, she joined the faculty, and she changed the whole concept of anesthesia in whole AIMS, not in AIMS, the whole country. Started onco anesthesia here, then TMS started, then everywhere now the surgeons are demanding that onco anesthesia we need. There's that working together, it can change everything. That's why, sir, I congratulate you and congratulate this IRCS team, especially Sunil, to start this thoracic oncology, and this is all the best for the taking it to next level. Thank you all. Thank you.
I now request Dr. Chandramohan to share few words.
Thank you. Dignitaries, honor of the dais, or representing IASO, I like to share a few words. Today, witnessing this meeting and workshop here, we have a hero, Dr. Diago, who had done a wonderful job in a tough case. I think that we all of us appreciated. At the same time, after this meeting started, we also started realizing some other heroes who built up this prestigious institution and leading the cancer care of the country. Dr. Sushma, Dr. Dev, Dr. Madhavandakar, Dr. Sunil. And what I feel is a good center in Delhi is very important, not only for the people of Delhi, but also for the nation in total, because many policies of the government are decided by the input from these people. And I used to know Dr. G.K. Rath very well, and he was pretty much there in all decisions, all selection processes which happen all across country, including my institutes. So whichever decisions he took correctly in selecting good people as our directors, we were benefited. Whatever mistakes he did in selecting bad people, we suffered. So I think your role is very big sitting in Delhi. And I'm so happy that the people who truly believe in surgical care, team approach, camaraderie and friendship, they are leading the National Institute of India. And I'm definitely happy that, our nation is going to benefit it because of them. Not only because of the role modeling they provide here by increasing increase the standard of cancer care of the country, by putting across, for example, in this meeting, they are putting across a concept of organ-based approach in cancer care, an approach of MDT, and these things are very important. I hope that they can lead us, they can give good input to the government of India in deciding policies. They can join us in improving our cancer care all across the country. And thank you very much. And as part of IASO, IASO will be part of your journey. Thank you very much.
Thank you, sir. I now invite Professor Diago to share his experience and few words of wisdom with us.
Well, first of all, I want to thank the AIMS institution, the chief, all the members of the team, also Dr. Sunil for inviting me for organize this amazing masterclass, this amazing workshop that combines the three best elements for learning that are cadaver lab. You can practice the technique in the cadaver lab with a fresh cadaver. I was really impressed about the quality of the cadaver. I have been performing these courses all over the world. I did cadaver lab many times in many countries, United States, UK, Europe, but I can say that this is the best quality of the cadaver. This is the same quality we have in Lisbon. We have a similar quality in Lisbon, and I think it's really good because this is the best way of learning. You can have also animal lab, but I think cadaver lab with this quality of cadaver is the best because you have the same movements, you have the same structures as you have in a patient. So definitely high class. And also the part of the interaction with lab surgery, with cases, with direct communication. You can see the venue, you can see the screen, the live surgery with 2 screens, really amazing. I think I can say top, one of the best live transmissions I ever seen. And the third part that will be lectures, interactions. Tomorrow we can share experiences with any kind of topics. So what we can say that this is one of the best workshops in thoracic surgery we can organize. So thank you for inviting me. Thank you for organizing. Thank you all of you for coming from far away. A special thanks for the help for being this possible, because some problems with the visa, with things that we didn't know that it working that way, human mistakes, and then now it was solved something. So thank you very much, and I hope to continue this collaboration. We are planning to have this annually. I think will be a good communication to stay annually doing this course, to continue improving the technique and to sharing the passion and the knowledge with you. Thank you.
Thank you, sir. I now invite Dr. Naveen Kumar to give vote of thanks.
Thank you, everyone. And thanks to all the dignitaries of the dais and of the dais. And a special thanks to our teachers here. And my special thanks to Professor Diago and all the faculties who have conducted the cadaveric workshop as well as live workshops. This means a good, and I think all of you have taken the good feedbacks also. So the thing is that, and a special thanks to our delegates, because it was not possible without their supports and their presence here. And my special thanks to Professor Dev and Professor Sunil, because they have mentored us, guidance, and given the guidance for conducting this workshop here. And the special thanks to our residents and the colleagues who are working hard to make
this is a grand success. And a special thanks to our NCI team, administration team, who have supported us in terms of all the logistics and as well as hospitality here. And they have supported us in a nice way. And special thanks to our sponsorship partners, Olympus and Panthers, who have supported us for the cadaver lab as well as in the live surgery workshop, for the live surgery workshops. And thanks to our OT staff team, technician team, who are working hard for last 1 month to make it a very to make it a good grand success for this live surgery workshops. Again, thanks to all of you, and thank you very much.
We will now have a small felicitation ceremony for all the esteemed faculty that have participated in this workshop and given us their valuable time and knowledge. The faculty will be called in alphabetical order. First, we have Dr. Aman Sharma with us, consultant radiation oncology in NCI.
Because we have running short of time, we'll keep calling the names. Please come on the dais quickly.
Dr. Amitabh Mandal, Assistant Professor, Surgical Oncology, IRCH and NCI. Dr. Atul Sanaya, Consultant Surgical Oncology from Bhopal. Dr. Babul Bansal, Assistant Professor, Surgical Oncology, IRCH and NCI. Dr. Bhushan Thumbare, Thoracic Surgeon from Max Ghaziabad. Dr. Brajesh, Assistant Professor, Onco Anesthesia and Palliative Medicine. Dr. Caleb Harris, Head of Department Surgical Oncology, NICRIMS Shillong. Dr. Chandra Mohan, Secretary IASO. Dr. Harit Chaturvedi, Senior Surgical Oncologist and Chairman of Max Institute of Cancer Care. Dr. Jeevan Vishnoi, Surgical Oncologist from AIIMS Jodhpur. Dr. Jyoti Sharma, Assistant Professor, Surgical Oncology, IRCH and NCI. Dr. KVVN Raju, Senior Consultant Surgical Oncology from Hyderabad. Professor MD Ray, Professor Surgical Oncology, IRCH and NCI. Dr. Anuja Pandit, Assistant Professor, Onco Anesthesia and Palliative Medicine. Professor Madhavanand Kar, Director, AIIMS Jodhpur and Darbhanga. Dr. Manish Gaur, Assistant Professor, IRCH and NCI. Dr. Manjunath Bale, Thoracic Surgeon from Hyderabad. Dr. Mohit Sharma, Head of Department Surgical Oncology in GCRI. Dr. Nishkash Gupta, Professor, Onco Anesthesia and Palliative Medicine. Dr. Pallavi Purwa, Thoracic Surgeon from National Institute of Tuberculosis. Dr. Prabhat Malik, Consultant Medical Oncology, IRCH AIIMS. Dr. Pradeep Jaiswal, Surgical Oncologist from RNR Hospital, New Delhi. Dr. Prashant Penumadu, Consultant Surgical Oncology from Jipmer, Pondicherry. Dr. Prashant Siroya, Consultant Onco Anesthesia and Palliative Medicine. Dr. Raghav Gupta, Assistant Professor, Onco-Anesthesia and Palliative Medicine. Professor Rajendra Prasad, renowned thoracic surgeon in AIIMS, New Delhi. Dr. Rudra P. Acharya, thoracic surgeon from New Delhi. Dr. Sachinandan G. Bharti, Professor, Onco-Anesthesia and Palliative Medicine. Dr. Sandeep Boriwal, Consultant Surgical Oncology, AIIMS, New Delhi. Dr. Sarvana Rajamanikam, Senior Surgical Oncologist from Tamil Nadu. Dr. Saurabh Vig, Assistant Professor, Onco-Anesthesia and Palliative Medicine. Professor Seema Mishra, Consultant, Onco-Anesthesia and Palliative Medicine. Dr. Shiv Rajan, Associate Professor, Surgical Oncology from KGMC, Lucknow. Dr. Shoaib Zaidi, Surgical Oncologist from Apollo Hospital, New Delhi. Dr. Shubham Jain, Surgical Oncologist from Manipal Hospital, New Delhi. Dr. Shubham Garg, Surgical Oncologist from Fortis Hospital, Noida. Dr. Siddharth Hazarika, Thoracic Oncosurgeon from Guwahati. Dr. Ashutosh Mishra, Consultant Surgical Oncology, IRCH and NCI. Dr. Balbir, Consultant, Onco-Anesthesia and Palliative Medicine. Dr. Shweta, Consultant, Onco-Anesthesia and Palliative Medicine. With this, we come to the end of the inauguration ceremony. Lunch is ready outside. We can take a short break and then we'll resume with the live surgery session. We have the second case ready in the OT.
We'll break for lunch and what time, Dr. Sunil? Half an hour lunch break? Huh?
So the anesthesia team has already started working on the case and both the cases are ready. So
I haven't recognized you. Today I recognize when they call you. Yes, sir, I will be looking you and support over there. आपका अपना कोई केस होगा एक फोटो ले लो
male patient but very thin bit like me.
Hello, Dr. Sheetal, Dr. Tej, Rahul. बहुत सारे हैं, बहुत सारे हैं।
This for you as well as you have a special one as well.
Sunil sir, just have a.
उसको ना सिर्फ टिक करके कूपन पकड़ा दो, प्लीज कलेक्ट योर कूपन, वहाँ बोल दो कि आप कूपन कलेक्ट कर लो, सिर्फ फैकल्टीज हैं वहाँ से कलेक्ट, आपके उसमें वो टिक करता जाएगा, वहाँ पे लिखे हुए हैं नाम। इसके लिए सर एक बार हो जाए कंपनी वालों को एक साथ, हाँ वो हो जाएगा।
सभी लोग कैसे लग रहा था So can I request our department to have a group photograph on the stage, please? All the faculty. No. हाँ बुला लो. Can I request all the residents and faculty of Department of Surgical Oncology to please come on the stage for a group photograph? Good afternoon, everyone. We will now be starting with the second session of the live surgery workshop. So I request all of you to collect back in the auditorium so that we can start. Good afternoon, everyone. We will now start with the second session in the live surgery workshop. Good afternoon, everyone. I request everyone to collect back in the auditorium so that we can start with the second session in the live surgery workshop. As chairpersons of the next session, I request Dr. Harit Chaturvedi, Chairman, Max Institute of Cancer Care and ex-President IASO, to come for chairing the session. Professor Rajendra Prasad, renowned thoracic surgeon and faculty of surgery, AIIMS, New Delhi, and Dr. Siddharth Hazarika, thoracic oncosurgeon, Guwahati, Assam, to also requested to chair the session. Hello? Can the OT team hear me?
Yes, we can hear you, ma'am. Hello, auditorium?
Yes, we can hear you.
Yes, ma'am.
Okay, then what is the status of the OT at the moment?
Hello, hello.
Good afternoon, ma'am.
Good afternoon. Shivani?
Yes, ma'am.
Okay. We
Okay,
just,
ma'am.
we are preparing the case. We are positioning the patient right now.
All right, ma'am.
Okay, intubation, everything is being done. Just maybe another 5 to 10 minutes, 10 minutes.
Sure, ma'am, sure. The chairpersons have joined us on stage. Dr. Harit and Dr. Siddharth Hazarika have joined us on stage.
Sure. Oh.
Okay, we'll request the moderators to please join us on the stage. Dr. Shubham Garg, surgical oncologist from Fortis Hospital, Noida, and Dr. Bhushan Thombare, thoracic surgical oncologist at Max. He's not there right now. And Dr. Shoaib Zaidi, surgical oncologist at Indraprastha Apollo Hospital. And Dr. Raghav Gupta, Assistant Professor, Department of Onco Anesthesia and Palliative Care. Okay. So instead of Dr. Raghav, Dr. Nishkarsh will come. Dr. Nishkarsh Gupta. Dr. Zaidi. You tell us about the case? Yeah.
Yes, sir.
Can you please connect to the OT?
Sir, वो OT से translation.
Yes.
Hello.
Ma'am, can we have a summary of the case, please?
Hello.
Hello.
Yes, Shivani.
Ma'am, can we have a summary of the case?
Sure. Can you see our slides?
Yes, ma'am, slides are visible.
So I'll just give a brief summary of this, the second case of ours, 57-year-old male, and who is from UP. He presented to us with the cough and hemoptysis. Cough and hemoptysis of 7 months duration, and patient has significant history of cardiovascular disease. He has a triple valve disease for which he underwent CABG on January last year, and also has a history of pulmonary tuberculosis for which he has taken anti-tubercular treatment, and also a known case of hypertension for 20 years. So it's a challenging case because known case of TB as well as undergoing CABG. Then he was diagnosed with squamous cell carcinoma of the left left upper lobe involving the main bronchus and the pulmonary artery. And he received neoadjuvant chemotherapy, 3 cycles of paclitaxel and cisplatin, which he finished on 26th of December last year. Patient was on clopidogrel, which which was stopped around 5 days back. He's also another treatment for hypertension. On examination, no significant findings. He has a good PS, ECOG1. On CT scan, which was before chemotherapy, there was a mass of around 2.8 centimeter and 3.4 centimeter into 4 centimeter in the perihilar region, extending to left main bronchus, which was around 3 centimeter from the carina. The left hilar nodes were involved, and there were fibrotic changes in the lungula. There were also some fibrotic changes in the right lung as well, post tubercular sequelae. So good, the PFT was all right. and no significant changes on the echo. CPET was run, which is 17.4 ml per minute per kg. Okay, you can see. So the patient is ready right now. The patient is positioned in the left lateral decubitus position.
Can we see the images, CT images?
Yeah, CT images, just a minute, we'll display the CT images.
Audio is not working from it.
On off कर दीजिए.
Can we check the audio from theater?
Sir, we have put the CT images of this patient. These are the post-chemo images. I'll just show the pre-chemo picture of this patient. So this is the left hilar mass, as you can see here. I'm just pointing it out. So it was involving the main pulmonary artery before chemotherapy. And this is the post-chemo. Okay. So patient has a good response post chemotherapy, but still there is a thickening in the hilum at present.
Yeah.
Yeah.
Right? Yes, we can do. Can I speak here? So what is, so the tumor was on the left main bronchus extending to the left upper, so we have to cut the left main, we have to cut the left lower, and we'll see what happened with the pulmonary artery. I think we have to control the left main PA from the beginning, because maybe we have to do arterioplasty. Okay, so challenging case. So probably what we are looking at is a double sleeve. Maybe. Or maybe just bronchobascular. No total double sleeve. Yes, bronchoplasty and maybe vasculoplasty, not double sleeve, not complete. Just cut and switch. Maybe, we'll see. Can we put this higher? Can we put this? Manu, this a little bit higher, move this higher.
Yeah.
Very well.
So is CTRT an option for such a patient?
No. Okay. Why the patient have a tube?
Bypass.
Oh,
This patient already received chemotherapy.
My God.
And this is post-neoadjuvant status.
So the patient has previous sternotomy.
Yes. So initial plan was chemo followed by surgery.
It's going to be very dangerous case. Because with chemo and the sternotomy, maybe the graph is there.
Hello. I think so probably the post CABG Lima already with the graphs were there.
They have been clear or not? They have been clear or not? No, maybe not. Maybe they are not clear. Okay, we'll see. Okay, okay. Okay, gonna be very hard case. Okay, you have a marker, please? Can you put this, can you move this out of the file?
Saurabh? Can you hear me?
Okay, let's not discuss.
Guys. Sachidanand, we can just discuss about the method we use for lung isolation and also some important things about positioning in such patients.
So since this is a left-sided mass, so we have put a right-sided DLT. And now patient is positioned in right lateral decompressed position. Okay. Right now, we just performed the bronchoscopy after positioning. We also see the lesion and also confirm our T position again.
Thank you. So there are very few indications for right double lumen tube because of the uptake of the right bronchus is much ahead and there's a chances of decreased ventilation to the right upper lobe. But this mass, as we can see, it is a left hilar mass. So the possibility of doing left DLT is not there. Dr. Sachin, do we have another choice? So suppose we don't want to put in a right DLT, can we use any other method?
Then we have to use the iron blocker. But again, with iron blockers, there is a problem that at the time of resection, the blocker may be clamped or may come in the staple line. So the first choice is right-sided DLT. And in case if it is not possible because of either any difficult airway or difficult anatomy, then we can put a blocker, and at the time of stapling or suturing, we can just pull back our blocker in the main lumen for the time being.
And this we are doing the bronchoscopy through the bronchial lumen of the DLT.
Yes, yes, yes.
We can see the right lobe being
This is the right upper lobe. You must be seeing on the screen, on the larger screen, that so this is the right upper lobe opening.
Yes, this is important because whenever we put in a right tube, so we have to actually see the right upper lobe being clearly being ventilated.
Yes.
Otherwise, we'll have a problems in the post-operative period.
Right.
Yes, it is clearly seen, so everybody can visualize this.
Yeah. This is right.
Middle and lower.
Middle and lower, and right. Yes, right side.
Right. We'll go to the left. Yeah, go to the left.
And Dr. Sachin, this patient was post-CABG, so how many months before he was operated?
1 year back, he was operated, and his cardiac functions are okay. We have optimized the medication. Also, the echo is normal. Ejection fraction is 60%. There is no regional wall motion abnormality. So, we anticipate that we will not face much of the problem. But yes, it's a high risk case, being a cardiac patient, post CABG, and also going for the double sleeve resection.
Okay, thanks.
So do we get a CPET for all the patients, or is it just he is a
So
cardiac
there is a
morbidity?
question, that do we do a CPET for all the patients posted for thoracic surgery?
No, not in all cases, only in a specific, there is a specific indication of CPET. Otherwise, based on the pulmonary function test, and if required, VQ scans, they are sufficient.
I mean, CPET might not be available at all the places. So probably at our center, we don't have CPET. So we would have got
a stress echo done to assess the cardiac function, and obviously we would have supplemented it with the scan.
So the advantage of CPET is it assesses the interaction of cardiac and respiratory both. So people have suggested if we don't have CPET, we can use simple test like a 6-minute. So that will be really good to assess overall function of the patient.
Is the left main. Okay, go inside slowly.
So this is in the left main lumen, left main bronchus. Our bronchoscopy is the left main bronchus.
This is lower. And this upper. Now, there's no tumor here inside, but we need from outside.
Now we are entering.
Okay, yes, go. Go. Hi, there's tumor there.
That.
Show up, yeah, there's tumor there.
On the 12 o'clock to 1 o'clock.
Okay, okay. So it's not too much. It's fine. We don't need to cut too much. Photo? Okay.
But Sachin, we are doing check bronchoscopy to see the mass in the left side.
Yes, yes, we are in the left main bronchus. And we have also checked our T position. And surgical team has also shown the location of mass. There is no interluminal component.
Okay.
We also put this epidural in this patient also, or we have other method of anesthesia in this patient?
We have put paracetamol in this case also, because we require a very good post-op analgesia in this patient. That's
Have you used invasive monitoring for blood arterial pressure and?
yes. We have taken a 18-gauge cannula, and along with this, we have a table line in position. That much from the line side. Because like, if cardiac functions are okay, that's why we are not using the continuous cardiac output monitoring in this patient.
So since it was a cardiac patient, so did we establish arterial line awake or after anesthesia?
We have like put the arterial line in awake in awake condition under local anesthesia.
We can also see that there's a epidural in place, in spite of being a small incision, that probably the drug requirement should be reduced, that's why too.
So it becomes challenging for thoracic surgeries, especially if it is in the same.
Yeah, in such high risk cases, do you keep noradrenaline or NTG ready?
Usually,
Yes.
so since you have specifically told about if the ejection fraction is okay and otherwise cardiopulmonary function is fine, so we do not preload it, but we keep it handy so that we can start in 5 minutes. However, if the ejection fraction was say about less than 30% and patient functional status was poor, we keep it set on the infusion pump so that we can start immediately if needed. Also, I'm sure they must have used etomidate for such patients because hypotension post induction agents is much lesser. So all precautions of such sorts are taken.
Yes, we have used etomidate in this case, rightly said by the experts, because it is more cardiac stable.
Another important tricky situation which arises, so this was post 1 year. So if it was 3-4 months post stenting, then we are not sure whether to stop clopidogrel or not, whether to start bridging therapy. So that becomes challenging, and a comprehensive decision has to be taken between the surgical team and anesthetist, whether it is safe to operate or can be delayed, say about 2 or 3 months. So that kind of challenge might occur if it is immediately post CABG.
And even in our setup, we keep internal paddles ready, defibrillator paddles ready within the OR setup when we are operating such post CABG or very high risk cases.
So internal paddles are there at our cardiac OTs, but at our setup we usually don't use internal paddles because that problem usually doesn't arise. But yes, in CABG OT, cardiac OTs we usually have, and they are handy if the situation occurs.
Like In OT setup, we have our system in place, so we don't place either automated pads. So we more rely on our manual pads. Once required, you can immediately access it and use it. Because
Dr. Assistant, can you show the monitor for a second, what vitals are going on in this patient?
sure.
So looks fine, and what opioid did we use, and did we use
We-
Optatus?
Yes, we have used 5 mics per kg of fentanyl for induction in this case, on higher doses. So as you can see, the vitals are more or less stable now.
Dr. Sucharan, are we using DVT prophylaxis in terms of mechanical prophylaxis, DVT pumps in this patient?
Dr. Sunil?
Yeah, for DVT prophylaxis, we are using manual compression devices.
Hello?
Yes, sir. Is the surgical team ready?
Yeah, they are just draping it, and
This setup is more or less like the previous case.
yes, exactly same. So it's a left-sided tumor, so the sides will be reversed. The surgeon will be standing on the right side of the patient, and monitor will be on the left side of the patients. So assistant again will be on the left side. Essentially, just the mirror image of what we had in last case. Okay. So, are you getting the feed of the external view of the patient field?
We are getting the external view, sir.
Okay, okay. So, we are just preparing, maybe 5 minutes from now, we'll be ready to put the NC.
Dr. Sunil, do we have a two camera setup on either side of the patient?
We have the monitor for the assistant, actually 3 monitors total.
Okay.
And one for the surgeon, one for the assistant, and one common monitor all mounted. That's there.
Okay. So if we could have a wide view showing the position of the monitors in relation to the patient, that will
do that.
helpful.
Yeah.
Yes, thank you.
So I'll ask the camera person to, yeah. No, you have to show the surgeon and monitor in the same frame. Surgeon and monitor in the same frame.
So I think this is the camera on the light. I believe that this is the bird's eye view. Yes, thank you. So we can see a monitor on the left side of the patient, which means on the back of the patient, and both the surgeons are right now standing in front of the patient, that is, they are facing the patient. The patient is left side up, lateral decubitus position.
Dr. Sunil? Dr. Sunil?
Yes, please.
I just wanted to know one thing, that you plan the patient NSCT followed by planned surgery. Is it always the protocol you follow or have you not planned?
No, in this patient, the tumor was quite adherent with the left main pulmonary artery.
Yes.
And chances of having a pneumonectomy was very high. And in all these patients, we have a policy to go for neoadjuvant chemotherapy. And in many times, we get away without pneumonectomy. Actually, it can be converted either into sleeve or maybe straightforward lobectomy also, depending on the response to the chemotherapy.
Can I just interrupt to make a small announcement? We'll be starting with the poster presentation in 5 to 10 minutes to be judged by Dr. Chandramohan and Dr. Madhavanandkar. So all the people who are there for poster presentation to assemble outside in 10 minutes.
You put the camera like this. Is the same as before? No, it's different. No, it's different tower. Okay, okay. Let's put it more higher. Let's put this more higher.
On top?
Yeah.
Prashant, Sarna, Shubham, Karthik, anybody, Dr. Raju, so would we have dealt this patient anyway? CABG, there's a tumor stuck to the hilar vessels. We would have gone the same, yeah, we are starting age-wise, you want to, Prashant, stature-wise, huh? Probably. I would have added immunotherapy in today's this thing. Okay, considering the response rates are very high, so I wouldn't have just stopped with neoadjuvant chemotherapy alone. And we know that the response rates are nearly 30 to 40% or even more than that when you add on immunotherapy. And CABG or previous coronary artery disease is not a contraindication as such for immunotherapy with such good, excellent performance status. That is one thing. And the only concern here is the pulmonary artery, which may end up in pneumonectomy along with the bronchus. So the pre-chemo, that is what is concerning, and pneumonectomy is somehow, and will not be a great option in such patients, but if you're able to do vascular sleeve and get a negative margin, that should be good.
What about CTRT?
So definitely, if it mandates a pneumonectomy, I wouldn't take up the patient for surgery. I would take the patient for CTRT.
I think your review, I mean, you said you're going to give immunotherapy. What's your experience? You have experience?
Yes, sir. So, we have just started off giving immunotherapy for a very few patients. The first, only one patient we've operated and 2 more planned in this month. We're just finishing. We've had the first patient was good, but supposedly the response on the lymph nodes get a bit more stickier. The response, that is what, but we didn't have a problem in the last case.
hopefully 9th, I'll be able to tell you, we planned one post immunotherapy on 9th of this month, so.
They rightly kept the case for Diago. I wouldn't have operated.
So CTRT definitely.
Dr. Zaidi, what's your take on this?
I would probably avoid CTRT and I would also avoid immunotherapy because that will make surgical dissection even more difficult because of the post immunotherapy fibrosis. Yeah, immunotherapy can be explored in adjuvant setting.
But upfront, what would have been?
I think I would prefer neoadjuvant chemotherapy.
CTRT.
Chemotherapy, neoadjuvant chemotherapy.
Chemo followed by surgery.
Yes.
Sir, in our hospital, for all cases, we are part of the Neodora and the trials for immunotherapy. And of course, it's all double blind. We don't know whether they've received, it's neoadjuvant immuno plus chemo versus neoadjuvant chemo for advanced stage lung cancer. And I think, but most of these cases, I think will be for open surgery, if you're even planning. And if you think you can't handle vessels, can't handle bronchus during surgery, whether it's open or whatever you do, I think the surgical decision would be to send the patient for chemoradiation. If you think you can't handle the post-op fibrosis, because in some patients.
Looking at these images, what is your call?
I think here surgery is a possibility. Because surgery is a possibility here. I would have loved to see the pre-chemotherapy bronchoscopy.
They showed the images actually. Yeah, it's going to be very tricky to my mind.
So it's actually the right case for a masterclass, and it comes with a disclaimer, don't try this at home, actually.
Now, how in the pre-chemo and in the pre-chemo, how far distal to the carina was the tumor?
No, we didn't see the pre-chemo bronchoscopy. We saw the pre-chemo images, and it was right on the hilum actually.
Pre-chemo bronch.
So I'll get the findings read from it.
So the bronch, I feel it's a left main pulmonary artery is what, and how much stump does he have, and that is more deciding, because you have a 3 centimeter from the carina. Bronchus is most of the times not a problem. The decision for pneumonectomy is predominantly on the vessel rather than the
Post chemotherapy, essentially the findings have more or less same, except that the bulk of the tumor intraluminally, now it is only a small nodule.
Before it gets, we need a plastic, remember, like a teeth.
See,
like this.
For example, see on the left side, everything is long.
So,
long pulmonary artery, you have a long bronchus.
Try to show the post chemo bronchoscopy picture.
The 0 1.
Sorry, pre-chemo. This is from 23rd September 2022. So you can see again the tumor is getting just sort of secondary carina, just reaching the secondary carina, and the primary carina is free, starting as per report 3 centimeter from the carina. So the extent has remained same, only the size of the nodule has come down.
Number 0. Is number 1.
Right, so if you are ready on the surgeon side, Diago is on the right of the patient.
Two ladies.
So incision will be in the 4th intercostal space or 5th?
The tower is better. Too far. Oh. It's not good. Let's see.
Diago, can you describe the incision?
No, chemo. Maybe, yes, but. Yeah, we did reach here in the 4th intercostal space. No.
Just adding on to the point of, CTRT especially. So in the era of durvalumab, okay, where the survival rates are exceptionally higher following radical CTRT. I mean, I would still, bang on if a patient high risk requires a pneumonectomy, I wouldn't take on in the era of durvalumab. Because it is not only the trial that actually shows evidence for improved survival, but also the all real world scenarios. Okay, even if this is also applicable even in the veterans group also, because there is a real world data which comes from the Michigan on the real world data on durvalumab in the veterans. That also shows the similar outcome. The trial is very stringent. It takes into consideration that you have to start durvalumab within a stipulated period of time. But real world, it is not possible. But in spite of that, the survival curves have remained.
It is 0. Number 1, 2 times. What is this?
Number 1,
Let me see. Number 1 is. Okay, we can be doing 2, maybe. It's not the best, but I use 0 normally. They don't have 0. You can try with this, maybe. It's okay, you can. Shall I help you? Okay, you can start. Nice.
Time off.
I think so. He has taken incision in the fourth intercostal space, and the whole incision lies within the mid axillary region.
Camera needs to be focused on the operating side.
It's too high here.
Camera, can you reposition?
Done.
Yeah. So there is a question, how can we know this is a fourth space? We can always calculate the ribs from below or palpate the scapula, angular scapula, which is at the sixth intercostal space, and two spaces from that.
Pick up, give me a DVD.
Take a patient light.
Can you collapse the line? It's too high. Go lower, it's too high. Is it better now? Yeah, a little bit low. And this a little bit high. Let me check. Stuck. Yes. No. Section? Section, please.
Action on, please.
We need section. It has intercostal space very narrow. Ah. Oh my God. It's too low. This space is good for now, but it's too low for can I start with this space and use this for anastomosis anytime if we need it. This one here I cannot. Okay. No, it's not working. It doesn't work.
So to the panel members in the thing, so when you are planning a vascular sleeve, how do you prepare prior? What is your, do you heparinize before, one night before? What is your protocol when you're planning a vascular resection in combination with the lobectomy?
So I think that will come when actually you're going to decide that you are gonna do a sleeve right now or not. So usually just before you're clamping, you tend to heparinize just before clamping. You do.
We normally do not heparinize. We just give post-operative prophylactic doses because it's a biological. We are not putting the processes. So high level of anticoagulation is not required. We just give low molecular weight plasma.
Okay, could the camera
continue for a week.
Camera. Okay. Stay like this. You have to go. Oh my God. Well, I cannot touch. Use my finger. Normally, use my finger to the touch, but because of this. Okay. Yeah, I need a hook. Hook. Manu, here. Give me another gauze, please. Change the gauze. Okay, let's stay like this, Manju, like this, okay, like this. Okay, this for you. Camera. And give me the pedal, please. Pedal. Yes, look at this. Take this out, please. Pedal for me, pedal and hook. Yes, Manju. Just keep it open, keep it open. Okay, go here. Go. Yes, go, put the camera up. Put the camera up. No, put this, look, this up. This up. So here. Clean this.
I think that's the challenge, that even to put in the sleeve that you need to create.
Very, very narrow the space, that's the problem. So yeah, take this. Up. Please, put this, okay, look. Look, put this, correct. Look. Hook. Hook. Come on. I got. Oh, no, go.
So what we are doing now is we are using the energy device. This is an angulated hook to open up the pleura actually, so that we can actually enter the pleural cavity.
Be careful. Put the camera. Put the camera, be careful. Come on. Go. Enter slowly. Slowly. Enter slowly. Enter. 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 Enter.
In these cases,
Come here,
hook
come here.
becomes a very good dissector.
Go back a little bit.
To
Go back a
cut
little
down
bit.
the adhesions.
Go back a little bit. No. Rotate, play, yeah, okay.
And also, especially if you have angled hook.
Go inside, go inside. Go inside. Go inside. Okay. Don't move, don't breath. Go inside and rotate. Rotate a little bit. Now.
So just for the audience sake, so if you're operating on a patient who has undergone CABG before, what all precautions you will take when you're doing surgery?
Yeah, so whenever you are operating on a post CABG patient, generally they open the left pleura to take the lima down, and also the crushed ice is also used sometimes. In those cases, if the patient has been done on pump, if it is an off pump patient, you need not worry, and there is no pericardium. The pericardium has been already opened up completely, so there will be dense adhesions at the 2 centimeter parasternal area, and where your lima to LAD the grafts would lie. So one has to be very careful taking out the adhesions from the apex of the lung on the medial aspect of the lung. Very much careful not to injure the your previous old grafts. But I think so this is an old case, almost 1 year down the lane of CABG. So all the adhesions would have been very nicely formed, and you can see sometimes a graft lying on there. So after visualizing, taking down with a hook cautery will give exact precision which you want, and always stay away from the grafts. So this is the area at the apex, the medial aspect of the apex, where your lima would be coming from there.
Let's go down first. Enter, enter. Enter. Let's go down. Oh. Stay here. Stay like this. Like this. Hook, no more. Hook. No, remove the cat, please. Cat no. Disactivate the cat.
So probably if you can appreciate that he's using the suction to actually keep the lung away while he's using the angulated hook to get to the adhesions. It's a very difficult thing to do actually, because the smoke also builds up and hampers the vision. Also, the camera needs to be cleaned very regularly, and it can be actually very demanding and frustrating at times.
And the space is very narrow.
Space is very narrow.
In this patient. So I have no space to work.
But we can see now the border of the lung actually, and we can see the chest wall. So,
and I don't have my suction. This is difficult for this.
one strand at a time, one strand at a time.
Yeah, show me rotate. No. Closer.
Yeah. See, most of the additions actually can be removed, but it is one of those which tend to bleed, which can be more troublesome.
No, closer, closer. Show me, show me. I don't see. My God, look at this. They are confused. Why is fused? Why this vessel is here? Why this?
Lot of new vascularization is there over the
What?
lung surface.
This case is crazy.
Dr. Diego, I think, see, when you're doing a very complex case, sometimes.
Okay, you need a hook. Say like this, hook.
See, it's such a complex case. What is the opinion for the moderators? Should we back out or should we proceed with the case?
I think that call has to be taken by Dr. Sunil and Dr.
No. We are all here. All of us are part of the decision making. So what is going to be the thing from moderators? We'll call you. Then we'll ask him, what do you feel we should say? Because see, his body language, the way he is remarking about the vessels on the lung, and he is not mentally comfortable. We need to help him out.
Is Dr. Sunil on the line? Dr. Sunil, sir? Is Dr. Sunil in the line?
Yes, please. Hello?
Yeah.
Yeah, Sunil here.
Sir, just from the audience, we just say that, okay, if it is too difficult and in a complex patient, I think, let Dr. Diego decide, but.
All options are open, sir.
Yeah.
So it's H call and only H call. That's it.
Yeah.
Give me those. Now the camera is a yellow. No, it's yellow. Give me a ghost, please, a ghost. Give me a ghost.
White balance, please.
So. No. Okay, here. And here, show me here, show me here. Hook. You have some sponge stick? Give me the hook. Oh, you have a cautery? No, but wrong. Clean the camera, clean the camera, clean the camera. Clean the camera. But you need protection. Okay, let's go. Go. Oh. Yes. This is the left. No. No. Just stay like this. The graph is here, I think. Maybe. Oh, yeah. Oh. Please put down the coagulation. No, 30. Go inside. Go inside. Terrible. Oh, yeah. This is enough. Obviously, they open the pleura. Obviously. My God. Go back. True. Yeah. Oh, yes. No. Now give me a spastic. Okay. You need a ligasure?
Ligasure, please.
This for you, Manju, this for you. Ligasure? To change. To show you how to go closer. My God. Spastic? Another spastic? No, okay. Go, here. Here. Here, show me. Show me. Here, here. Here, Manju. Show me. Here, here. Here, no, here. Okay, kind of go, yeah. Oh, yeah, oh, yeah. No. My God. Yeah, yeah, Manju. Okay, let me change this, please. And give me a spastic. No, sorry, a grasper. Okay, back. Change the camera and give me a spastic, one more spastic. Take this. There you go. Okay, here. Manju, no. Manju, no. Oh, yeah. Go. Oh, yeah. Show me, follow me. Very careful here. Manju. Okay, Ligasur. So like this. Ligasur. Take this. Take this. Your hands immediately, Manju. Go. Closer. Change this. Agos, please. Agos. The space is very narrow. Go back, go back. Let's see from behind what you can do. Just stay here for a while. And let's see. Let's remove the low additions because you need a hook. Give me the cutlery. It's not working. It's not working. It's not working. No, it's not working. It's not working. This is not working because of this maybe. It's not working. No, you see? What is that? You see, it's not working because of that. My God. Oh, it's not working. Okay. Show me in the middle. Oh. Oh. No, man, go slowly. Man, go slowly. No. No, no, good. Yes, vertical. I got it. Need a ligature. Sponge stick. Yes, sir. Oh. There are vessels everywhere. My God. What is this? Okay, give me a sponge stick. A sponge stick should be in a different way. Should be like a sponge stick, like a ball. Harmonic. Cautery is down. How's it? Look at this. Ciao, mi mangi, ciao, mi mangio. Take this for you. You. Yes. Ciao, mi mangio. Show me here. Out, out. Out, out, out. Oh my God, unbelievable. Give me one glass, put here. One glass. Take for you. Plastic. Open that, open that. Open that. We need to have it. Back. It's true. Camera is well, it's back. It's back now. No. Clean. Space is very narrow. Space is very narrow. Oh, mind you. I don't have a good instrument. Give me another rasper. It's not good. No. Clean the camera, mind you. I need more angulated just. Suction. Ligature. Ligature. Condition water. Come on, don't touch me. No. Come here, you come here. Stay like this. Okay, leadership, go inside. Move the camera. The camera is back. And the camera is here, rotating. Yes. Okay, I'm gonna cross my hands, okay? Okay, like this. Yeah. And you know, don't move too much. No. There's like a lot of vessels. I cannot.
A lot of new escalation.
So, Dr. Shubham, Prashant here. So, when you have additions like this, when do you take a call on, your personal experience? We're not talking about Dr. Diago's or, when do you take a call that it's time for me to convert, or, you feel after conversion, do you feel that releasing additions are better, or you would repent after converting that I should have continued with VATs?
So I would have converted probably half an hour ago when I was not able to enter.
In general, like, for the sake of residents, let's say that you have additions, when would you take that call? So because most of them would be actually starting, and additions or something that which are not, you're going to see every alternate case. Additions.
So personally, I feel that, we should get down all the additions, although there are some school of thought which says that the load that you are operating, if you let it hang, it will help you in not falling. But if you have all the additions down, at least you have the advantage of moving the lobe both ways and seeing the vessels across it. It's not wise to actually just see one side of the vessel and operate on it. You should be able to see both sides of the lobe, at least when you are starting. You have done too many cases and then you can take a call. But I feel that.
Please.
There are adhesions normally through a small incision or through the laparoscope. Removal of adhesions is much more easier because it is in the deep corner and all. You will only land up increasing the incision, or you will do blunt dissection causing a lot of oozing. So the thoracoscopic release of adhesion is much better than.
Agreed.
So that is what has to be.
So actually, for sake of presence, you might feel that you're taking too much of time releasing additions by, minimal invasive. But actually, when you open, you really repent because you don't even see what you're releasing. Okay, so that causes more of air leaks. Here, you're actually seeing in the right plane, and if you see, there is no parenchymal damage anywhere so far. Okay, everything has been extremely well dissected and it's in the right plane. You can see Dr. Diago doing it in the right plane. It's one of the most challenging cases that he is demonstrating, but if you see, I don't see a single parenchymal tear. So extensive additions is one of the most important predictive factor for your outcome in the postoperative period. The small air leaks, prolonged hospital stay, prolonged ICD, even if you use negative suction ICDs routinely, the amount of damage that you would have caused is huge. Okay, and the recovery time is going to be long. So if you're if you're not proceeding, that is a different scenario altogether. But if you're proceeding, then I think, don't think that opening is going to make your life easy. It's going to make it more difficult.
Also, we saw some of the bleeding, which we were able to control well, and we were able to visualize with the help of the thoracoscope. So that has also helped.
So in my first 2 years, I used to have a practical thing. So I used to tell the anesthetist or the technician to inform me after 1 hour. By 1 hour, if I was not starting the lobectomy, I would convert. So I think because to achieve this kind of a skill takes years and years and many patients to get to this level. Yeah, and patience. So in some hospitals, you are charged by the hour. And so
another strategy is that if you're not able to do with your uniportal skills or something, you can always make a lower mode port, go with the 2-port approach in your initial days. You can go into 3-port approach. Still you're not going, then you can open. That is another stepwise approach towards VATS lobectomy.
No. Yeah.
So one thing I've seen very helpful in doing such cases is to identify landmarks before you start the procedure. So like I mentioned always, the phrenic nerve anteriorly, vagus posteriorly, inferiorly the diaphragm, the aortic arch, on the right side the SVC, the esophagus. Now all these are landmarks that give you indication of how much more you need to do and where you should stop. So always, identify these landmarks and try to make the entire lung mobile before you start the procedure.
So in such a case where the mediastinal assessment has not been done with an invasive method prior because of the sternotomy, when we proceed for surgery and it's a hilar lesion, possibly looking at a pneumonectomy, would the order of the surgery involve the nodal dissection, centimeter fusion, then first, and then proceeding with the surgery?
What's going to touch this?
So ideally, that's a tricky question whether in N2, you're asking a question, in N2, would you be doing a pneumonectomy? From this stage, I wouldn't. So that would have been a very well call before, because EBUS is something that which would give us. So I wouldn't send it for frozen now and change my decision now.
This patient has received chemotherapy for N1 and N2 disease already. Patient has received chemotherapy for N1 and N2 disease already. So automatically, subsequently doing mediastinoscopy and clearing all the nodes is not. It needs to be cleared with the. So you have already done. No. If you have already done chemotherapy and it has responded well to on the PET scan, then you don't need to do. But if it was upfront, you had to do surgery for a tumor where there is a possibility of node. They do mediastinoscopic dissection completely, and then at a second stage, after 2-3 days, they will do the surgery.
Why? Ms. Karthik?
See, Shubham, I'll tell you one thing.
think they have to
Understand
share.
that here. So
Maybe.
before,
This is the.
before in the
Yeah,
study, the Albin study where they said you have to do, if you have to do a pneumonectomy for a patient with N2, they have very bad prognosis. What has happened is, people have started doing sleeves for the same cases they used to do pneumonectomy for. So the rates of pneumonectomy have also come down, and the second thing is, the post-operative critical care has also improved. So it doesn't mean that for an N2 and a well-selected patients, you will not do a pneumonectomy. So the complications after a pneumonectomy in today's standards have improved greatly. So for ideal candidate, pneumonectomy is not a bad option even after even with the N2 disease. So I think it's an individual selection plan. Patient is young, operable. You can do a sleeve or you can do N0. No, I think it's a personal decision, but like you rightly said, try all means to convince that this is a patient for surgery. So in your mind, you should get convinced that, okay, yes, this patient will benefit with surgery. So if you think that by doing a mediastinal assessment, you're going to answer that call, do it. So many times we say that patient is ideal candidate for pneumonectomy, but just because he's N2, we're not offering him and they're roaming around alive, good physically fit patients. So you can actually offer surgery for them patients if you're able to do it safely. It's not like you have to avoid a pneumonectomy for every patient with N2 disease.
Yeah. The patient was anticoagulated, I guess.
Yes.
So.
He was an aspirin and he was on a clopidogrel, but he stopped it.
How many days ago?
5 days. 7 days.
there were few proposals to change in classification, where they saw that these proposals were made before the AJCC 7 and 8. And they saw that the number of years involved was a better predictor of survival than the N1 and N2 location. And they assessed in terms of the number of the lymph nodes, the volume of the lymph nodes, the bulk, and the weight of the positive nodes. And they said all these parameters are independent predictors of survival. And it was the number of nodes which is more important. They saw that the multiple N1 nodes versus a single station N2 node, the prognosis was worse in multiple N1 nodes. While the location which is more important, the number is more important.
Back. Okay, let's leave it.
I think this is a very useful trick, and there's a lot of use. You can even shove a mop through a small 3 centimeter incision. So and just carry on with the section further. It's a very useful tip.
Clean it.
Now we are seeing something, Dave. Something.
We start to see a little. Section. Clean it now.
Oh my God.
My God. The more difficult is everything. Previous coronary bypass, chemo, central tumor, bronchial. So, okay. Yeah. Yeah. That was the aorta. Aorta, the pulmonary harmonic. Ligature. This is the leaf node on the outer pulmonary window. And the heart is behind. Show me, you knew it. Coming up. It's a big leaf node here, huh? Why this big leaf node? Come back. Come back, show me here. Yes, hey. Back. Good for you. Sure. Wow, this is, no, it's crazy.
It's a huge one.
I don't see.
This is bulky.
Back.
Bulky.
Come down the middle.
You want to try intrapericardal control when?
Where is the phrenic? Phrenic is here now. Where's the phrenic? Should be here.
So that is the phrenic. Yeah, that is the phrenic, yeah.
But the lead node is involved in the phrenic. Or? In the middle, my friend, in the middle. Go back. What is this? Yes. I'm sure the final nerve will come to solve. Here's the final nerve. Show me here. Look. So trying nerve, I think we have to sacrifice maybe. Eh? It's here, you see, involved in this. We have to cut it because I cannot go here, it's huge. Are you sure? Yes, I'm sure. I think I need to cut here because here.
Dr. Diago, would you like to do a frozen section for these bulky lymph nodes?
What?
Frozen biopsy of these lymph nodes before proceeding for this.
Yeah, but this is now this malignant for sure.
No, what will be the actual survival benefit in terms of surgery versus radiation and chemotherapy?
I can see if I can present maybe here. I think closer, closer, closer. No, 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 Wagner. So, should we cut, eh? It's better, eh? No, the problem is if I go here, I will lift. I can't do this, but I'm not sure. So in the middle. I need my my section. Ah, snake, snake. Maybe.
He has history of TB also.
Yes, sir. For sure, has to be.
He had TB, history of TB.
Yes,
Yeah.
of course. Have everything. Everything to make an nightmare. My God. Oh.
Huh? ATD.
What is it?
Thank you, America.
Oh, yeah. Oh, yeah. Behind this. Take this, behind it. Take this. Yeah. Take this. No trash, no trash. Look, this is out. This should be out. This out. Oh, oh. Have to keep the cables out from the field. See, if not, I cannot push. Go. Go. This doesn't look to be look malignant. This is malignant. Okay, malignant. Harmonic. I'm afraid the artery is too proximal. It is no, look at it. Yeah. Yes, sir. Yes, sir. Yes, sir. Use the PA. Okay, go.
If something goes wrong, it will fall on you.
Totally blocked by this. In the middle. In the middle, my friend. In the middle. No. Middle. Up. Who's this here? Stupid. Take a shot. No. In the middle. Clean this. Clean. Clean this. No, clean. Clean. Here we go.
Okay, Diego, do you think you will get proximal control? Do you think?
I will try now. Give me the leadership. Closer. Oh, otra vez. Okay, it's like. This is the main PA. It's hard, huh? Over. Yeah. No, not yet. So when you do this, it's good because if you have some project, you can always do like this. Okay, and clamp it. It's a good trick. Yes, sir. Okay, this for you. Okay. Thank you. So you work more on the posterior now. Like this. No. Still like this. Let's do more. Okay, yeah. Closer. The middle. The ground here is completely stuck. Closer. Okay, back. Show me here. Yes. No. Here. I want to go here. Closer.
Yes.
So it's not a bronchial now. It was, but not now. It's good. The more we remove now here, we have more work done. If we do more work from here, yes. Yes. Let me cut this now. Okay, good for you. Now, go again here. Let me cut this. Give me the ligature. Okay. Keep calm. Take a breath and relax.
Diego, how can someone relax when it's so difficult?
And with this section is very difficult for me because I'm used to my section. It's too thin. Have to be more careful with the traction. Give me a compress.
So Dr. Diego,
I want to remove this.
what is your plan now? You are planning control?
No, my plan is continue. Same. Dissecting. Let's go to do here some. Maybe here I go. So another change this. Give me a grasper. More gauze, please. More compress. Aquí en la cámara. Out. Let me go in. Let me go in. Wait. Oh. Out. Ready for you? Okay, going. Andrew. Okay, not bad. Okay. Yeah. If you give me a gauze, give me a compress. A small stick. Yes, I think, but I have to see where. Give me the hook.
Mr. Diego, what the power setting of the hook you are using right now?
What?
Power setting, at what power the hook, you are using the hook right now? Coagulation, at what power?
30.
30, okay.
Coagulation mode 30.
Okay, thank you, sir.
Sorry, now. I think we'll stop now. Give me another compress. Nice. Hook. Now. Stop. Okay, Megana. I think the person is anticoagulated, so it's a problem. It's all losing. I mean, it's not. Okay. It's impossible, you see. Everything we touch bleeds. Go. Go, 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 go. Go. Closer. Closer, my friend. Closer. You see everything I touch, nothing. Okay, give me the gauze. One gauze. Or Suricel, you have Suricel? Give me one Suricel. And do the Suricel and my gauze. This for you. Suricel, please. Give me. Yes, open. Open. Okay, give me now a gauze. Gauze. Okay, we just leave it there. Okay, okay. Okay. Snake. Go ahead, go. Go. Okay, that. Look. Now. Like this. This should be out of me. If not, I can't say. Okay, okay. This for you. Yes. Go. This for you. This for you. Okay, this for me. Give it to me. Back, back now, back. Let's see where is the Fisher. Fisher is here. Yes, the Fisher. Should not be stuck. Should be okay. It should be okay. Yes. Give me a snake. Show me. Closer. Fisher. Out. Fish for Emmanuel. Fisher. Important to beneficiary. Put the camera good. Okay. Put the camera vertical, please. Sure. I'll use for you. Give me a sponsor, please. Closer. Maybe stapler. Maybe stapler. Or maybe not. With the stapler, yeah.
Stapler. Purple 60.
Now zero. Show me. Stapler. Okay, for the touch, huh?
So this is a purple cartridge being used for creating the fissure while dividing the lung parenchyma, right?
Yes.
Rasper. Sure. Okay. Please, doesn't work. Section. Snake. Oh. Yeah. It's yellow. Section. Section. Give me one in the meantime. It's too big. Oh, it's stuck. No, this is a bullshit. No. Not good for rats. Okay. Here's for your money. Show me here, show me here. Closer, closer. It's blocked. The artery is blocked here. The artery is blocked by lymph nodes. I think this patient has more than the tumor. I mean, this patient has no only the tumor. I mean, they give radiation for all the reasons. Or the tumor, no? Because lymph nodes.
Dr. Diago, we also feel that the lymph nodes are pretty
I
significant.
mean, the
there.
tumor has lymph nodes.
Yes.
Before, not only because now I think you see the we can do pneumonectomy. I know. Yes, sir. Yes, sir. Is this for you? Hey. Yes, sir. The problem is the fissure, I feel it here, you see? It's blocked. Fissure is blocked here. You see, I feel here hard. You see? The problem is here. I'm afraid here. The artery here. Is the yes, because if the patient has not good function, not good function for. Yes.
Obviously, the other side will be also of similar quality.
Yes, that's the problem. Because here, you see here, if I can control the artery, but I think yes.
No, it's more of a infiltrative kind of thing, which is just cicatrized completely. The division.
It's here. I think here is hard.
Yes. No, it's better to back out then.
Don't damage too much.
I think it's CABG, he will not tolerate pneumonectomy.
So not only about tolerating, but the survival benefit with the node positive extensive nodal disease, that way is also, I feel.
Yeah, because this is not malignant.
Yes, so oncologically also, I think it would be safer not to commit to a surgery.
Yeah.
But I think you have tried your best, Dr. Deva. I think we have to give you.
Yes, because if the official were okay, I can control the area.
We need both lateral and distal control.
And this side we can do sleep, vascular sleep here.
Yeah.
The problem is that
distal
the
also,
tumor behind here,
it's infiltrated.
look, here is hard. We cannot even dissect the vein here.
So I think it's a wise decision to come out, sir.
I think yes.
We should not do
Yeah,
it.
because it's a very high risk patient for pneumonectomy.
Yeah.
Because tolerance is an issue and definitely.
But actually we learned a lot, like how to manage adhesions, how to identify.
Yeah, this is a good trick. A good trick that I always do when I have a difficult case. Dissect the artery from behind, dissect the anterior. If you have one, you can put a clamp or something.
So I think we've learned a lot from even from
You don't
this
need to
case.
dissect completely, but just for the initial control is good. And we detach all the lung.
Also, I feel that not only the removal of the adhesions, but also the creation of the fissure. I actually enjoyed the creation of a fissure because many times you come across a case where the fissures are not well defined, and most of the times we have to create fissures like you did.
What about
the quality of the lung is very bad.
Very bad. I think we should not,
And you see the patient has a lot of vascularization in the lower.
Yes. So Diego, we're doing the thymus now or?
No, tomorrow.
Okay.
Okay. Yeah, this was more than an exercise. The phrenic nerve is intact, no?
Yeah, phrenic is okay.
Okay.
Phrenic is here. You see the phrenic?
Yeah, yes.
Phrenic is there. We preserve it. But here, the problem is here. You see retraction here. I cannot even progress here. Yeah, it's hard.
Dr. Sunil, for the post chemo assessment, we had a CT scan, right?
PET and CT both.
PET and CT both.
As well.
Okay.
And look the lung, huh? Look at this.
Yes.
Wow, look at this. Thousands of vessels.
Since almost 40% of our cases are post neoadjuvant treatment, so we have a routine policy for going for restaging for all the cases.
Yes. No, I think, the intention to give cure in this patient with surgery is cannot be doubted. You have tried we have proven that this patient is, post EBUS, post chemo, good response.
We try because the tumor was very small, but
so I mean, there's no harm in, there's no harm in taking a decision on behalf of the patient. I think it's a wise decision.
See, given we have a concern about nodes, if you have a concern more about the quality of the lung, what we are expecting on the other side.
Yes.
Although all the objective parameters, if you name it, he has undergone CPET as well.
Yes.
And he is a candidate for pneumonectomy too. But we have a concern about the nodes as well as post CABG tolerance.
Yes.
So better not to take chance. At least that's what I think personally.
Yes, sir. Yes.
All agreed, sir. All points taken, and everybody here in the.
Because the problem is that we can start to try, we can do double sleep, but if you reach a point that
And
there's no return.
I was also hearing the debate about why didn't we go for CTRT also. He is post CABG already on the left side, and radiation oncologists, they were not very keen to go for this kind of variation, again, the connectivity is going to be aggravated only. Given the city picture, given the PET picture, and then the restaging, then we thought that we'll give a chance for that.
I think we tried our best.
And probably we will also agree that in the whole world, Diego is the only person who can give a chance.
No, if he says no, you have to listen.
Yeah. No, because I mean, the problem is, if the patient had another status, a good function, I will try because maybe when I start to open the fissure, I can expose the artery and you can do double slit, maybe, but it's not the typical case that we are sure because here is blocked. So if you start to do this, there's no return because we have to open the fissure. We have to control the artery. So there will be a risk for the patient. And if finally we reach a moment that we cannot do anastomosis because it's too deep involvement, there's no,
no sense.
I mean, we have to be sure the patient tolerates pneumonectomy. And this patient is a high risk for pneumonectomy. So that is the problem. We didn't expect to have this here. It was initially a lesion that seems to be on the bronchus, but close to the artery, but the lymph nodes were not expected, so it's a little bit challenging. When we it's a pity, but this kind of cases are, no, it's a pity that and here is blocked. No, I will show you, look, take the camera. You need a grasper, one grasper. I will show because the vein, anyone, any grasper. The other one. You see the vein is here. The vein is here. Look, I'll show you. Let me show you the vein. Come here. Let me show you the vein. I'm gonna show you the vein and we go. Look. The vein is here. This is the vein. And it's blocked here. Here I cannot dissect the vein. So I have to go even intrapericardial. You see? We will have, if we, in case, but oh yeah, no, another problem. Another problem, open the pericardium in this patient. Look, the vein is blocked here. Give me a sponsor here, put the sponsor. I'm gonna show you. Still like this. You see, look, the vein here is blocked. Here. It's blocked with the artery here. Okay? I cannot dissect here. It's impossible. This is totally blocked. So we have to go here down to cut from here. Here is in the heart. Here. Cut in the pericardium here. But it's not a good option in this patient. And go from here, open the pericardium and do the artery, the vein here behind.
Phrenic now, vagus, multiple problems in a patient. If the patient had one node, okay.
Because this is, I think, is the lymph node malignant that is blocking here the artery. For in this case, is mandatory in the middle. It's mandatory to do a double slit completely because there's no even, you see, you cannot even see the origin of the first branch.
Yeah, there's no plane at all.
Look, it's hard, look. And this is the vein, And I feel behind this, I touch something hard here, behind, here.
Where vein is involved.
So artery, vein, and bronchus are all involved. In one, yes. So no chance. It's too much difficult.
Thank you, Dr. Diego. Anyway, we still, all of us are still
Yes,
watching.
let's now check the correlation.
Okay.
Dr. Shivani is there? Yeah, Dr. Shivani or Ritu, since now we are having some time.
Yes,
So, we can have as the Olympus people are ready, so we can have the technology lecture which we have planned for 15-20 minutes, and then we can break for the tea.
Yes, sir, we are just loading the program.
Yes, so we'll do the closure, we'll reach the auditorium. In the meantime, please get started.
Yes, sir.
Is water? Back, show me here, and then through. Show me. Okay, can you some water? Let's do a little bit water. To the camera. Good. Yes, we need to put in. But let me correlate a little bit. Yes, let me wait now. Put some water. Okay, put here. I remember. Yeah. Yes, yes, yes. Yes, yes. Possible. No, this is impossible. Because all the depending on the language is involved and the fish. Many. 10 per year. Double sleep, I do 10 per year. Good. If you do a good anastomosis, it's good. Normally not. Very well. Hmm. When you have bleeding?
You have not taken the control of the main PA and something like bleeding has
You have to control the main
How do
PA.
you take the control or you convert the patient, so how do you control through the uniportal surgery? First,
Yes.
clamp. First the clamp. Because if the bleeding happens suddenly, the gush of bleeding, you're not able to.
Compress and work on the artery.
Work on the artery. One person stably compressing. Even the lung parenchyma is also, works very well to compress the one. Lung irrega, that will automatically compress the artery.
And this camera is good, huh?
No.
Yeah. Yes, always in the other part. Always in the other
Good
part.
evening, everyone. Tea is ready outside. Anyone who wants to take a break can get their tea, following which we have
Yes,
some lectures by
Because
the Olympus
the
team.
camera show, sometimes the assistant put the camera like this and don't realize.
So kindly
And then
reassemble into
interfere
one
with
after
me.
10 to 15
Interfere
minutes so
with
that
me.
we can have.
So you have to go like this and play with this. Be parallel to me. You understand? With this, you can go down. This.
It remains the same position. Yes. But the single position. Sometimes we use double move, but the problem with the addition is be able to, take out separate the addition all around.
Attention everyone, we have tea which is ready outside. So anyone who wants to take a break can get their tea and then reassemble in the hall. We have some lectures by the Olympus team, which will last for around half an hour. So kindly reassemble here after 10 to 15 minutes. Thank you.
You want to take a coffee or tea?
Yes, yes.
Coffee के लिए बोलते हैं, coffee के लिए. It started. So ready कर.
Have to be careful here. Careful here. Back. Going. Oh. Out. Yes, plastic.
यहाँ पे आनंद साहब मेन ऑफ सिटी जैसे आएगा ये मेन ऑफ सिटी इसीलिए बताना है.
Okay. Now it's plastic, put more like this.
So we'll just do the hemostasis part and plus retain come out. So we are stopping the transmission now.
Good evening, everyone. Can we all please reassemble in the hall for the some lectures by the Olympus team? Also, for your information, we will not be having the third case, the thymectomy case today. This was the last live surgery session that we had today. We will conclude after the lectures by the Olympus team. Sir, he's Once again, I'll request all the delegates to please reassemble in the hall. We have a few lectures by the Olympus team, after which we can disperse. I now hand over the dais to the Olympus team for their lectures.
So good evening, everyone. Greetings from Olympus. First of all, I would like to thank Dr. S.V.S. Dev and organizing committee to give us opportunity to present our platform here. So I will take you through the journey of a newly launched platform, that is Visera Elite 3, through a small presentation showing its key features. And I hope you all have been already enjoying the quality here in the same system which is being transmitted. So I'll take you through a small presentation of the product now. So we Olympus presents the Visera Elite 3, a new platform. This is an advanced surgical platform. So why this platform came in existence, that we have considered the key concerns of today's stakeholders which are there involved in the even decision making for any laparoscopic system, from surgeon to the management. So these were the key pain points which were highlighted during the discussion, that always inconsistency in terms of lab image quality, colors, focus, ergonomics, yes, was very important. Then the complex operations of equipment, there are a lot of cabling, lot of complex operations to use these processors, and most importantly, continuously evolving technologies. So the technology is now pace of evolution is very high now. Every new 1 year, 2 years, something new technology is coming. So how the end user can make match the pace of technology along with this development, and definitely ROI is one of the concern. So the answer to all of these concerns is our Olympus Visera Elite 3. Next, we'll show you a small video which will give a glimpse of this system, and then we'll discuss about the key features. So Visera Elite 3 platform. So with Visera Elite 3, you become a visionary. So we are presenting Visera Elite 3 platform. It's an advanced surgical visualization platform. The key features are, it's one multi-specialty platform. So we have a single platform for all today's needs, 4K, IR, 3D, everything. Its features includes enhanced patient safety, and also LED life, which is maintenance free for near future. So my next slides will go through the small key highlights of these features. So the first feature which we like to introduce is the continuous autofocus mode. So in this mode, as you can see, once you activate the continuous autofocus mode, you no need to focus anytime throughout the surgery. That is something very unique point in Visera Elite 3 platform. Also, this camera is autoclavable, plus it has a feature of EDOF, that is an extra depth of field, which helps you to visualize the farther anatomies also very clearly. So continuous autofocus is one of the feature in 2D, which is something unique and not available till now with any. Then we also, Visera Elite 3 platform is equipped with IR facility. So we have full color IR mode. As you can see on the screen, you have white light mode.
Also, apart from this, we have selectable IR gain. You can adjust or select the gain levels from low, medium, high, depending on your need. Apart from the IR mode, only the white light IR mode, we have two different modes, which is magenta plus IR and IR only mode. These modes are depending on different your specialties, you can use the different modes. So IR only mode gives you a contrast mode where you have only black and white contrast, where you will see only ICG, while the white light plus IR mode gives you white light plus ICG at the same time. Another feature is these all modes, you can have a PIP on a single screen or a two different screen, which gives you help you to stay live from both on both the images, the white light as well as the ICG. This is something very unique, yellow enhancement. So even in the white light, now we have an improvement called yellow enhancement mode. So you can see once this activated, the complete yellow structures are highlighted. So these structures helps you to identify the nerves vessels more clearly. This is a new mode, which is after the clinical evaluation, what we have come across. It has been very promising in terms of pancreatic surgeries, HPB surgeries, on the colorectal surgeries, wherever the fat differentiation plays a very important role. So this is a very new mode and still in evaluation, but yes, it has been promising till now. So it is called as yellow enhancement mode. As you can see, the anatomy, the vessels becomes more apparent when we on this mode. This helps you to also helps you to give a more clarity when dissecting the lymph nodes dissection. Then the same platform is also compatible with the 3D scopes, and with Olympus we have both the types of 3D scope, the rigid as well as the flexible tip. So this is the flexible tip scope. This is the endo eye flex. So just to give an idea about what's the 3D capability of 3D eye flex is, as you can see on the image, the first image is a 0 degree. When you see in a 3D, you can get an idea about the anatomical location of the endoscopic view. But with 30 degree, it can be a little bit improved. You are able to get the interposition of between the anatomy. But with the endo eye 3D flex, what is that? You can get a view that is bird eye view, and even can see the anatomy which is hidden. If talk about the wet surgeries, it is very useful in terms of dissection of lymph nodes, even towards the mediastinal lymph nodes. Also, when dissecting the plane of dissections, and also the suturing. So the 3D flex allows you to operate in all 360 directions, since it has a flexibility of 90 degree angulation across the direction. So this helps a lot, in the wet surgeries also. So when we talk about Visera Elite 3 platform, it has the maximum compatibility, the compatibility with 4K, 3D, HD camera heads, video scopes, means the Kaleido scopes or any other specialty, multi-specialty video scopes, plus the previous 2 generations Olympus HD camera heads. So it has a maximum compatibility in terms of adaptation. So now, since I have been calling it again and again a platform, Visera Elite 3 platform. So why we call it a platform? So here you can see till now it was like for every new technology, you have to buy a new processor or a new tower. So we have HD, 3D, 4K and ICJ till now. So with Vizra Elite 3, we have combined all these three in one. So you have all this solution, what is available today in one, but what about the future? So future, do you need to buy one more box for another technology? No. With the Vizra Elite 3, these all future technologies can be upgraded through software. And just to give you a glimpse, what type of technologies is being under development is in a new scope where have 4K, 3D, ICG, flexible tip all in one scope. Also, we are working on the IR extensions and the IR intensity maps, plus molecular imaging, which is again new concept which is coming up, and some format of AI. So when we talk about future readiness, so say for next decade, if you have Vizra Elite 3 platform, you can be a future-proof, future-ready platform. So any new technology in the market and you already have that in your place. So when we talk about the long-term investment, it's very useful with Vizra Elite 3 platform. So this is my last slide. So to conclude, Vizra Elite 3 is one-in-all platform for across the specialties. It's an advanced surgical platform where you can perform IR, 4K, 3D, all modalities, and it's a future-proof platform. Thank you very much. So, pardon, sir? Yeah, any queries regarding technology, please? So, sir, as just to address, because now always the hardware cost has always been more. The capital cost involved is very more. But with the software, definitely, if I talk about in the percentage, the 100% cost will come down to almost 30%.
These numbers we can't understand. You should tell us what is this amount. 20 lakhs, 30 lakhs, for something like that you should tell us.
See, I'll ask one question.
30%, 40% will go down.
Sir, see, suppose if we have already scopes, we have 4K scopes, 30° with us already, Olympus.
Yeah.
Is it compatible with this system?
Yes.
Scopes, not the camera head.
Yes, scopes are
Scopes.
Yes.
Whatever, can we use other competitor scopes?
No,
in
sir,
your-
this is particular. I think it is right for any competition. Also, you can't use other camera heads, but telescopes definitely you can scope.
They're not answering.
See, you have to tell, sir, we will, please give your name and details. We will contact you privately. This is the answer you have to give.
Query sheet filled for you and we'll let you know the prices.
See, he's giving the right answer.
Thank you for that.
Thank you very much, sir. Thank you for listening. Now, Mr. Nishant will take you through the Avis X1 platform.
Also, you mentioned that with this Vizra Elite, one scope is compatible. What is that scope? That scope with the Vizra Elite, one scope, flexible scope.
Yeah. So like
No, the endoscope. There's one endoscope which was seen in the.
Yeah, so it's like the future development. So there has to be one scope which is under development, which you can have the flexible tip in 3D, ICG, 4K, all in one single scope.
Do you have anything to do with this molecular thing? Wherein we'll be able to pick up onco cells or something like that?
Yeah, so it is basically development technology, sir. So it's type of a cell tagging thing. So you have a particular like ICG or dye. So they are staining dyes, and then with particular camera or the software, you can see that, visualize that.
That's also there in this.
So that's what the future, sir. We are talking about. So because it's under development, not yet approved in India, in fact. But next, possibly, sir, maybe 2.5 years, you have this technology. So whenever it is there, yeah,
Can be integrated.
yeah. So you already have the platform, so you don't need to invest on the whole system once again.
No, but will you charge for the software upgrade? That is my question.
Yeah. So definitely charge is there, but compared to the capital investment is really very sustainable. Thank you, sir.
Thank you, Anil. Very good evening all, and my name is Nishan. So I'll be presenting our endoscopy platform, which is for your bronchoscopy and for endoscopy platform. And this is very unique in nature, that I'll say that, because as a surgeon, you've been aware about 4K system already. But in endoscopy, this is the first platform in the world that is talking about a 4K platform in endoscopy. So let me just take you to a glimpse of it. So product consists of very unique in nature, that we call it as it's a unified solution. It's a single box solution, and it is light source and processor integrated. And this is a 5 LED spectrum platform. What I mean to say that 5 LED, because LED has a typical nature that by nature they are cold light source, and the color reproduction is not very optimum. So in order to counter that particular limitations, we have included in this platform as amber LED. So amber LED makes the light source warm enough so that the color reproduction on your endoscopy system makes it perfectly as it is what you say with the daylighting. The other advantage that we're saying it's a upscale image 4K from the processor. So processor has an output of 12G SDI output. That means it's capable of producing 4K imaging. And the monitor that we are also giving along with this particular platform is a 4K monitor. So that means through the processor and through the monitor, you are able to get a upscaled image of 4K here. In terms of main features, I'll just talk about, because there is a lot of need as a surgeon, that you'll always wonder that what if a patient comes to you at a early stage, so that patient, we are not just talking about the, you can say, just increasing the life expectancy of for a few months, but patients can be lived for, I think, without the cancer. So as a company, we also take a challenge for that, that how as a company that we can improvise on early detection. So what if we give a technology that can actually help you to see the precursors of cancer? So that really help you to see underlying cause, which can actually, before starting the cancer, you can predict all those precursors, and then can actually create a wonderful, I think, effect with your technology, and can do the wonderful procedures with that. So let me just introduce you a very important technology with X1 that has been introduced, is the TXI. So texture and color enhancement imaging, and mind you, I say that it's a new white light because NBI is a flagship tool that we've been promoting almost like a 2 decades time, and till today we know that I think even all the levels people have a limitation, because we understand that it has a learning curve, and people still try to figure out that what it is means when they are seeing into the NBI light. So this technology basically helps you to see exactly what you say with the white light imaging. That means the person need not to be learning a new color gamut system, and it is similar what they say with the white light imaging. Very fact that what is going to be addressing a point as first very important aspect, that visibility of all suspicious areas, the precursors, and potential replacing the white light imaging. That why we say that this particular mode should be switched on throughout the endoscopic procedure or bronchoscopy procedure. That enables you to see all flat and sessile lesions and the precursors of all carcinomas that may be possible that you can see without having any special lighting. So let me just quickly come back how this technology is we are trying to make it. And so any endoscopic image, the image gets split by 2 images, which has been a texture of the image and the brightness of the image. So as a company, we've been promoting the structure enhancement for quite some time, which was there in 190 platform, and how the texture is different. So structure enhancement, with that you will be able to see the you can be able to see the pit patterns and the vascular patterns. But with texture, you will be able to see the precursors like the inflammatory markers, or maybe the abnormal surface which just has started because of some abnormality on the mucosal surface. That may be very much visible with the texture enhancement. And the brightness, I'll say a very important tool, because if the area is dark, you are not able to see, in spite of having a very good optics. If the light is not optimum, you're not able to see that. So both aspects of endoscopic image has been enhanced, and further it has been stacked together, and they give you a very enhanced image, which can actually give you an option of further changing the color. What I mean to say the changing the color, because any flat or sessile lesion should be different from the surrounding area. So if you, if in your department, there are like a maybe students who are working. So we want the efficiency of the students to that level also, that a professor or a teacher who's been doing the same kind of outcome with that endoscopy. The same can be achieved with this technology that really helps the students to see what they, the trained eye from a professor who is able to see that. So you have an option of changing the colors, which makes the entire endoscopic image more enhanced, and the image that has been produced, it's basically the vascularity, the ups and crests of the image will be very much crisper in nature. The other part that I was talking about, the brightness, it's a very specialized brightness, because this technology enables you to see or enhance the brightness of only a darker areas. That means wherever you see a darker image, only the darker image can be, you can say the light is optimized, and there is no increase in halation in that part. So that really helps the endoscopist or bronchoscopist to see further, especially in fundus area or in bronchoscopy, when you want to see the bronchial tree, you can see much farther, so that it really adds value without going further. You can see from a very far place as well. I just quickly run through one of the videos which will gives you an idea that what I was talking. So on the right hand side, when you see is that the center of the image is pretty dark, and versus the image that you're seeing it here on the right hand side, it shows that at the end of the tunnel you can see the much brighter light here. So that ensures that you can see further, and there is a decrease into the miss rates, and then both in colon, that adenoma detection rate can be improved on with this actually also. So that means you have more time and farther you can see, so that the endoscopists can see more and that have more time to see during the scopy that they're doing it actually. Further, a very special technology that I'll be talking about, because as a surgeon, you've been coming across the bleeding part and been managing very well. But when it comes to the GI bleed specifically, nobody wants that patient should be bleeding. And it is really a very pain, always been a pain that, that any bleed that happens, that needs to be addressed very quickly. So addressing to that particular need, that we come across a very new technology that we known as red dichromatic imaging. This particular imaging technology is addressing the concern of bleed. That means whether it is a active bleed, whether the patient has by accident that a bleed has happened, or as a prophylactic technology also, that you want to see the underlying big vessel, that can also be identified with this technology. That means this one technology addressing can be used as a rescue technology as well as a prophylactic technology for all your therapeutic procedures. So how does this work? It is particularly, I'm just showing some of the videos. So as I talked about, there is an amber LED which has been included in this particular platform that really enables the user that any active bleed that can be visible from a very far distance. How that happens? Because amber has a good affinity towards hemoglobin, and wherever there is an active bleed, the amount of hemoglobin content is higher than its surrounding area, and that really helps to see the with this technology you will be able to see that pinpoint from where the blood is oozing out. So that means now you have an option of pinpointing the source of bleed, and then you can actively coag and do the coag. So that means you not only save the time, but also save the patient blood loss. At the same time, the total overall procedure time is being very shortened in the times. Along with that, very important aspect with this, we have launched a very specialized scopes that we call it as EZ scope, that basically has an easy zooming. So because very important aspect that in terms of improving the detection, you really wanted that scope image quality has been improved with the 4K platform, but how as a optics that because during a patient has gone under head and neck surgery and you want to be doing a vigilance endoscopy for those cases. So you don't want to miss out any small precursors also at early stage.
So this really helps you to do that. So how this is possible? This is basically an extended depth of field scope. That what I mean to say that extended depth of field, it's primarily whenever you are using this particular series of scope, the image is captured in two aspects all the time. That means whether you are in a near mode or in a normal mode, which is a dual focus mode in this, the image is captured both aspect, the near and the far image all the time. That means even if you're doing a magnification of 100 times, the image is captured both for near and far image. So that really helps. And not only that, the further, because by physics that we talk about, whenever we are focusing near, the far becomes blur, and whenever we are focusing near, so whenever focus far, near becomes blur. But whenever both the images are captured, it is basically superimposing both the images, and that really helps you to see all the image all the time. What I mean to say all the image means you are not compromising on your field of view, even if you are doing a magnification of 100 times. That means you will not increase on your miss rates, your miss rates become reduced, and all the time that if you're seeing means specifically in a narrow lumen like esophagus, where you have a like on the walls, scope is always very close to the mucosa surface. So that means even if you're going very close to the mucosa surface, which is 1.5 mm, you will be always in focus. So that means the endoscopic image, the blurriness is never been there, and you can do a magnification of 100 times. But at the same time, without the hassle of handling a zoom scope, because zoom scope have that you have a tele mode and a normal mode. You have been always toggling, and then you'll always say a patient having a peristalsis or maybe cardiac movement, and is becoming out of the focus all the time. So that is going to be a very game changer in terms of the imaging quality. Lastly, I think all you trusted the NBI becoming much brighter in nature here, and that's why we call it as, and it's a third generation NBI in this particular platform. And that really helps to see and do the magnification because now you can combine EDOF along with the NBI, and that really helps you to see the imaging quality to a very great extent. Some glitch, okay. So this really helps you to see, if you see the margins, which is exactly what you can achieve with the TXI technology, the NBI is also giving a much clearer and much brighter picture in here. And mind you, I'll say that if you're doing endoscopic resections or any kind of you can therapeutic work for the lesions or any margins, so TXI helps you to see the margins very well, so that the resection is very perfect and patient will not come back to the reoccurrence of the cancer. So these are the technology that we would like to wish that this particular platform is enabling a very unique nature. And also this is same technology is also there in the you can say in the bronchoscopy as well. I'll just run a small video here.
Furthermore, that I talked about the BIMAC, this is a very wonderful tool to use in bronchoscopy because bronchial tree will be, you can see from a very far distance as well. So if you have a thicker scope, even that with this technology, you will be seeing the bronchial tree from a far distance as well. And the TXI that I talked about, the vascular pattern specifically, the early precursors of even lung cancer can also be picked up with this particular technology as well. And I say that RDI will be more useful also in bronchoscopy as well because you had such narrow lumen and you have a lesser time. So RDI definitely adds a lot of value when it comes to be seizing the bleeding very quickly on this technology. A very unique feature of the very two scope which we launched in bronchoscopy as well, which is 1100 series, that allows you to give you a full image in the entire monitor. So that means you have the more visibility. That means that can be seen on that. So that is it from my side. If any question is there, I'm more than happy to answer that. Thank you.
Do you have navigation bronchoscope?
So as of now, the navigation is not there, which we are providing, but I think globally we have tie-up. Specifically, navigation has been provided by some other company, which is Bronchus, which is there. And Olympus globally been working very closely with the navigation technology. In future, definitely we can come with a navigation tool in bronchoscopy specifically.
EBUS.
Yes, sir.
Compatibility with X1.
So 190 EBUS scope is very much compatible because I forgot to mention that very important point. This platform helps you to give you compatibility with the existing all your 190 scopes. That whether it is in bronchoscopy, whether it is in gastro, everything is 190 is compatible with this platform. And that to be, I say that get upgraded when you're using with this platform because you are able to utilize the technology like TXI and RDI. So which was not there with the 190 platform. Now it has been upgraded when they use with the same scope on a different platform.
You can get simultaneous endo and the EBUS image.
Yeah, because that's a function that you do with PIP. Definitely that can be done with this same. And I'll say because this is an upscaled image, you will get a better image as well.
Compared with the ME1, so we have ME1 processor.
ME1 because that's an ultrasound processor. Of course, that can be done with that. So you need not to be buying an additional ultrasound processor. That if you have 190 ultrasound scope, EBUS scope, that is very much compatible with that. Okay, thank you so much.
Thank you. I think that brings us to the end of this long day. So we have some small housekeeping announcements. Quickly, we'll finish that. Then we'll break for maybe a 1.5 hours break and reassemble here by 8 o'clock. We have some light social entertainment here, followed by dinner. Then we can go back to our guest houses. So Dr. Sudhil would like to say regarding tomorrow's any change in the program?
Okay, so you saw what you saw, that's the thing. And that's the part of the thoracic surgery, you can't escape that. So having said that, I came to know that many of you are interested in subxiphoid thymectomy as well. Unfortunately, we do not have the transmission system available for tomorrow, but as a kind of matter of request, I requested Dr. Diago to come up with a lot of videos on subxiphoid thymectomy, his technique. And he agreed for that because we have given full 1 hour time for tomorrow to him to interact with the audience. That's a kind of an open house session where you can ask anything you want. He will tell his story because he has come through whatever goes behind the success. Many times we are not aware about that, and some of those glimpses we will try to share that. So tomorrow we have some beautiful papers by some of the very good institutions
who were selected from the abstracts. Yeah, and as per the decision of the judges, the 6 of them have been selected for oral presentation, podium presentation. That will be started in the morning. All of you, please be here. And we ask for very simple and focused instruction in the form of that it has to be thoracic surgical oncology abstract with institutional experience. So no left and right, no lateral deviation from that. And I'll just announce the names who were selected for that. The basic instruction has been given that the podium presentation will be 5 + 1 minute. That is total of 6 minutes. 6 to 8, maximum 8 slides, because you have to finish in time. If you are not finishing in time, again, you're losing your points basically. Total duration of 5 + 1 minute. The uploading instruction is simple. You just have to do it through the pen drive. And name, as you can see, Dr. Divya Jyoti Deka. This is in the alphabetical order. Dr. Haresh Mahana, Dr. Neha Selikeri, Dr. Pawan Kumar, Dr. Shivani Kapila, and Dr. Shiva Prakash. So all these people, please keep your presentation ready for tomorrow. And then
we have, I think, judges have grilled them really well when Diego was struggling with that case. So I would like to congratulate all these 6 people. Tomorrow we'll have the presentations followed by, they'll get some prizes for top 3. All of them will be assured of a prize. So we have some housekeeping announcements. Transport, Harish, you want to say something? What are the arrangements?
Good evening, everyone, respected faculties and delegates. So we have a late evening social activities here. So before that, if there are any faculties who are willing to go back to Delhi before the event or after the event, please contact us. I will let you know the phone number. There are vehicles, cabs allotted here to go to Delhi or to the airport. Either before or after the event, you could just please let us know. And the shuttle between our NCI campus and H3 is always available. You can either have a leisurely walk or you can take the cab as well. It is just a 5-minute walk. That is up to you. But if there's anyone who wants to go to Delhi or to the airport for faculties, please let us know and we will provide the arrangement as per your convenience. Yes, and in order to bring everyone back to the events here, the shuttle cabs from H3 will be coming back to NCI. It will be shuttling back and forth to bring everyone, whoever wants to come via cab from H3.
Please make sure to be here by 8 p.m.
Please note down the phone number if you want to contact for accommodation.
We'll put in the group. We'll put in the group, or yes, that will be better.
Okay, and thank you. Thank you very much for bearing with us for the whole day. We'll looking forward to have some relaxing night after 2 hours. Thank you. Yeah, here only.
Thank you.
Dinner is just 1 floor above.
Yeah, thank you for this excellent thing from the delegates and the faculty members.
Thank you,
Excellent.
Doctor.
Thank you. Thank you for the pains you guys have taken.
Thank you.
बातें तो ये करनी चाहिए नहीं है
सर वो स्टैंड सर वहाँ पे रखवा दो प्लीज, वो स्टैंड सर है ना वहाँ पे, माइक वाला स्टैंड सर वहाँ पे रखवा दो, मैं आ रहा हूँ वहाँ पे।
ये लो आपका माइक।
तो वहीं पे रखना पड़ेगा अभी अभी फिलहाल तो ये वाला माइक है ना, दोनों को बाहर रख दो।
यहाँ वही
वही एसी होगा, एसी नहीं अभी चालू होगा, अभी दोबारा 8 बजे।
ये बताओ
उधर उधर
इनका क्या मैटर है सर?
इनका मैटर है
यहाँ पे या वहाँ पे?
हाँ जी हाँ जी। वो स्टैंड सर वहाँ पे रखवा दो प्लीज, वो स्टैंड सर है ना, मैं आ रहा हूँ।
ये इसके बंदे पहुंचे हो गया यार, चल हम ले जाते हैं।
ठीक है सर, आप मिलते हैं। अच्छा 8 बजे ठीक। और फिर प्रोग्राम चालू होगा। हाँ और क्या तक चल रहा, वो तो चलेगा 11 बजे तक। भाई ऐसे ऐसे करेगा,
मजे ले रहा हो। बावली होली क्या चक्कर है? अरे दर्द का दिक्कत नहीं।
हाँ हाँ नहीं ऐसे नहीं, ऐसे
नीचे 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 जाएगा या यही रहेगा?
यही पे
ये लो, ये है ना वो
नीचे गिर जाएगा तो मेरा नुकसान हो जाएगा।
क्या अब होगा फंक्शन यहाँ?
हाँ दोबारा होगा।
फिर ये क्यों निकाल रहे हो?
ये कुछ नहीं निकाल रहा मैं
कल 2 बजे तक है ना?
मैं सेट कर रहा हूँ।
कल 2 बजे तक?
हाँ
कल 2 बजे तक।
जल्दी कर ले भाई, अभी रुक जा।
क्या कपड़े काम है यहाँ? स्टेज पे भी है क्या प्रोग्राम?
हाँ हाँ स्टेज पे होगा, हाँ स्टेज पे
बाहर भी है। बाहर भी है। फिर डिनर तो कब करेंगे?
डिनर कर लेगा,
डिनर चलता रहेगा।
डिनर का हमने टेकल रखा।
ऐसा भी है। और चल भाई पुलिस पकड़ लेगी ना? पुलिस पकड़ लेगी हैं? अरे अलग थोड़ा करते इन तजीन ये करेंगे पुलिस पकड़ लेगी। हाँ कितने एक्सलेट डाल दिए?
हाँ अब मतलब 6 है, 6 का डाल दे, 6 का डाल दी। इन लोग बात की हो डॉक्टर ने यार, ऐसे थोड़ी आलो कर देगा।
मेरा चार्जर रख दे, वो एक एक्स्ट्रा मेरे को तो उसमें से निकाल लेंगे। कल तक कल गएगा फिर ये अलग अलग आगे के मिक्सर नीचे लग रहा है।
हाँ हाँ
नीचे से ऊपर से आ जाएगी तार में मेरी। तुम रिकॉर्डिंग कर रहे हो नहीं कर रहे?
अरे रुक जाना, रिकॉर्डिंग मैं कर रहा हूँ ना, मैं कुछ दूसरा सेटअप कर रहा हूँ मैं, अभी इनके भी चाहिए ना।
वीडियो है, वीडियो है।
हाँ सारा सेटअप तो नहीं कर पाऊंगा।
11-12 बज जाएंगे 10-11 बजेंगे।
मारने के दिन दिख रहा हूँ, हमने की दिक्कत के दिन दिख रहा हमने की
तुम्हें कोई दिक्कत है? मुझे दिक्कत है, मुझे सॉल्व जाना है। बाकी ऑडियो यहाँ ले रहा तू?
क्या
बाकी ऑडियो इधर ले रहा है?
हाँ वहाँ की ऑडियो तो यहाँ पे ले आया,
मेरे को यहाँ से ले लेगा तू?
मिक्सर में तो आ रहा है।
तो मेरे को आउट दे दे।
क्या चीज की?
कैमरे की।
अभी एक मिनट जाना, मैं कर रहा हूँ।
दे देगा ना यहाँ से?
अभी दे देंगे। अभी क्या करने लगे आप? अभी तो सेटअप होगा। कल का ये प्रोग्राम अलग है, कल का प्रोग्राम अलग है। अलग कर देना। हाँ अभी जो 8 बजे चालू होगा दोबारा
और टॉनिक बेकार बनाया हो हैं? सही नहीं है और क्यों?
यार बकवास बना रखा है बिल्कुल। नहीं वो तो मेंटेनेंस करना, ये वाला सिस्टम तो ओके है, सिस्टम तो बहुत बढ़िया है, ठीक है। ये ना ऐसे इस टाइप में लगा रखा ना, वो ठीक नहीं है।
वही हमने ये इन कभी नक्शा पास होता हुआ
तो ऐसे उड़ी मारते हैं।
हाँ, ना मैं बेरा नहीं ना मैं बनाया जो गलत है।
नक्शे की नक्शे देंगे क्या?
गवर्नमेंट ने बनाने वाली गवर्नमेंट हरियाणा वाली बिल्डर बनाने वाले
ऐसे नहीं बुरा कुछ।
गलत है। हम तो लास्ट कैटेगरी में आ जाए सबसे नीचे
उसका ले लिया
इसका चार्जर लग गया अडॉप्टर।
इसका चला गया इसका भी चला गया इसका भी मैंने दे दिया आउटपुट तो भी चलेगा। अच्छा इसमें से फाइनल आउटपुट है ना
दूसरा जो साउंड आ रहा है वो सितार का रहा है। हमने बैलेंस किया था इसको एग्जैक्ट वैसा कर दीजिए प्लीज। ये बहुत विस्तार कर रहा है और बहुत से साउंड कर रहा है। सितार का बदल दीजिए। उसको एग्जैक्ट वैसा ही कर दीजिए जैसा हमने बैलेंस किया था। तो साउंड चेक में हमने बैलेंस किया था वैसा ही कर दीजिए प्लीज। अब इसमें इफेक्ट नहीं आ रहा है और लेवल भी कम आ रहा है सर। सितार का साउंड बहुत कम आ रहा है, थोड़ा सा बढ़ा दीजिए। आवाज नहीं आ रही है सितार की, बाहर नहीं आ रही है, मॉनिटर में भी बहुत कम आ रही है। ये प्लेन हो गया अभी, इफेक्ट्स खोलिए इसमें। सितार में इफेक्ट्स दीजिए, इको और रिवर्ब थोड़ा सा दीजिए। बस वॉल्यूम दे दीजिए थोड़ा सा और। इको थोड़ा सा कम कर लीजिए, बाकी बस इको थोड़ा सा कम कर दीजिए, बाकी ठीक है।
Bye. पता ही चला जूम में तो जूम
सितार का थोड़ा सा वॉल्यूम दे दीजिए प्लीज, सितार का वॉल्यूम। जब प्ले हो रहा है तो बिल्कुल हमें समझ नहीं आ रहा है कि क्या प्ले हो रहा है। थोड़ा सा अगर सितार का वॉल्यूम दे दीजिए प्लीज।
Sir, now you will definitely explain because we also have the vocalist here. So please be seated and हाँ, मैं हमारे जो वोकलिस्ट हैं उनको आमंत्रित करता हूं। हमारे अमान हुसैन जी, आप प्लीज स्टेज पर आइए।
Hal, check, hal. Hal, check, check. Hal, check. Hal, check. हल चेक चेक हल थोड़ा सा हाँ थैंक यू एक और थोड़ा सा दे दीजिए थोड़ा सा हल चेक थैंक यू हल चेक चेक हल 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 मेरी आवाज सब तक पहुंच रही है पीछे थैंक यू और गुड इवनिंग एवरीबॉडी और बहुत बहुत वेलकम करते हैं आप सभी का इस खूबसूरत हसीन शाम में और सबसे पहले तो मैं थैंक यू कहना चाहूंगा आप सबका और इस ऑर्गेनाइजेशन का और स्पेशली हमारे मिस्टर गुलाम वारिस साहब और मुजाहिद अली साहब का जिन्होंने मुझे यहाँ आने का इनविटेशन दिया और मैं आप सबके समक्ष बैठा हूँ सबसे पहले तो मैं जो मेरे साथी हैं उन सबका तारुफ आप सबसे कराना चाहता हूँ शुरू करने से पहले तो सितार पे तो आपने सुना ही है माशाल्लाह हमारे मोमिन भाई सितार पे एक बार मैं चाहूंगा जोरदार ताली हो जाए मेरे साथियों के लिए और तबले पे हैं हमारे गुलाम वारिस साहब और कीबोर्ड पे हैं हमारे मुजाहिद अली साहब और सारंगी पे हैं हमारे ताबिश भाई और नाचीज का नाम अमान खान बहुत बहुत शुक्रिया और आज की शाम की शुरुआत जगजीत साहब की गजल से कर रहा हूँ उम्मीद करता हूँ आप सबको पसंद आएगी और आप जो भी कुछ अगर सुनना चाहें गजल या कोई गीत तो मुझे जरूर बताएं पूरी कोशिश करूंगा आपकी फरमाइश और आपके दिल तक पहुंचने की थैंक यू हाँ क्या बात है